Good morning, Dr. Shaban. We are just waiting for 2, 3 more minutes. Let more people join in and then we'll start. Am I audible?
Good morning, sir. Yes, you're audible.
Yes, yeah. So
No
just
issues.
wait. Yeah, just wait for 2, 3 more minutes and let more people join and then it'll start. Yeah. Okay.
All right, no issues, no issues.
Mhm. Welcome all delegates on International Digital Dentistry Congress. This is Dr. Nurul, organizing chairman as well as the host and moderator of today's sessions. We would be starting from now and we'll go till 6 o'clock. And we have around eight speakers today who is going to talk on various aspects of uh, digital dentistry. Am I audible? Can you confirm? Anybody? Dr. Shaban, am I audible?
Yes, sir, clearly.
Yeah. Good to go. Yeah. So, uh, so this is our second edition of International Digital Dentistry Congress. We get very good response first edition, and there was very great day. Last 2 days, we started day before yesterday on Friday, 21st of August, 2026, and we have four speakers on that day, and then yesterday we have paper presentation with faculties. There are some, we get very good number of paper to be presented. We have shortlisted many faculties and they have presented their their presentation. Today we have also the PGs and rest of the faculty who will be presenting their papers. So to start with today, this International Digital Dentistry Congress, I would like, without any delay, actually, it's already 12:12. So we'll start with our first speaker, Dr. Shaban Khan. I'm just giving his brief introduction. And Dr. Shaban, if I missed, you could add on later on any point in your introduction. Dr. Shaban is MDS in periodontology and implantology, and he's assistant professor in Karnataka University. He has won a prize for his photography, Mahabat Maqbara, organized by ICOMS and UNESCO. Dr. Shaban profile was featured in IDA publication, and his photographic shots and well published by Nat Geo Traveler, Nikon, and Nat Geo Arab magazine. See, look at his profile actually. Being a dental surgeon, periodontologist, and implantologist, he has a great interest in photography and how his profile is. So he looks like more than a photographer, and and clinician as well. Additionally, his photography was also appreciated and published by BBC. Along with his photographs are published in various newspapers. He is executive committee member of various photography groups. He has been invited to judge various competitions of art and photography in national conferences as well as various social media pages. He's also invited as a guest speaker in various academies and dental colleges to take lectures on dental photography. Other than dental, he has a special interest in wildlife photography as well. So he is known face in dental photography. Anybody who want to deep dive in dental photography, this presentation would this talk of Dr. Shawan would very enriching and all. And he would be talking on dental photography simplified, three-word title of his for today's talk. So over to you, Dr. Shawan. If I have missed anything, you can add on because I haven't given your clinical background because you are having flying colors in photography and you are known face. So, what if you want to add anything on dentistry, you can add on and you can start your presentation.
So I practice in Ahmedabad. My clinic name is the City Dental Hospital. Me and my wife, we both are practicing. I'm a periodontist and she is an endodontist. And thank you, sir, for an amazing introduction. Now, without delaying much time, I would like to start the presentation. Can everyone see the screen? Is it visible?
Visible, your slides are visible, sir, dental photography.
Okay, great. So first of all, thank you, sir, for giving this opportunity. And this online platform is, I think, helpful for the many students, interns, PG students, and clinician to upgrade their skills and knowledge in the field of digital dentistry. So yes, starting with our today's topic, that is on dental photography. So I would like to ask participants, like, what are the common problems you all are facing when you start documenting your case? You can write that on chat box, I think. What are the basic common problems you all are facing? Okay, so let's start with the most common problems when a new beginner or a student start documenting their cases, right? So this are few common problems. Yeah, is it my screen is visible? My presentation is visible? Yes. So these are the top six problems what a clinician face when they are documenting their case, right? So the first one is the blurry pictures, wrong angulation, improper lighting, improper isolation, foggy pictures, and sometimes when they try to capture one tooth, that becomes cropped. So that we can say it is a half captured tooth, right? These are some myths like मेरे पास DSLR नहीं है, I don't have proper flash, everything is costly. So today in today's lecture we'll be covering all these things, right? Uh, why we should start documenting our cases? So these are the top three reasons why you should document your case. The first one is self improvement. This picture I clicked in 2010 with a simple 2 megapixel phone. I posted it on my Facebook. I think it is still there on my Facebook. I get many appreciation from my friends, colleagues. Bird is beautifully sitting on the fencing, lovely clouds, a Christmas tree, right? Now in 2026, I click pictures like this, beautiful, vibrant colors, close up shots. So, in the journey of this, you can say 16 years, uh, we can see that the picture clicked at 2010. It was having no colors at all. And now in 2026, you can see vibrant colors, more close up shots. So, photography helps you in improving your cases. Let's take an example of a dental case. A patient came with a deep periodontal pockets. We did phase one therapy, scaling and root planing. Later on, also there were pockets. So we decided to go for the flap surgery. We raised the full mucoperiostal flap. We did scaling. We did debridement. From our naked eye, it looks like everything is cleared. But when we click the picture, we will able to see that there is still calculus present over there, right? Then again, we did the root planing. Now it's all cleared. No calculus present. But we can see still that there are some granulation tissues over there. Then again we debrided it and now it's the cleared, nice alveolar, healthy alveolar bone is visible, nicely root plane surface, right? Let's take another example if we are placing an implants in the for an overdenture example. So usually we operate from around 7 to 10 o'clock position, right? So if we want to take up, if we want to judge parallelism of two implants, we can easily ask our assistant or someone to go at the 6 o'clock and click a picture. So a photo can improve your work. Second important thing is that uh, in today's era जो दिखता है वो बिकता है. You can say your success story. This patient came with a smile like this and it went with smile like this. So how we converted this patient, we showed him case similar to him or even worse than case than him. This was the case which we shown to the that patient. He we explained the patient that we are going to do minimum prep. we are going to give you on the same day we are going to give you temporary prosthesis. My screen is visible. I'm getting some issues.
Yeah, the screens are not visible. Now it's coming. Yes, it's visible again, Dr. Sharma.
Okay. So we'll explain the patient that we will do minimal prep. On the same day, we will give you temporary prosthesis so that you don't leave without the prosthesis. And this is how your final prosthesis will look. And first, we will check the fitting. Then we will do the etching bonding process. So we tell the patient, we show the patient the pictures, right? So patient would be mentally prepared. Okay, from now after this step is going to be there. So a blue gel they will apply. So we explain the patient, you might feel a little bit uncomfortable when we apply this gel. So patient will be mentally prepared for that. So that patient might cooperate better when we show each and every step to the patients, and this is how your final teeth might look. So it helps in converting the patient. When a new patient come for the consultation, instead of googling a case, you if you show your own cases to the patient, so patient might get motivated. Patient might go outside and बोलेगा डॉक्टर नया है मगर काम अच्छा कर रहा है, right? So third important point is the diagnosis and treatment plan. With the help of better pictures, you can analyze the smile. You can analyze the curvature of smile, shape of teeth, and immediately with the help of some softwares, you can show to the patient the before and after procedures, right? And there are n number of uses of a dental photography, or you can say documentation. So illustration, patient education, patient communication, doctor patient transparency, co-diagnosis, staff training, medical legal cases. Now let's step into the basics of dental photography. The more picture you see, the better you are as a photographer. So what is photography? It is an art, science, and practice of creating durable images by recording lights. Uh, Again, I'm repeating, it is an art, science, and practice of creating images by recording lights. In photography, light is a very important element. So I'll again ask everyone, I'll repeat this word. What we are doing, we are recording lights in photography. Now let's compare photography with the most common thing in our dentistry, that is the radiology. There are three things. There is one source, there is one subject, and there is one sensor, right? So in X-ray, a source is your X-rays, a subject is your tooth, and behind that we place our sensor. Similarly, in photography, there is a source in the form of light, there is a subject, and there is a camera that we can say as a sensor. So now what happens when we shoot an X-ray? Rays penetrate from our subject and it is recorded on the sensor. Okay, so here in X-rays, in radiology, rays are penetrating the subject and it has been recorded on the sensor. In photography, light is getting reflected from the subject and it has been recorded on the sensor. Correct? So what is photography? Photography is all about recording lights. Now, let's talk about DSLRs, and there are many types of cameras, right? So the most common ones is the full frame and APS-C, that means crop sensor. As you can see, the size of the sensor in full frame is quite bigger compared to APS-C camera. So both of these cameras are having some advantages and some disadvantages. Now you can compare the size of the sensor in all of these cameras to see, particularly focus on the full frame, that is 36 by 24. APS-C, that means your crop sensor, that is 23.6 by 15.6, and compare it with your mobile phone or you can say cell phone camera sensor size. It is just 5.76 by 4.29. So it has been told that the more the sensor size, the better picture camera can capture, right? Now let's have a discussion. A DSLR is basically having a body and a lens. Now let's compare a full frame body with a crop sensor. On your left hand side of the screen there is a full frame, and on your right hand side of the screen there is a crop sensor. So as you can see, the size of two cameras are quite differing. The full frame is bigger in size, the crop sensor is smaller in size. Along with that, the sensor size on the full frame is bigger compared to crop sensor. So a full frame body perfectly perform well in low light condition because the sensor size is big. And the crop sensor body, it performs a little less compared to a full frame because the sensor size is small. But along with that, there is also difference in the field of view of both the cameras. So let's compare field of view uh, in dentistry. As you can see, there are two rectangles. The outer rectangle, which is yellow, and the inner rectangle, which is in red in color. So the red one is taken from the same distance with the same lens. As you can see, the field of view is covering only half of the laterals to laterals. Whereas in a full frame, you can see both the canines are covered in our frame. That means a crop sensor body gives you cropped images compared to a full frame body, right? Now let's move towards the working of a DSLR. So as earlier I had mentioned that there is a body and there is a lens. Now what happens? A light is traveling from the lens. As you can see there, a 45-degree, there is a mirror over there. It is called as mirror. Behind this mirror, there is a shutter, and behind this shutter, there is a sensor. Now what happens? A light is coming. It is getting reflected at this mirror. Now after reflecting, a yellow outline is there. That is called as pentaprism. Multiply this light is getting reflected and you are able to see in a viewfinder the piece your you can say eye from where you are looking is called as viewfinder. So optically light is getting reflected many times and you are able to see in the viewfinder. Now as soon as you press the shutter button, this 45-degree mirror, it goes up. So light is coming, it is traveling from the lens, and now it is directly hitting the shutter, and from the shutter images are getting recorded on the sensor. Similar example, light is coming, it is getting reflected from the subject and it is getting recorded on the sensor. Now as the technology is getting advanced, DSLRs are being replaced with the mirrorless cameras. You can see in mirrorless cameras there is no mirror at 45-degree. So light is coming, it is directly hitting the sensor through the shutter as there is no mirror present over here. So in the viewfinder, we are able to see everything digitally. In DSLR, we were able to see everything optically by reflecting many times. But in mirrorless cameras, there is a small screen over there in our viewfinder. So we are able to see it digitally. Now, what is focal length of a lens? So it is the difference, it is the distance from the sensor to the center point of your lens. That is called as focal length, which is denoted in mm. So the more the focal length, the more zoom you are getting in your picture. As you can see on your left side, a picture taken at 18 mm. You can see there are clouds, there is sea, there is a foreground. Now on your right hand side, you can see a picture clicked at 300 mm. No sea is there, no foreground is there. So a picture is zoomed in. So the more the focal length, the more zoom you are getting. The lesser the focal length, the less zoom you are getting. Now along with the more zoom, the size of your lens is also getting increased. Look at this picture of 560 mm lens, it's quite bigger, right? Compared to a 31 mm focal length lens. Now lenses in DSLRs, they are basically a zoom lens and a prime lens. In zoom lens, you can adjust the focal length, you can zoom in, you can zoom out. In prime lens, the focal length is fixed. So we will be more focusing on the prime lens. As I told, the focal length is fixed in a prime lens. The lens which we are using in dental photography is a fixed or prime lens, that is the macro lens. So what is this macro lens? Macro lens allows us to go closer to our subject. So before studying that, we should study the minimum focusing distance. Sorry. So every lens is having a minimum focusing distance. If you go closer to that minimum focusing distance, you will not be able to focus the subject, right? That's why macro lenses are having quite less minimum focusing distance, so that it allows us to go closer to our subject and click the pictures of that subject. These are a few examples, few pictures clicked with macro lens. Now, starting with the basics, what is exposure? Exposure is the amount of light reaching your sensor. It means how much light you are allowing to expose your sensor. So it has been controlled with the help of three things. The first is lens aperture, second is shutter speed, and third is ISO. These three things are inbuilt in the these are in the camera. But when you are using any external flash, also you can control the intensity of the light or intensity of the flash. So let's study it one by one. Before that, there are three types of exposures: overexposed image, underexposed image, and balance exposed image. First one is overexposed image. In an overexposed image, you can't differentiate the white things. In this picture, there are clouds in the background, but you are not able to see. You are not able to see the clouds because it is overexposed. Now, in another example, we will see an underexposed image. In this image, you can clearly see the clouds, but the minute details of the monuments is not visible. So in underexposed image, black things can't be differentiated. In an overexposed image, white thing is not differentiated. So we want our picture to be balance exposed, so that the white things and black things both can be differentiated. Now let's compare all the three pictures. On your left hand side, you can see it is an overexposed. On your right hand side, it is underexposed. And in the center, it is balance exposed. So we want a picture to be balance exposed. We will change the exposures with the help of lens aperture, shutter speed, and ISO. Now first, let's start with what is aperture. Aperture is simply a hole in a lens, right? So the more the hole, right, the more the opening of the lens, the more light will pass on to our sensor. The lesser, the narrow the opening of the lens, the less light will uh, pass on to our sensor. Now it is denoted in f-stop. See this example: a picture taken at f1.4 and a picture taken at f16. As you can see, at f1.4, the opening of lens is quite wide. So more light is reaching on our sensor. So we will be getting more overexposed image. And at f16, less opening of our lens is there, so low light will be reaching on our sensor, right? So more the number, the darker will be the picture. The less the number, the brighter will be our picture. Now, along with controlling the darkness and brightness of a picture, aperture also controls the depth of field. Compare the two pictures. A picture taken at f1.8, where you can see there is a sharp central, lateral, and canine. But from premolar, everything is blurred. So a picture taken at f16, central, lateral, canine, premolar, molar, even the texture of the background is visible clearly. So the more the number, the darker will be the picture and more depth of field we be getting in our image. So which kind of picture we want? We want picture with more depth of field, right? We don't want a picture in which only centrals or canines are visible. We want from the central to our second molar or third molar should be sharp and should be focused. Now, second thing is the shutter speed. Shutter speed is the duration of time when the digital sensor inside the camera is exposed to the light. Now, this is now take an example, a picture taken at 1 by 500 and a picture taken at 1 by 2. A picture taken at 1 by 500 is freezed, right? And a picture taken at 1 by 2, it is hazy. So a picture taken at higher shutter speed. Let's first understand how a shutter speed works. So imagine there are two curtains. A picture taken at 1 by 8,000. A first curtain will go up and second curtain will follow that. Okay. So in picture 1 by 8,000, there is only a small slit opening is there. Whereas a picture clicked at 1 by 1,000, you can see the more gap between the two curtain is there. So less light will be reaching the sensor at 1 by 8,000. So picture will be darker at faster shutter speed and picture will be lighter at slower shutter speed. Okay. A picture taken at 1 second and a picture taken at 1 by 2500. As you can see at 1 by 2500 shutter speed, the picture is freeze, right? Now, third one is ISO. ISO is the sensitivity of your camera sensor. So the lower the number, the darker will be the picture, and the greater the number, brighter will be the picture. Let's compare a picture taken at ISO 200 and a picture taken at ISO 3200. So a picture taken at ISO 200 is quite dark compared to picture taken at ISO 3200. Right? So the more the number, the brighter will be the picture. The less the number, darker will be the picture. Now we balanced our exposure with the help of all these three. The first is aperture, shutter speed, and ISO. Now another thing, important thing which I want to discuss in this today's digital AI world, whenever you are clicking a picture, you should always click it in RAW and JPEG both, right? So this raw data on your left hand side, you can see uh, it is not at all any edited there, right? On your right hand side, you can see there is an edited picture. So the raw data, its extension would be .rar or .nif. So whenever you edit the raw data and you export it, or it always converts into JPEG. So this is the raw data or your identity that this picture was clicked by you only. That's why whenever you are submitting any article, some journals ask for the raw pictures, right? So that is the proof that you had clicked this picture. After setting all this, make sure you have battery, it's fully charged, right? Now let's understand the macro lens. I think we already discussed it in previous slides. What is minimum focusing distance? Now these are some AACD guidelines. What should be the settings? What should be the aperture, shutter speed, and what should be the your magnification ratio for the particular shots. Now let's talk about importance of a lens diameter. So this is the, you can say, a minimum focusing distance written on front of your lens. So in this lens, it is 0.28 meters or 0.92 feet. So from the distance of 0.92 feet to infinite, you can focus. And next to it, there is a diameter of your lens. So here it is a 52 diameter of the lens. So whenever you are going to buy a flash, make sure your lens diameter matches with the flash adapter so that it get properly fit, or else you need to go for the step up or step down converter. Now there are different types of flashes in dental photography. The first is the ring flash and second is the twin flash. Ring flash means one point, twin flash means dual point lights. So I personally suggest, if you are having more of the posterior work, you should go with the ring flash, right? So this is how it looks. And this is the twin flash. In twin flash, we get liberty to change the direction of the light right, in both the planes. Now, flash power, you can see at power 1 by 1, you will be having the maximum intensity of the light from the flash. As you decreases to 1 by 2, 1 by 4, 1 by 8, the intensity of light gets decreased. Along with that, you can use soft boxes. So soft boxes, they diffuses the light and give you good results. You can mount softbox with the speed light or else with the help of this S bracket. So there is an S bracket in between the stand, the light, and softbox is mounted on this S bracket. You can also use studio lights. Now coming to the another important thing, that is the retractors. You should not use any colorful retractors. You should always go with the clear transparent retractors, and these are my favorite one. These are with the wings. So this wings helps you to retract the lip and cheek, right? Now next is how you can get the black background. So with the help of contraster, you can get a black background. Next important thing is the mirror. You should always use, you should not use glass mirrors, fiber mirrors. You should use stainless steels or rhodium coated mirrors. What happens if you use a glass mirror? You get the ghost image. As you can see, a light is coming. Two times it is getting reflected. You can see here. So two images, double images you can see whenever you are using a glass mirror. So never use glass mirrors. Now regarding the chair positioning, uh, for all of the pictures I make the patient, for pre-operative and post-operative, I make the picture patient sit on the stool, and for the full arch images I keep my chair position as low as possible and as supine as possible. Now these are a few very basic things, principles, like we should be having proper retraction so our light can reach to our area, concerned area. Our concerned area should be isolated. It should be saliva free and blood free, and proper light should be used for getting proper images. So retraction, isolation, and illumination, we should never compromise with any of these three things. And sometimes if you are not getting enough exposure, you can
This meeting is being recorded.
basic uh, editing with the help of Photoshop, Lightroom, or Snapseed. So yes, this is my contact details. As like half an hour, it is very difficult to learn every in detail of the dental photography. But you, if you have any doubts or any questions, you can reach out to me on my Instagram, or you can directly contact me on my given number. Thank you. If you have any doubts, please leave it on chat box so that I can read and can answer.
Anyone want to ask any question regarding photography? Because you guys are, keeping your records intact in your, records. So you want to take a photograph. So any tips anyone want to, take any insight for photography in dentistry? We have expert Dr. Shawan with us. You can ask questions. There's a one question asked by Dr. Anisha Malik. What is the difference between, just hold on. Yeah, what is the difference between a DX lens and a macro lens?
So as I had mentioned in my slide, that a macro lens is having less minimum focusing distance that allows us to go closer to our subject, and we can click compared to any other lenses, whether it is zoom lens or whether it is a telephoto lens or any lens. So the thing, a macro lens, it allows us to go closer to our subject, and it lets us to click. If you try to click with any other lens, example a telephoto lens, right? So that will not allow you to go as close as possible as a macro lens allows you to go to closer to your subject.
Thanks. Anybody want to ask any question? They can either unmute your microphone or you can post it in the chat box. So Dr. Shaban, there is no more questions now. There is the one question, yes. If I have to use mobile for intraoral pics, what to use micro lens option of vivid?
So the basic principles of dental photography is proper retraction. Uh, no need to get any lenses attached on your mobile phone. I personally use good lights. So both twin light and ring light, both are available for your phone also. If I'll just show you which light I am using. Can my screen is visible, sir?
No, not yet.
Okay.
Just
Okay, just a minute.
yeah.
Yes, so this are some lights. You can see a ring light which can be attached on your behind your phone, and also twin light which is available for phone photography. I'll show you how you can use that. Yes, so the for a beginner, ring light hardly it comes around 200 rupees. You can find it on Amazon. And for twin light, this is how you can attach your phone, and you can get good illumination. And that helps you a lot. As I had mentioned, that proper retraction, isolation, and good illumination is there. You can click excellent images. So these are some of my slides from my phone dental photography presentation. We can have sometime later on discussion on phone photography also.
Okay, Dr. Shaban, if you have time, you can stay with us. With your permission, should we move to our next speaker, Dr. Shaban? You stay with us if any
Yes,
questions
sure.
comes. There is the one. Thank you, sir, asking Dr. Girish Akhtar. Yeah. So, Dr. Shaban, we are moving to our next speaker.
Sure, sir.
Yeah, yeah. Okay.
Thank you, sir.
Great, talk with you, Dr. Shaban, and we are privileged that we have understanding about the photography in the industry. So, if you have time, you can stay with us, and maybe the question comes, you can answer the question. So, with your permission, I am moving to our next speaker, Dr. Rohit Agarwal. Dr. Rohit Agarwal is the meeting room. Dr. Rohit, can you yes, yeah.
Yeah, hi, good morning.
Yes, yes, yeah, you are audible. I'm just giving a brief introduction of Dr. Rohit. And Dr. Rohit, if you am missing anything, you can add on in your introduction so that our attendees have a fair idea about yours. You are the known face in implantology. So I'm just giving you a brief introduction. Dr. Rohit Agarwal is a distinguished implantologist and laser surgeon with over 17 years of experience. He serves as a professor at Maharana Pratap College of Dentistry, and he is the head of the Department of Dental Implants and Laser Surgery at Agarwal Hospital Research Institute, Gwalior. He is a postgraduate and he has received advanced training in implantology from institute in Japan, USA, and Germany, including a fellowship in advanced implantology from Goethe University, Frankfurt. He is the first dentist in his region to conduct full-day implantology and laser workshops with a live surgery. His expertise encompassed bone grafting, sinus lift, GBR, RPF, therapies, physiosurgery, and facial injectables. He has presented at 53 national and 12 international conferences with 7 international publications, and he served as a reviewer of British Medical Journal of Case Reports. Over to you, Dr. Rohit. If I have missed anything, you can add on and you can start your
No, no, thank you so much. Thank you so much. I'll just share.
Yes, your slides are visible. Slideshow mode, could you please? Yeah, perfect, perfect.
Okay. Yeah. Thank you so much for giving me this opportunity to speak on this topic of digitalization in implant dentistry. And I'm going to keep it very simple and straightforward lecture with lot of photographs and very little less theory. Okay. Currently, we are in the phase of transferring from the analog to the digital world. So we are now using digital technology, scanners, and all those things for our day-to-day practice. And we are also using it for crown and bridge dentistry, for full mouth rehabilitation, veneers, and whatnot. So it is a great boom in the field of dental implantology if you want to transfer from analog to your digital world. But obviously, you have to keep it in mind that we should know the pros and cons of both of these technologies, because every technology comes with some of its advantages and disadvantages. But keeping that aside, it is a great technology that we should all incorporate in our day to day practice. It is a great tool to use so that you can get more amount of patients and you can deliver the treatment in a faster way. Today, we are in a fast stage world, so where the patient wants everything to be done quickly. So, if you use digital technology, so you are able to deliver the prosthesis or the required work in a faster way. So that way, digital technology is a very good tool, because supposedly you are staying in a small city, like for example, I stay in Gwalior, Madhya Pradesh. So we do not have very good labs here. So if I want to send a work to a lab in Bombay or in Gujarat or anywhere else, so if I'm doing in an analog way, so I have to take the impression, then you have to do the make a parcel and then you send it to the lab. The transfer will take a lot of time, and in sometimes in transfer the impression is also destroyed. So supposedly if you want to give a single cap, sometimes it used in the past it used to take even 10 to 12 days. And if it is a repetition, it might take up to 1 month. So, and if your a neighboring dentist is giving a cap in within 3 days, so that creates a competition, because patient wants everything nowadays immediately. And if you are able to give it, so it increases your practice, because now we are in such a competitive stage that we have to see that what we can deliver better than your adjacent dentist or in your area. You have to create your own niche, because everybody is good at something, so you have to find out that thing. So that way digital technology helps you to increase your practice also. Apart from making your life and work much easier, it makes your work also faster. So especially if you are in small cities, so I think for those dentists living in small cities, digital technology gives an extra edge, because you can do your work in a faster way and you can connect with multiple labs. Supposedly, you have taken a digital impression, no matter for implants or anything else. Now you can show it to the patient. So it is a very good practice management tool. You can show it live to the patient, everything, what you're designing, what you're planning. So patient is not imagining anything. It is live to live interaction. So that way, patients counseling is much easier. Like if you're doing a smile designing case, you can even show pre-op, post on, and all those Apps are also there nowadays available in the software. So it is a very good tool for practice management. Secondly, you can send the same work at the same time to multiple labs. But if you are doing an analog way, you can only send it to one lab. And then when the lab receives that work, then only the technician will be able to discuss the case with you. But in a digital technology, you can do a live discussion with the technician. Supposedly, taking impression like I have shown the slide here. I'm taking impression for a single posterior implant in the 4-6 region with the scan body. Now, if the patient is sitting on the chair, I'll send the scan file to the lab. I can make the patient sit in the waiting area. He can have a cup of coffee or something like that for around 15-20 minutes. By that time, I will have a discussion with my technician. If I want to correct something, or if I need to rescan it, there are some errors, whatever it is, what type of process I want to give, we can have a discussion with the technician, and we can and we can tell the patient to come inside and we can make those changes. So you have to take the impression only once. That's what I'm trying to say. When the patient goes out of the your clinic or hospital, then whenever he will come back for the final processes or for the next step at least. But the impression won't be repeated. That's what I'm to tell here. Otherwise, it makes a lot of headache. You take an impression, patient is also gagging and all those things. It looks very bad. So, and after that, when you send it to the lab, and labs calls you after 3-4 days, depending upon on which lab you are sending it. If you're sending to a local lab, then also the patient will go out of the clinic. At least he will call you tomorrow and tell you, sir, this impression has bubbles or there is a less interarch space if you are doing a crown cutting. So modify your cutting and all those things. You have to recall the patient. If you have given the anesthesia on the first sitting, then you have to re-anesthetize the patient. So all those things increases time, and patient also sometimes becomes a little bit agitated that how many times you want to repeat it. So I believe digital technology is a great boom and everybody should use it and should learn it and innovate yourself. So, like straight away come to the topic. So, like I am showing you, this is a slide. We are taking impression for the. Sorry. Yeah. So now you can see in this video, I'm taking an impression for the implant placed in 4-6 stage in the 4-6 region. So now we are taking the impression with the help of scan body. These are all called scan body. These are a peak scan body. Every implant company has different design of the scan body. Some have those metal kind of scan body. Some have these peak kind of scan body. So you're taking an scan. I've done the scanning. So now you can see now we are analyzing the scanned impression that everything is fine. All the whole surface of the scan body should be recorded properly. So now if you can look closely here, you can see this flat surface. This flat surface of the scan body. Most of the scan bodies given by any company, I'll show you multiple cases. They have one flat surface. Okay. So this flat surface should be placed buccally. That we have to keep it in mind so that it is recorded properly, because this flat surface will help your technician to pick up the particular lab analog from the digital library. That is his work. Okay, that is his work. But this flat surface gives the orientation to the technician, your technician, the CAD/CAM designer. Okay, so that is very important that you record this flat surface properly. Okay, so now you can see this recording. If you see like this software is also saying ki you have to record this around the scan, and you have to record this flat surface should be sufficiently recorded. That is very important. So, now when you take the scan, So you can select whatever type of scan body you can, like I've selected mandibular scan body. Now there is a whole list here. Whatever type of scan body you want, you can select. You can even add search. You can also upload the library. You can ask your implant company, if it is not mentioned here, that send me the file, and you can upload that library here, the scan body library here. So now, for example, we have selected this kind of scan body. So it will be easier for the software. You can see this is an add-in scan body. So this have multiple flat surface. I have assigned it for the 4-6 region here. So now you can see the scan body is popped up here. So what happens now when you will do the, if you select the scan body from the library, and then you will scan the surface of the scan body intraorally. So it is easier for the software, the AI, to pick it up. Means once you start scanning, even after 10 seconds of scanning, when you have scanned only half a surface of the scan body, the software will match it with this scan body and will put the scan body on the tissue surface. So AI matches it. So that makes your life much easier. So you can select it from the library, which type of scan body you want to use. If it is not mentioned in the library, like the list is here. If it is not mentioned, your implant company is not mentioned, you can tell your implant company guy to send you the library of the scan body, and then you can upload it in your software. So now when you are scanning, like we are doing a mandibular 3-6 region. So first, before doing the scan body thing, first you have to scan the maxilla, then you have to scan the mandible, then scan body, and then your occlusion. These all 4 things you have to record: maxilla, mandible, uh, your scan body data, and then your occlusion. Okay. And you have to also record the soft tissue profile. So here we are recording the soft tissue profile, because you need to record the soft tissue profile also. Because based on that only the technician will give the particular emergence profile to your final crown. So you also need to record the soft tissue profile of the implant region where you're planning to place the scan body. After recording the soft tissue profile, now you can select your scan body from the library, place your scan body, like you can see it is RS7. 7 means the height of the scan body. They have long and short scan body. So you can see this is a different type of scan body. This is of the IDDCON company, that was of Strawman Peak scan body. So now you can see it has multiple surfaces. So we want one flat surface to be recorded. And if you have selected the particular scan body from the library, the AI will do half the work. Only you have to do just little bit 50% scanning. The AI will pick up the scan body from the library and will place it here. So that will make your life easier. But make sure you are able to select a particular scan body. See, we have selected 4-6 add-in scan body. You have to assign it. Every software, every company software has different protocols, but the nutshell of the story remains the same. So now you can see multiple surfaces. Then it is easier for you to record. I'm trying to keep the lecture as much simple as possible, so that everybody understands it. Now I am just focusing to show you that how the final recorded impression looks like. You can see all the surfaces of the scan body has been recorded properly. Also record the proximal surface of the adjacent teeth, because the technician will develop the proximal contact of the final processes also. So this is again one more scan body. This is again a peak scan body. If you can look closely, this is a peak scan body. And you can see here, this is the another design, but again, you can see one flat surfaces here. So we have to record the flat surfaces properly. Try to orient and put one flat surface buccally. Means a little bit here and there it will work, because based on that only, as I told you before, your CAD/CAM designer will be able to pick up the particular scan body from the library on a software. Most of them uses Exocad software. then occlusion. So this is how it makes your life easier because you have taken the occlusion digitally, your occlusion is fine. So now based on that, you can also analyze how much crown height space is there. So you can also decide the type of processes. If space is less, you can go for screw retained processes. If space is more, you have to go for cement retained processes. You cannot give screw retained processes. So based on that, you can give a pre-milled abutment, customized process, whatever you want to give, you can decide based on that. Same thing works for crown and bridge dentistry because if your height is less for the processes, you can on the spot you can do more crown reduction and re-record the impression. You don't have to anesthetize the patient again. You do not have to place the retraction cord again. So it makes your life easier. So that patient does not have to sit on the chair again for the same procedure. Now directly he will come for the next step. Like in this case, we can now directly go ahead and give the final processes to the patient. So this also helps you to analyze the crown height space digitally. Because sometimes what happens is that if you are doing multiple implant cases, like if you are doing a half arch, I'm not talking about full arches, but if you are doing a half arch, for example, and if you are taking the impression in an analog way, so the technician, yeah, the CAD/CAM designer who is sitting in the lab won't be able to record the bite properly. So what he will do next step, he will send a occlusal rim so that you can take the jaw relation and take the bite. But if you are able to record the bite digitally, so straight away he can skip that step. So that saves times for the patient, saves time for the patient also and for you also. It makes your life easier. So I will show you a few cases. Like this is, we see these cases commonly. Extraction followed by immediate implant placement. You place the healing abutment in the in the center of the tooth region, in the central fossa region, that is the interradicular septal region. You have to place your implant so that the occlusal forces are directly axially to the implant, and it should be in the center of the implant region, in the central fossa region. So now if you can see here, we have taken the impression digitally. This is your resin cast, resin port cast, which we get from the lab. This is your customized pre-milled abutment, which is sandblasted from the lab. You can see this is a customized pre-milled abutment according to the tissue profile. So this is like a crown cutting, like you do a crown cutting. You can see the margin of the crown. So it is just like replicating a natural tooth. So it has a better tissue profile, better emergence profile. And now you can place a zirconia over it. You can also give a PFM, your choice, but you can also give a zirconia. So this is how it looks like on the cast. This is your resin cast, the printed cast, and this is your zirconia crown over the abutment. Then you can seal this hole. So this is intraoral. Now you can see the crown margin. This is your crown margin. If you look closely, you can see the crown margin. So this is the abutment seated properly. Platform switching is also there. This is your emergence profile. And this is your final crown. Final zirconia crown placed over your customized pre-milled abutment. This is one more case in the anterior region, upper right anterior region. So again, you can see this is a customized pre-milled abutment. Customized pre-milled abutment, which is sandblasted for better retention. So we are replacing one tooth. So you can see this is again a layered zirconia. Very nice work done by the lab. You can see they have added this white patches to make it look more natural. And then you can straight away give your final prosthesis. So you have to just take the scanning, then straight away you can go for your final prosthesis. You don't have to do jig trial. You don't have to do bite. You don't have to take bite with the help of occlusal rim. All those steps are skipped. Directly you can go for final prosthesis. If your digital scanning protocol is right, then you can skip all those steps. So it saves a lot of time for you and for the patient also. So this is your final prosthesis. Again, one more case, extraction, immediate implant placement in the interradicular bone in the center after osseointegration. Now this is a again cement. That was a that prosthesis was over customized pre-milled abutment. This is a normal stock abutment cement, but done digitally. So you can skip all these steps, just take the impression with the scanner, and straight away you can go for the final processes. As you can see, it is delivered by the lab. Place the abutment, place your crown. So this is your final thing. Interval you can see. So now it is a very good tool if you want to do immediate loading, because in immediate loading you need to take the impression, because if you are doing an analog way, if you want to do immediate loading, so in immediate loading you have to follow all these steps. You will take the impression, you will do the jig trial, then you will do jaw relation. Sometimes you have to do metal trial also. But we all know in conventional implantology, if you want to do immediate loading, you have to load the tooth within 7 days. Maximum you can go up to 10 days. Otherwise, then the osteoclastic activity starts and your primary stability starts decreasing. So, in such cases, this scanner is a very good boom, because if you've taken a impression with the scanner and it is very precise, and you have also taken the bite, so straight away you can go for the final processes, final temporary processes, and you can easily give it immediate loading to the patient. Like for this case, there was a localized periodontitis in the entire region. They were grade 2, grade 3 mobile teeth, 3132, 4142. So this patient came to me from, I think so, she was going to Bangalore. So she had only around 1 week. Then she had to go to Bangalore for her father's heart surgery. So we told him that we'd place the implant, take the impression, and within 4 to 5 days, when the work comes from the lab, then give the temporary prosthesis. So after doing the implant placement, so now we are taking the impression for the patient. So for immediate loading, now you can see we have a lot of options to do. You can see this is your maxilla, scanning of the maxilla. This is your scan body, which you have selected. So we have selected, this is a mandibular cases. So we are using a horizontal scan bodies. Okay. So these are horizontal scan bodies. Okay. These are not your normal scan bodies. As you can see, these are horizontal scan bodies. What happens is that because you're doing immediate loading, so you have lot of bleeding. So it's sometimes it is difficult for the scanner to pick up the data, because the scanner, no matter of which company, they pick up data which is stable. So with the blood and all those things, saliva, especially in the mandibular region, it is difficult for the software to pick up the data, especially if you are doing full arch cases. So in those cases, horizontal scan bodies are very helpful, because they have a long metallic arm. So that metallic arm gives a stable point for the scanner to pick up, because it is a hard object. So there is no soft tissue, mobile soft tissue. So it is easier for the scanner to pick it up. And you can horizontal scan bodies also, you can select which type of horizontal scan body you want to use of the company. See, I will open up the library now. See here, the library, it is showing the scan body library. So you can open up this and you can select the horizontal scan body. Different companies are making it. New Biotech, Orden. I've used these FireX scan bodies of the RR Dental Lab. So then you can select it. So once you have done with the scanning of the uh, scan body, then you can also do you can also take a pre-op data, like you can also record pre-op data, pre-op maxilla, pre-op mandible before removing the teeth, and pre-op occlusion. So the occlusion is with you before starting the surgery. You have taken pre-op maxilla scanning, you have taken pre-op mandible scanning before removing the tooth, and you have taken pre-op occlusion. After you have done extraction, you have placed the implant, you have done the scanning. So now you send the whole data to the lab. Pre-op maxilla, pre-op mandible, pre-op occlusion, and your scan body data. So now your occlusion is perfect, because you have already taken a pre-op full mouth occlusion. So this is a DMLS bar, which we got from the lab. This is a DMLS bar, printed DMLS bar. Over that, we have given a temporary PMMA prosthesis, polymethyl methacrylate prosthesis. So now DMLS bar is placed inside patient's oral cavity. You can see here. And now this is the final OPG of the patient before she left my hometown Gwalior. So because it is PMMA, that is why it is radiolucent. And this is your DMLS bar over which we have given. बाद में हो जाएगा, लेक्चर चल रहा है ना. So sorry for the disturbance. So this is your DMLS bar. Over that, we are given this PMMA prosthesis. So now again, this is one more immediate loading case. This is again a kind of a full arch case. So before removing, this was a case of immediate extraction and immediate implant placement, full arch. So in this case, what we did is that before extracting all these teeth, we took the pre-op maxilla, pre-op mandible, and pre-op occlusion. So now your jaw relation and occlusion is there with the lab. So now after extraction, you have to just take the scan body, collect the scan body data. And if that scan body data is perfect, finally the lab can straight away give you a prosthesis, temporary prosthesis, because the occlusion which you have recorded is perfect. That is the natural occlusion of the patient. So here, because there is a lot of bleeding, these are the sutures you can see here. So that is why we have used this. We have used this horizontal scan bodies. Otherwise, it is difficult for the scanner because of this bleeding and this friable soft tissue which is mobile. Sometimes it loses the track while recording. So if you give a stable, long metal object, so it is easier for the scanner to pick it up. So these are all your, you can see these are bleeds are there. All these blood is there. This is your sutures are there. So this is on the day one, we have done the scanning. So within 7 days, we get the process and we give it to the patient. It makes your life much easier. So this is the pre-op of this patient. So before extracting the teeth, you take the pre-op maxilla scan, pre-op mandible, and the bite. So this is now the, later on the patient is going ahead with the lower processes also. But upper, if you can see, we have placed these tilted implants. And we are going now we are going after giving the immediate loading after 3-4 months. Now we are going for the final processes. This is a metal trial. Again, digitally you have done, so straight away you have gone for metal trial. So this is the final process of the patient. This is screw retained prosthesis, DMLS prosthesis over multi-unit abutments. You can see crown height space is less. This is kind of a FP1 prosthesis, screw retained. You can see. So this is the nutshell of the story. I've tried to keep my lecture very precise and very short and very easy to understand. So if you have any queries, you can also WhatsApp me or you can follow me on your Instagram. I have a lot of educational videos which I have there. This is my hospital where I work along with my wife. She is also an endodontist. And thank you everyone for listening to me patiently on your weekend, Sunday. If anybody has any queries, please ask. I'll be happy to answer.
If you want to ask question, you can unmute your microphone and you can ask question. Otherwise, you can write the question in the chat box. Thank you, sir. Nice session. Very informative.
Thank you so much. Thank you so much for listening to me on Sunday.
Dr. Rohit is thanks saying this. Yeah. Okay, Dr. Rohit.
Okay. Thank you.
Presentation went very well and they understood. And you have already shared your phone number. Audience, you can take the screenshot of this. The mobile number is given, and the scanners are there, so you can connect directly to Dr. Rohit if you have any question. And if you want to upgrade your skill, you can always better connect Dr. Rohit for this. Thanks, Dr. Rohit, for sparing your precious time on
Thank
Sunday
you so much. Thank you so
and
much.
joining us and giving your enriching
Thank you.
presentation.
My pleasure. My pleasure. Thank you for
Yeah,
giving
yeah,
the opportunity.
yeah. So with your permission, we are moving our next speaker, Dr. Harshvardhan Arya.
Yeah, sure, sure.
Should we move to the next speaker now, sir?
Yes, yes. Please, please go ahead. Please. Thank you.
Okay, okay, okay. Yeah, Dr. Harsh. Uh, Dr. Harsh is visible, yes.
Yes.
Yes. So we are coming to our third session of the final day of International Digital Industry Congress. We would be, Dr. Harshvardhan Arya would be throwing light on restoring single centers IA chair-side approach. And he is our regular speaker in our, he was also a speaker on first edition, International Digital Industry Congress 2025. And he is come joining again. We have privilege that an expert is with us, expert professor on this. I'm just giving formal brief introduction of Dr. Harshvardhan Arya. And Dr. Arya, if I'm missing anything, you can add on because you guys are doing upskilling yourself and you are, various accreditation you are adding on regularly. So if I am missing anything, you can add on. So
Thank
Dr.
you.
Harshvardhan Arya is a distinguished prosthodontist and implantologist with over more than 2 decades of experience. He is alumni of Nair Hospital Dental College, Mumbai, and he did his PG from GDC Nagpur, a known organization in dentistry. He is former professor and PG guide. He is currently the key opinion leader in CERECS CEREX chair-side CAD CAM in India and serve as a guest faculty for digital dentistry at INU Kuala Lumpur. He is co-guide for PhD research at VNEET Nagpur and international publication. He runs an advanced dental practice and in-house CAD/CAM laboratory focused on implant superstructures and all ceramic restorations. He has lectured internationally in Malaysia and Philippines and served as a sectional editor of Journal of Indian Prosthodontic Society. He is the second Indian certified by the Digital Dental Academy Berlin and a mentor for implant prosthetics at Norris Medical. So over to you, Dr. Harshvardhan Arya. You are visible. You just share your slide, and if I'm missing anything, you can add on your presentation. And over to you.
Thank you very much, Dr. Nurul. That was a very kind introduction. So without ado, I will share my screen now.
Yes, your screens are visible.
Is this visible?
Yeah, in a slide for you.
Okay, great.
Perfect, perfect.
So I realized that this is a Sunday, and as my dear friend Rohit, who gave a brilliant lecture before me, mentioned that thank you all of the members who have joined today on a Sunday. We all know that Sunday is the only day we get to rest and spend some time with our families, and you have chosen to be a part of this wonderful Congress. So without wasting time, in the given time, I'll try to tell you a very interesting yet a simple topic, that is restoration of single central incisors. So what's so special about single central incisors? We all restore uh, uh, teeth routinely, but what is so great about, or the challenges about restoring central insights, right? So this is my clinic in Nagpur, Maharashtra, where I practice. I've been practicing for close to 24 years now. And as was mentioned in the introduction, I am a chair-side CAD/CAM user. So I have been using chair-side CAD/CAM for more than 14 years now. Uh, and we have also recently acquired a 5-axis milling machine. And as a prosthodontist who has been doing a lot of technical work himself, I really enjoy creating restorations in the clinic. So today we are going to focus on a very specific aspect of application of chairside CAD/CAM technology, and that is restoration of single central incisors. So what is so great about single central incisors? Now, if you see, you all must have restored, replaced missing central incisors, or those which are broken down routinely. But what are the challenges that we face when we restore a single central incisor? Restoring two centrals is easy because it's a mirror image of each other. So that is the biggest problem. A central incisor is an absolute mirror image of the contralateral central incisor. So you have to get it absolutely perfect for the patient to have a very satisfaction in the treatment. Restoring lateral incisors is very easy. Restoring canines or premolars is also easy because it's very difficult to ascertain the exact symmetry between the two contralateral teeth. So in a central incisor, even a minor asymmetry is very noticeable by the patient and their relatives and friends. So this is a big challenge for all the clinicians, no matter how experienced you are. In spite of years of experience with the same, we still face issues when a patient comes to us with a deteriorated or broken down central incisor. Now, to match the exact color and the shade is very challenging because we see the patient on the chair, we take pictures, make impressions or take scans and send it to the laboratories. They cannot really judge the color of the tooth, and with a little bit of experience and with the help of images, they try to give you a shade which many times is not perfect. So it usually happens that when we are restoring a single central incisor, the work of the patient is sent repeatedly back to the laboratory and then comes again, and there are some minor changes. Sometimes the shape is not right, sometimes the color is not right, and it can be quite frustrating. So let us see what are the different approaches that we can have. So since I have less than 25 minutes, I'll just show you a few interesting cases, simple cases, which all of us routinely encounter in our day-to-day practices. So here what you see is a broken down left central incisor. And of course, even the right has experienced some amount of class 4 type of defect or chipping. So we want to be conservative in our approach. We don't want to aggressively prepare teeth. Now, mind you that both these teeth are vital, right? So I don't want to do endodontics for these two teeth and give full crowns to them. This is what we used to do many decades back, and this is what was taught to us. But today we have better understanding of restorative dentistry, and we have bonding techniques and material which are very superior. So in this case, as you can see, we have the left central incisor, which is almost fractured 50% of the tooth surface, and the right central, which has incisor-cervical fracture. So I prepare the tooth, I add composite on the left central incisor, and then prepare the tooth for a full crown. So the left one will receive a full crown. The right central incisor, 1-1, has been restored by using composite resin only. So here we have not done a porcelain veneer. We have not done a full crown using any of the all ceramic materials, just a simple composite buildup. And this is where I use chair side CAD/CAM. So as I mentioned before, that the challenge in restoring a single central incisor is that it is a mirror image of the adjacent tooth, right? So luckily for us, in the CAD/CAM softwares, we have a provision to copy and mirror the adjacent tooth. So if you select this option, the software will give you a proposal of the tooth being restored, which is a mirror image of the adjacent tooth. So it doesn't come 100% perfect all the time, but it gives us a good starting point. So if you see here, this is milled using a feldspathic ceramic block, which is a multi-layered block. And this is the result after milling. Then obviously, we check this in the patient's mouth. Now, it's very important not to finally glaze or cement the crown without checking it in the patient's mouth, because there are a number of changes that usually have to be made, and it is best done while checking in the patient's mouth rather than seeing it on a model, right? So we take the crown to the patient's mouth and then make minor changes in the shape of the teeth. And then I have the privilege of staining and glazing these kind of central incisors right in the patient's mouth. So this is the advantage which you have when you have in-house CAD/CAM with you. So unlike the dental technicians where they at the most can see a picture on their WhatsApp which you have sent them, I can actually see the color in the patient's mouth and then put the crown in the furnace for firing and then cement or bond the crown in the patient's mouth. So this is the final result of what we have achieved. And as you can see, it is a pretty decent match. So this was the pre-op and this is the post-op. So this is what we can achieve when we use chairside CAD/CAM and do characterization directly in the patient's mouth. Now, doing this with composite resin is very easy, because we have complete control over the layers of composite that we are putting, and you can shape them, you can layer them, add translucent material. If you don't like it, you can remove and relayer and resurface it, right? But the same ease or convenience you cannot have with ceramics because they are monolithic in configuration. If I send it to the laboratory, they will try to layer it, which also creates number of issues, especially in a single central incisor. So it's very easy for a dental laboratory to make 6 veneers or 8 veneers, because then they can control the shape, color of all the restorations together. But it is very challenging to achieve it in a single central instance. Right? So let us see another case where we have again a 2-1 of the patient which is chipped. Now here again, I do not want to go very aggressive by doing endodontics for this patient and giving a full crown. So we add composite and just prepare it slightly more than a veneer, but certainly less than a full crown. And then I'll just show you few steps that I usually follow in order to match the color and the shape of the crown or the veneer with the adjacent central incisor. So as you can see, I have this milled ceramic crown using that copy and mirror function. Now you can see the shape is more or less correct. However, a little bit of obviously texturing, if you like. Texturing. If you see the labial surface of the adjacent central incisor, you can see pericymata, you can see mamelons to certain extent, and you can see secondary anatomical features on the labial surface. So this is a great opportunity for the dentist to achieve this kind of characterization on your restoration directly in the patient's mouth. It's very difficult for the technician. Of course, that is where the skill of the technician comes into play. But it's easy for us to match those secondary anatomical features directly on the crown. So here I have done some characterization and I have used glaze now finally. Put the glaze on the crown. As you can see on the midline, a little bit of excess of glaze is seen. So once I am happy with the overall appearance of the crown, then I remove the crown carefully from the patient's mouth and directly keep it in the furnace for firing. So it undergoes a thermal cycle in the furnace, and all the glaze, the color, whatever we have added on the surface gets fixed on the crown. And this is the final result of the. Since we know that this is artificial tooth, we will always be able to see some subtle differences between the restoration and the natural teeth. But for the patient or a third person who's viewing, it looks like a near perfect match, right? So if we cannot go 100%, we at least try to do 95%. Now, many times we come across central incisors which are discolored, which have a tooth stump which is darker in color because of intrinsic or extrinsic staining. And this increases the level of difficulty in restoring such kind of teeth, right? So we will see how we can manage discolored stumps and still get a reasonably good match with the adjacent central incisor. So you see the tooth number 1, and there is obviously there was some trauma very long back, because of which the tooth is devitalized and there is discoloration. So one approach, of course, is to do endodontics and do non-vital bleach or walking bleach for such a tooth. But many times, some of you who have already seen cases like these will agree that the canals are completely obliterated because of formation of secondary or tertiary dentine. The tooth is completely asymptomatic. Patient does not have any pain or discomfort or swelling related to that tooth, but they only want cosmetic enhancement. So in this case, we have an isolated central incisor which is discolored, but since we are improving the aesthetic appearance of this patient, we will also try and close the spaces or the diastema. So again, here the approach must be conservative. So what is the aggressive approach here? To make 4 porcelain veneers. So I wouldn't say it is wrong. It is correct. But sometimes you can do benefit to the patient by doing minimally invasive dentistry, right? So making 4 porcelain or ceramic veneers is easy, because then the technician can or the laboratory can really match colors easily, except the central, because it has a very dark color. So if you do not give information to the laboratory, they will make 4 veneers of exactly the same translucency and color. And when you place these 4 veneers in the patient's mouth, you'll find that the right central incisor or 1, the darkness of the tooth stump shows through the veneer, right? So it appears still darker than the adjacent teeth, right? So that will defeat the purpose. So here what I have done is composite buildups and closing of the diastema spaces just merely by composite buildup. And then I have, after doing a veneer prep on the right central incisor, we found that the discoloration is not very great. It is moderate in nature. So we can easily mask this by using the appropriate ceramic. Right. So we've gone for a veneer. So it is very conservative. We have not gone for a complete full crown, which would have been easier. But the problem with a full crown is then you are dependent on the lab to give a layered zirconia crown, and getting the shade match becomes extremely difficult. So here we have the final result. And of course, since I have chairside CAD CAM, all this is completed in one single visit. But you can do the same using a good dental lab. The key here is to have good communication with the dental laboratory. Right? So this is a very simple case of discolored tooth which is managed. So here in this case, we were able to overcome the discoloration because it was moderate in nature, and there is sufficient opacity in the veneer material to mask that discoloration. But sometimes we get difficult cases. For example, this patient is a medico and she's daughter of a very senior dentist practicing near my city. And he himself has, made crowns for her, which she did not like. Then she went to Mumbai and got some treatment done there, but she's still unhappy. And she was doing her MS, so she couldn't come to the clinic very often. So his dad, the senior dentist, called me and said that please help her. I know you can do this in one single visit, and she cannot come again and again. So she'll come for a day, complete the case and let her go. So it's a fairly challenging case. And as you can see, the crown which was done previously has a certain amount of discoloration on it. So again, the problem which I talked about earlier, that the patient, the dentist did not consider the discoloration of the underlying dentine and directly ordered a crown, a full ceramic crown made in Emax, which still looks low on value. Okay, so the shape overall is maybe acceptable, but it is looking darker clearly, right? So in such cases, we have to, I don't have a choice of making a veneer or anything conservative, because it is a crown was already given to the patient, right? But when I remove the crown, I find that there is a considerable amount of discoloration. Now, this cannot be completely masked by using a all ceramic material, right? So here we do a trick. Since our full crown was already given, the amount of preparation was considerable and quite good. So there was a lot of space available to restore this tooth. So here I have given her a coping in zirconia. So this is like a coping, which usually is made when a lab wants to layer ceramic on it. So we have made a coping in zirconia, and then after that, I have made a feldspathic ceramic crown over that coping. So scanned it again, designed it. As you can see, some staining glazing done directly in the patient's mouth, and then the final restoration was delivered. So you can see how the change has happened. Again, it is not 100% perfect, but it is far better than what it was, right? And all this we could achieve in a single day. So this is the advantage. Now you have another tooth, the left central incisor, which somebody had done a composite buildup. And obviously you can see she's a young girl and she wants her aesthetics to be as good as it can be. And you can clearly see that the composite buildup was done very long back. Probably it looked very nice when it was completed, but over the years there has been micro leakage, some discoloration, etc. Right now, the more you get experience in restoring single central incisors, the more you realize that all cases you cannot commit the patient about the final result without removing the old restoration, right? So you have to remove this, and then you know the exact picture that you are dealing with, and then you can recommend the patient what will be the best line of treatment. So in this case, once the composite was removed, you can see the amount of discoloration that is present on the tooth. Now, in this case, it is easy for me to revert to a full crown, reduce the tooth considerably, and try to, make the lab make the best of it. But I decided that let us try something conservative. Let us still give a veneer. Now, if you see the color of the underlying dentine and enamel, it is quite dark. Now, this amount of darkness cannot be compensated merely by using a full ceramic material which is slightly opaque. If we go for a very opaque material, then the aesthetics of the translucency which you see on the adjacent central incisor will not be duplicated. Right? So we do a trick here, and this is a tip for all of you. You can also try this in some of your cases. We sandblast the tooth surface and then apply some bond on it. You etch it using phosphoric acid, wash it, apply some bond, cure it, and then apply what is called as a composite opaquer. So this is a opaque composite which is available in a flowable form. So you apply very thin layer of it on the teeth and ensure that the margins of the prepared teeth are still free. Do not extend the opaquer on the margin, because especially in a veneer prep, the margins are absolutely essential for bonding. So they should be free. But accidentally, if you happen to apply it on the margin, you can again use a burr at a slower speed and carefully remove that. And once you do that, you can achieve an excellent shade match. So you can see on the left of your screen is the artificial tooth, and the shape and the translucency have been matched accurately. So a tip I can give to the youngsters is that work very hard on the shape of the teeth. right? So the carving that you learned in your second BDS and the wax carvings that you did, and some of you felt that it was so unnecessary and it was boring and it was really uh, something which nobody likes to do. But that carving skill will be very helpful to you when you are practicing aesthetic dentistry, because the shape of the restorations have to be absolutely perfect. Once the shape is perfect, then the color is easy. And as we will see in the color, there are three dimensions of color: hue, chroma, and value. Value is the by far the most important characteristic that you should be matching. So another case we see here, there are two central incisors, one on which a full crown was already given. So when we remove the full crown, we see that there is some cement underlying, and the right central incisor is quite deeply discolored. Right? Now this again patient, we get a lot of patient from outstation, so they want their work to be completed, if possible, in as less appointments as possible. So we try to do, because of CAD CAM, we are able to complete such cases within a day. And this is a challenging case because if I do a full ceramic restoration without addressing the discoloration, we will never get a very satisfactory result here, right? So now you have the 1-1 which is discolored, and we have 2-1 where the crown has become dislodged. So obviously we will have to do a crown on the 2-1, but on 1-1 we can do something a little more conservative. So here I do a veneer prep on 1-1. I refine the preparation on 2-1 and use the same composite opaquer which we tried in the earlier case. Okay, so once you apply the opaquer, it takes the discoloration of the underlying tooth out of the equation. So now you have a tooth colored surface, okay, which is slightly whitish, which is favorable for making all ceramic restoration, right? So here we see that I have made two feldspathic ceramic crowns, and I did some glazing, but it didn't go the way it should have. A too thick layer of glaze on it, and you see that it is pooling there. So that can be removed and it can be polished. Also, you can notice that there is a triangular space where the papilla has receded because of the previous restoration that the patient had. But if you do your dentistry right, if you take care of all the key features, then you can have a favorable response from the gingiva also. So here you see after few months, 8 months follow-up, and you can see both the central incisors are looking pretty natural. And you can also see how the interdental papilla has grown back into the interdental spaces. Right? So this is one good technique, a simple technique to overcome discolored dentine discoloration, which is present in the tooth. Now, this skill will also extend to implant restoration. So it's not only natural teeth which require natural central incisors, which require a very close match with the adjacent one, but sometimes even implant cases. So suppose this is a case where the 1-1 or the right central had fractured and it had to be extracted. So here I have done socket shield and placed an implant in the palatal orientation to give absolute perfect emergence to the crown. And there, after that, the challenge is to match the shade of the tooth. So I gave a Maryland bridge to this patient and then waited for the osseointegration to happen. And then when the patient came again, I took a scan. Dr. Rohit, the speaker before me, has already shown a few cases using scan bodies. So the same technique is used. However, that is the easy part. The difficult part is to again match the shape and color of the tooth with the adjacent central. So we saw a few cases of natural teeth. Now we see a few cases of implant crowns. And this is a screw retained implant crowns. And you can see how by using the correct translucency of the ceramic material and doing some staining and glazing judiciously in the mouth, you can achieve this almost near perfect match. So like I said, if not 100%, at least 95% of match. And the right central or 1-1 here is the implant crown. So it has a good emergence profile, which should be present when you plan and execute it perfectly. Right? So now another case of implant whereby the implant, of course, is the easy part, but again, matching the single central incisors become difficult. So here, this is again a fractured 2-1 or left central. And one of my endodontist friend referred this case to me and saying that we tried doing endo, but then we took a CBCT. There is a horizontal fracture, and you will have to manage this. You'll have to extract and do an implant. Now, this patient was very, very demanding. So, what are the challenges that I had in this case? Very high. He was a male patient, but very demanding because he was in public contact, and his job required him to be meeting a lot of very important people. So, his aesthetics was very important to him. And other challenge was that he had a thin biotype. He had a very characterized right central incisor. So the challenge was to match it perfectly. And as again, I get very short time because this patient was from abroad and he had very limited time to complete. So what was the plan? Doing partial extraction, immediate implant, connect the abutment immediately, and then give him a provisional restoration right away, provided we get good primary stability, right, in the implant. So this is what we achieved socket shield or partial extraction, implant place, good primary stability. And then I gave him a milled PMMA crown. So this is made out of PMMA, which is acrylic resin, basically. So if you see the color and the texture is not matching, and as I told you, this patient was really demanding. So after doing this, I have done some characterization and staining using composite stains. So we get, just like ceramic stains, we get composite stains which are light cured. You can apply on PMMA or composite resin and just light cure it, right? So this is what I have done, and you can see that the picture on your right hand side of the screen, that is after characterization. The one is directly after milling on the left side, and the one on the right is after characterization. So I could achieve a better color, texture, and color match. Right. So patient was happy, and he went back. Then he came back after 8 to 9 months for the final crowns. So when he came back, this is what the picture I had. Now the challenge is to replicate this in the ceramic material. It's easy to characterize composite resin or PMMA, but it's very difficult to characterize ceramic, right? So first I did that copy and mirror, which I told you about, told the software to match the right central. It did, and a little bit of tweaking in the design, and then I get this. So the shape is good, right? Overall shape is pretty decent, but the value is low. So the tooth is looking duller. Tooth is looking darker, the left central incisor, our implant crown. So now here the problem is with the translucency of the ceramic material which I have used. So this is a very translucent block. So what it is doing, it is allowing the light to pass through, and it is exposing the darkness of the mouth behind the teeth, and that darkness is showing through, and overall value of the tooth is dropping, right? So here, instead of that, I go for a median translucent block. And you see, this is how it looks like. So on the picture on the right, you see the higher value, slightly higher value. So if you carefully see, you will be able to see, make out the difference that the new crown is slightly brighter. That is what we want. We want to match the value of the adjacent teeth, right? So this the Emax lithium disilicate is in purple color when it is milled in the milling machine, but after that it has to be crystallized in a furnace, and that is how you get the actual color which is supposed to be there, right? So here, this is the final result. Now this crown, I have done some texturing using burr and magnification directly in the patient mouth. There is no staining and glazing done in this case because the color was almost perfectly matching. So what I have done is texturing and polishing. That is all which I have done. I have not added any staining here. And you see that the left central incisor is pretty decently matched with the right. And you also see it on the X-ray view. So this is something which is sometimes very challenging, but with experience it comes. And this is the final, and this is the CBCT of that case, and we see the socket shield. You can appreciate the socket shield, the implant and the crown. And this is the final texturing that was achieved using a correct translucency of ceramic and some texturing. So this was before when the patient came in, and this is the final result that we get. So I know my time is up and I'm ending my presentation. What are the take-home points from this very brief presentation? Remember, all youngsters who are watching, shape is shade. Again, I repeat, shape is shade. If you get the shape right, the shade will follow immediately, automatically, right? So work hard on the morphology of your teeth. So do some carving and get the shape right. Many times the lab is not able to give you the exact shape, so you should have the skill to shape in the BIS trial stage yourself, and try to give a match which is absolutely perfect. It is as symmetric as the adjacent teeth. The next is to determine the value of the tooth, that how dark or light the tooth is. Don't worry too much about the shade, whether it is A2, whether it is A3. That is, all these modern materials are very translucent and they have what is known as a chameleon effect. So they can match the color of the teeth due to their translucency. The main here skill is to determine the value, how dark or light the adjacent tooth is. And if you get that, and if you get a good shape on it, you have won the war. So it is then becomes very predictable and easy. Next, obviously, is to involve the laboratory, because if you let your technician come into and have a look at the case, then you will be able to really help the patient in getting a perfect match, or you may send the patient or take your patient in very critical cases to the lab. Now, all this is possible when you have enough time for your case. So please, whenever you are restoring a central incisor, don't consider it just like a single tooth replacement. Don't consider it like a veneer case where we are doing 6 or 8 or 12 veneers. This is a very specialized case and it is difficult. So keep some time for it, because you may require multiple appointments to get that shape and shade right. And needless to say, those who are practicing dentists, you have to charge the patient accordingly, because if you are working so hard on a single central incisor, it cannot have the same charge or fees as a single crown or single posterior crown, right? It has to have more value. And when you have that value, you will be able to give more time. So thank you very much for the attention that you all have given. And I hope the small tips that I could give you today will be of some help to you. Thank you so much, Dr. Nurul, for giving me this opportunity.
Yes, thanks, Dr. Harshvardhan, for throwing light on a very crucial and very important central incisor, because it's the visibility is the first actually to central incisor only. So the aesthetics is very important where we are restoring central incisor. And anybody want to ask any question? The very good, take home message that shape is shade, and work hard on morphology, because when you are taking care of shape, the shapes will follow itself.
Right.
And the value is important. And the main thing for the budding dentist is that keeping the lab in the loop actually to get the better results. Anybody want to ask any question? They can ask question right now, or they can type on the chat box. Any question? Otherwise, we'll move to our next speaker.
Dr. Nurul, may
Yeah,
I?
Yes, Dr.
Actually, I don't have any question, but I thought I should thank Dr. Harshvardhan for a very wonderful presentation. And in fact, what happens is people forget aesthetics. And being an academician, I felt you were the only person who said that there is importance of carving, which students actually forget.
Right.
They forget their handwork. And I don't know, probably when they do PG, they might be realizing that what was the importance, what was something being taught to them. Being an alumni of the same institute, thank you so much. I also belong to the same institute. But yes, you gave credit to a subject that was very nice. And in fact, your cases were very good, sir.
Thank you. I really firmly believe that what we have learned in our dental colleges is extremely important, especially the preclinical work, which we tend to forget. And it only helps us later in practice. So those who are still studying, make sure that you make use of all the opportunity that you are getting to learn. Thank you, ma'am, for those kind words.
So there is one question to Dr. Harshvardhan. Doctor, question from Dr. Hafida. She asked that how much asymmetric between the two maxillary central incisors can be aesthetically acceptable before it becomes perceptible to the patient or clinician. The question is in the chat box. You can read and answer.
Yes, sure. It's a great question. Actually, 100% symmetry is needed. Even minor differences are easily noticeable by the patient. Although they are not trained in aesthetics, but even a lay person can identify if there is a change in the central incisor. If you make a lateral incisor which is not symmetric to the contralateral lateral incisor, it will not be noticeable, so much noticeable. But central incisor is very tough because your eyes are trained for golden proportion. And even a lay person who's not a doctor, not a dentist, not even anywhere close to dentistry, when they have a look and they will ask the patient that कुछ तो कराया है क्या आपने treatment और वो ये दाग कुछ अलग लग रहा है. So ideally 100% match should be there, which is impossible. We all know that. So considering the practical limitations, it should be at least more than 90% match. Try your best, work really hard on it. Many times we have changed the material, changed the crown 2 or 3 times to get a perfect match. But once you do, the patients will understand your skill. They will understand the time that you're giving, and it will only help your work and your practice. So 90%, at least 90 to 95% should be your target. I hope that answers your question.
Yes, well answered, Dr. Harsha. And with your promotion, we are moving to our next speaker, Dr. Rabia. Dr. Harsh, should we move ahead?
Yeah, sure. Thank you very much.
Yeah, it was very enriching, presentation on central incisor. Yes. Dr. Rabia, she's there in the meeting room. Dr. Rabia, could you unmute and open your camera? Yes. Yeah. Good afternoon, Dr. Rabia.
Good afternoon, Dr. Nurul.
Yes. Dr. Rabia, we are, searching for the dental surgeon who is working exclusively on AI nowadays, because AI is taking every walk of life actually. So AI is in every, science and every clinical thing when we are managing. So AI is working. So we somehow reached Dr. Rabia, and she did a wonderful work in AI in dentistry. So before we start, I'm just giving a formal introduction. Dr. Rabia, if I miss anything, you can add on, because you guys are upskilling, upgrading yourself regularly. You have accreditations, you have fellowships, adding on every time. So if I am missing anything, you can add on. I'm just giving, as a moderator, I have a responsibility to give you formal introduction. Dr. Rabia Koya is an aesthetic dentist, the CAD designer, and AI in dentistry innovator with over 14 years of clinical experience. She serves as a consultant cosmetic dentist and head of the department at Wockhardt Hospital, Mumbai, a known hospital. And she's a director at Impression Dental and Maxillofacial Center. She's postgraduate in aesthetic dentistry from prestigious Manipal. And she did AI and machine learning from Texas McCombs 2022. She holds a patent for an AI-based dental diagnostic system using OPG imaging. Her expertise spans dental imaging, AI, CAD design for patient-specific implants, and AI-assisted specific implants and AI-assisted clinical workflows. She is the author of a clinical intelligence in dental clinical dentistry from Elsevier publication, and she has an IEEE accepted paper on multimodal dental diagnostics. An international speaker on AI and digital dentistry. She is certification instructor in Blender for dental. Her awards include bronze in AI image analysis at Fandent 2023. And she also got an award in Passionate Dentist of the Year in 2017. So over to you, Dr. Ravia. If I miss anything, you can add on and you can share your presentation. You can continue.
No, that was a lovely introduction, and thank you, Dr. Nurul. I will share my screen.
Yes.
So is my screen visible?
Yes, it's visible. Can we go on slide share mode if possible? Yeah, it's perfect. Perfect.
Okay.
Very
So
good afternoon. Wonderful.
it
Yeah.
has a lag. It has a lag.
Oh.
Okay, so good afternoon, everyone, and thank you for this beautiful introduction, Dr. Nurul. It's a real pleasure to be here today, and I'd like to thank the organizers, especially Dr. Nurul of IDDCON, for inviting me to be the part of this session. So today I'll be talking about AI in dentistry and from the clinical practice, what exactly and how are we using artificial intelligence in our workflows. So before I, just 1 minute, I'm really sorry. So before I talk about AI, I want you to forget everything and know about dentistry and artificial intelligence in just 1 minute. So I would be playing a video and looking into the future, not future, it is exactly a present of where are we today in AI in dentistry, and what do our patients imagine when it comes to dentistry as a technology. So here's the video for you. So now the interesting question is, how far away is this from reality? Some of it is still futuristic, but a surprising amount of it is already happening. So AI is no longer fiction. It is the reality. And we mostly saw, the science fictions in movies, those sci-fi movies, what we see, and those intelligent machines, the robots talking with the human beings, and all that had seemed to be far, far future. But that future has arrived, and AI is no longer fiction. It is already the part of our reality. And this is where we are today. Robotics in surgery, autonomous system, intelligent imaging, and language models where we are interacting with our patients through chatbots, generative AI, These are no longer ideas confined to scientific fiction. They are technologies that are already being developed, and they are used in real worlds these days. Especially in healthcare, it has been integrated very beautifully. So before we go deeper into the AI in dentistry, so let's understand the bigger picture. For just a moment, that how the market of AI is, the statistics. Uh, it has moved far, beyond research laboratories, and it has become a major global technology uh, in industries these days with enormous investment. And it is rapidly and exponentially growing each year. And the numbers are quite high and very surprising. So, and that growth is happening across every sector, including healthcare. Today, AI is everywhere, it's universal, right? And most of us are already interacting with AI every day, whether it's through a search recommendation, voice assistance, facial recognition, navigation, or generative AI. Few of the terminologies you won't be understanding, but yes, I would be giving those definitions ahead in my presentation. So the question for us isn't really whether AI is coming. It's already here. And the question, what we are going to do with dentistry would be most important for us. What are we going to do AI in dentistry? So let's look back into the history of AI. It's not new. This journey actually began 70 years back from the early ideas in the 1950s through the periods of AI winters, where there wasn't any breakthroughs happening in the field of artificial intelligence. So that is called as AI winter. And then there happened, there was a IBM Deep Blue computer which defeated a human, Gary Kasparov, who was a world chess champion. And that was a major breakthrough of artificial intelligence. And later it came. There were break after the AI winter. They had deep learning. There was a breakthrough of deep learning in the 2017. There were transformers, and finally there are generative AI, agentic AI, multimodal systems, which are right now being used in various sectors. So what exactly is AI? So let me make this very simple for you. What do we actually mean when it comes to artificial intelligence? AI is essentially the ability of a machine to perform the task that normally requires human intelligence, and which recognizes patterns, understanding information, learning from the data, making decisions, problem solving, and or generating the content. And AI is not one single technology. There are various types to it. There are narrow AI, general AI, and super AI. So when I'm talking about narrow AI, we are just taking one task at a time and making the computer learn, and that is narrow AI. And till now in dentistry, whatever technologies are being developed, they are in narrow AI only. When it comes to general AI, it is a much broader term, and it should have a human-like intellectual capabilities, and super intelligence is which is still hypothetical, and there is a lot of money into it to make machine super intelligence. There are big companies like Google, DeepMind, and many companies which are into all these things to make machine super intelligence. So for our clinical discussion today, what we would be talking ahead is narrow AI. And AI being an umbrella term, there are lot of branches under this umbrella, and it's a broad field. AI is a broad field. So under this umbrella, it contains ML, which is machine learning, deep learning, computer vision, NLP, which is natural language processing, and generative AI. So, in short, I would talk about, and I'll just touch what exactly all these means. ML is one of the ways we actually build AI, and instead of programming every rule explicitly, we give the computer the data and allow it to learn the patterns from those examples. So now one example I could give you in ML is I will give a model 100 images, maybe thousands of images which are labeled ROI, region of interest, I have labeled. And through that, I want the computer only to learn that labeled image. And those patterns would be learned, which are associated with that particular finding, and then apply what it has learned to the new image. So once learning all the label data, when if the new image comes in, ML will start recognizing that ROI, the region of interest, what is already been learned by the computer. And there are various steps to it. We first train, we give the data, we train, we validate, and then there's a prediction which happens once the learning is complete by the computer. And learning itself has various branches to it, which is reinforcement learning, unsupervised learning. Now, when it comes to supervised and unsupervised learning, supervised learning is we are giving label data to the computer, and unsupervised learning is where the system looks itself for a pattern, and we are not giving label data to the computers. When it comes to reinforcement learning, it learns through actions and feedbacks and rewards. Like we playing a game, and to win, we are getting rewards and we are going ahead in the game. So that's called reinforcement learning. I would give you this is a very interesting field in ML, which is reinforcement learning. And this was the major breakthrough. Google DeepMind Computer AlphaGo had defeated the world champion of Go, which is a Chinese game. And it's a very complicated game. And I would just for a moment, I will demonstrate the power of how it has approached. This is a video. I will run through it. He's being very low. He is the one who is the world chess champion, and he is very scared of playing with the computer and losing.
History, the human professional Go player. Artificial intelligence researchers have solved the game of Go a decade earlier than expected. The computer named AlphaGo was able to beat the European human champion.
Artificial intelligence researchers have made a significant breakthrough.
It really is a big leap forward. There's a big difference between the way the IBM computer beats Kasparov, which was programmed by expert chess.
Okay, so for me to play this video isn't the game of Go. The idea that machines can learn increasingly sophisticated strategies, which we even have not taught them, is what is reinforcement learning. And when it comes to deep learning, there are the branch which I talked about is deep learning, under which it comes computer vision. And most of our field, dentistry, computer vision is the work where we are working on when it comes to images, because this is we are giving a vision to a computer. And dentistry is incredibly with a lot of data. We are generating image-based information. An AI system can also be trained to detect, classify, measure, and segment structures within these images. I would give you an example ahead of about these. And so let's explore how AI is revolutionizing, the diagnostics part of dentistry through giving radiographic interpretation. This is few of my work which I would go and show you ahead. CBCT segmentation, oral cancer detection, and also its risk predictions. So first, what we are giving is we are giving a large amount of data to the computer. We are annotating it, which is like we are marking the region of interest where we want the computer to learn. So we are labeling those data. We started with these panoramic radiographs, and we annotated them, trained the model, and simply it started detecting what it was trained on. And these are the I mean, it was 94% correct. These are the numbers. What it shows are it's accurate 94%. And this was the model prediction for the things what it has learned on. Whereas in caries, we got a very less amount of percent, which was 70%, and we are still working on it to get 95, 99% accuracy. Uh, this is the work which did not remain at a level of experiment. It progressed into a research publication when it comes to OPG reporting, and we also created a chatbot which would solve the queries of the patient as well as the clinician, and also interact with the patients and generate a complete report of OPG. This is a patented work, and we had presented this year in IEEE Conference of Artificial Intelligence. Now, when we move from 2D image to a 3D image, we are dealing with a lot of volumetric data. And this is where this is my own work, where we had segmented tumors and cyst, and tried evaluating and try AI learning it and auto segmenting it for us. Because previously, when it comes to when you are taking a CT into a CT viewer, CBCT viewer, you need to threshold it and make a 3D model out of it to understand the extension. And it's a lot of tedious work. People have, there are few of us who are not comfortable working on the systems, and there's a learning curve to each and every software we are using. And this makes our task very easy. Just a few of clicks, and you have a segmented data to understand the extension of the lesion, and to get a 3D model. So these studies are no longer a research project. There are already commercial available systems like Overjet, which can analyze dental radiographs and identify multiple findings to generate a structured report. So there are many into the markets, especially in the US. Later, when it comes to cancer detection, CV, computer vision principles are also being explored in this field, where oral pathology and cancer detection is being predicted by a AI model. So far, we have understood CV, computer vision, and what exactly CV is helping us to do. When it comes to natural language processing, it's like we are talking to a computer and the computer is giving us the answer. It could be a text to speech or a speech to text form, or NLP is also where uh, there uh, there are search summaries for a dentist, and you want to understand a few studies, and you don't want to go through all those together, all being so tedious. So NLP would be the one who would make a small summary out of all the research papers and give it to you. Now, when it comes to Gen AI, it is a more advanced form of NLP. It is unlike the traditional AI systems. It is that are primarily trained by class to classify or predict. They are either predicting, or they are classifying, or they are segmenting. But to generative AI, it can produce new content. When it comes to just giving a one-liner that I want a video on so and so, and it is going to generate a video for you. So this is generative AI. And similarly, when it comes to dentistry, how the AI is evolving, we have evolved from manual to digital to CAD, and now we are into AI-driven workflows. So let's see how these workflows are like, how these workflows are like going, and why it really matters to us as a dentist. So AI is not here to replace dentist, but it is going to be a co-pilot for us to help us give more good and better decisions, and give precision in all the work we are doing. So here's why AI matters. So far, we've looked at what actually we were interacting was the theoretical part of AI. Now, uh, when it comes to the clinical part, for example, EHR, the clinical management. Okay, there is AI can work with electronic health records, and it can summarize the patient information, automate the documentation, and identify the patterns of and support the clinical decision making of the patient's records. When it comes to chatbots, on the patient side, we are seeing AI assistants that can answer routine questions, support appointments, and it can be also a follow-up appointment where chatbot is helping us to. When it comes to inventory, this is quite interesting when a simple inventory can become predictive. Instead of discovering that we are out of a material, the system can anticipate, and it can, the consumption, and it can help you manage the supplies. When the supplies are going low, it's going to definitely give you an alarm that this is needed in the clinic. So AI is not just becoming a diagnostic tool, it is becoming an intelligent layer across the entire dental practice. Uh, this is a small pilot project which I have developed myself with the idea of creating a dental assistant that can support my patients when I'm not immediately available. A patient could ask questions and understand post procedure instructions as well in this chatbot, or get the guidance on what they should do next. And I also wanted to build an escalation pathway so that when sometimes something appears urgent, the system doesn't simply continue chatting with the patient. It can alert me so that I can intervene. This is the video of the chatbot. So I'm just asking that I'm Rabia. Trying to be more human. Okay, so now when we are after diagnosis, let's see for virtual planning, when we comes to design, a chairside CAD designing, it also is becoming a co-pilot. It is helping us for guided surgical procedures, for smile designing, implant planning, and a lot of things. So when we are uploading a CBCT data into a DICOM viewer, we are having, we have to threshold and segment our data. But nowadays, it's just one click and your 3D model is ready and it's ready to print. And this is all AI, wherein there's a lot of data which is being trained for segmentation, and it's automated. Now, once you get a 3D model and a segmented tooth, we can always plan or design the implant guide for our patients. And those guides also are nowadays AI generated. We just need to place a point where we want an implant to be and cross-check exactly where the AI has placed an implant. We need to intervene. We just can't leave it on AI, because it's we clinician who are going to work on the patient, right? So once we segment the data, guide is going to be, we'll place an implant, we'll cross-check those implants, and a proper guide is generated out of the AI model. So this is an auto alignment and an AI guide design. So the CBCT provides us the anatomical information. The intraoral scan provides the surface information. So those two are merged together, and the software can automatically align these data sets. Once the data sets are registered, implant planning is done, and the guide design becomes much more automated. What previously was, very much manual is increasingly happening in few clicks nowadays. And implantology is one of the part of the restorative workflow. There are many to it. Now, there is a smile designing, which is a smile simulation, which is happening through AI. We just need to upload few clicks of a patient, and there are softwares like Smile Cloud, which is giving you a beautiful transformation of your patient, which increases the conversation between your patient and how the patient can really actually get convinced to the certain treatment what you are recommending them. So this is a visual transformation they would understand before and after, much before sitting onto the dental chair and we touching their tooth with the drill. In prosthodontics, AI is also going a long way through crown margin detection. We just have to upload an intraoral scan, which a tooth preparation. It will self-detect a crown tooth preparation margin and generate a crown of tooth on it. Tooth is already generated after detecting the margin. So now AI in orthodontic is another field where AI fits naturally because there is a huge amount of image-based analysis and repetitive planning is needed in this field. So cephalometric tracing, one of the most practical application, is automated. And instead of manually locating every landmark, AI can identify landmarks and generate the tracing much faster. But the speed is only one benefit. The larger opportunity to it is building to allow and analyze the data for the treatment planning over time. And when it comes to tooth movements, when it comes to tooth movements, where these aligner companies are using, this simulation for the movements is definitely through artificial intelligence. It also detects the peri-implantitis, even much before it is happening in the patient. These models are under research, and definitely it's going to go ahead and become a commercial model someday. AI on endodontics is also with caries detection, MB2 canal detection. There are a lot of AI in endodontics research which is there. Now, so far, AI has been helping us to analyze and to design, right? And but what happens when that intelligence becomes the control, when physically controlling our systems? So that is robotics in dentistry. And this is where the robotics in dentistry is leading, where it is self-drilling the implant in the patient.
site 30 here. And now we can see we're locked in on site 30.
This robo was
Now
there in
So now
25
that's correct.
IDS,
You can see how that number's getting smaller.
2025 IDS Germany.
As soon as we have that correct angle, it locks in. And now it wants me to move my positioning, which would be lingual. Now I'm locked in on my site. Even if I orient right or left, it's going to stay locked in on that site. So now when we're ready to drill, it will only drill as far as the plan's at. We can see.
So now we are delivering treatments with machine level precision. And because the intelligence behind the design flow is directly into execution, because we are giving a lot of data to the computer and it is executing for us seamlessly, right? So where are we going next? What is the future? If so much has happened in the field of dentistry when it comes to artificial intelligence, what is next? So there are multimodal AI, where there would be a lot of data together, uh, which is combined and would be analyzed by the patient, by the computer, when it comes to text, images, CBCT, scans, clinic records all together. Even if the patient is coming after 10 years, it would be retrievable and predictive that after 10 years, what would be his or her clinical outcome, maybe predictive. If the patient is a diabetic, what would be his periodontal conditions? That could be predictive through AI. And so when you're talking about all these, there are each and every aspect have a pros and cons to it. So when it comes to AI in dentistry, what are we getting? We are getting enhanced precisions, increased speed, and definitely predictable outcomes. We are automating a lot of stuff, and this is making our life much more easier. But what are the cons to it? There is a high initial cost. There's a lot of data which is going into it. Nowadays, people don't want to give data. They know that giving data is like, revealing the identity. But rest assured, all these are taken care of when it comes to medical data, and it's ethically cleared before training or even before uploading it onto the computers. There is a lot of training needed, and uh, there is a risk of job displacement when it comes to, but definitely no. AI is not going to replace a dentist. It's going to become a co-pilot for us, wherein our work is going to get easier and it's going to be on our shoulders, just a second eye to us. Wherever we are missing out onto any point, AI would be the one who would suggest that this is one which you are missing out on. So this is where AI would go ahead with when it comes to healthcare in AI. Now, AI model limitations, when you're talking about, yes, we need a lot of data. You need to understand what the model is actually learning. There is a black box nature of algorithms. So when it comes to training medical data, you need to have a white box algorithm. You need to know the reasoning out of why did you use that algorithm to train your data. And this is why this is one of the major reason that there are many major models which are under FDA and the HIPAA clearance, which have not they did not get HIPAA clearance. Reason being is because they were not explainable AI. And it should definitely be generalizable. It should not be confined to one ethnicity. Now, the biggest risk isn't that the AI is becoming intelligent. The biggest risk is that we become less intelligent in how we use it. And AI should augment clinical judgment. It should not be a replacement to what you are doing. This is to be taken care of when the challenges and when you are talking about ethical considerations. Uh, so the human and AI collaboration would be, it's more powerful, and AI can read the radiograph, but dentist will interpret it to the patient. AI is only reading the radiograph, but you are the one who is going to interpret it to the patient. AI is designing the crown, but a dentist would adjust its aesthetic and functions to it. What my speaker before me, Dr. Harshvardhan, said, that you should have an eye and you should have very precise eye to what a patient needs out of us, right? So even if you are designing a crown into a CAD system, you should know the anatomy well so that you are designing, you know, to carve virtually that tooth. And AI is helping us to definitely work and making our life easier, but you should have the complete hold and knowledge to it. AI is segmenting our anatomy, but we are the surgeons. We are planning that segmentation accordingly. So the future of dentistry is not just digital, but it is an intelligent workflow. And so my take home message in AI and dentistry is it's not going to replace us. Definitely, it's a second pair of eyes already told to you, and it's an intelligence system. It's you being with AI is you are ahead of times, and you know the system well, because this space of AI and technology is like, you know, running, like you have to pace up. You just can't be at very slow in learning. You have to pace up in how the technology is actually running and giving you better precise and predictable outcomes to whatever we are doing right now. And yes, the human expertise should be combined when it comes to machine intelligence. Your expertise is much appreciated, and it should be at the forefront. It should not be at the back front when it comes to back end, when it comes to using artificial intelligence into your practices. Thanks for your patience listening. And you could contact me through LinkedIn or email me for any collaborative AI ideas or anything related to digital dentistry or artificial intelligence. Thank you so much.
Thanks, Dr. Rabia, for throwing light on upcoming thing related to artificial intelligence, machine learning, and deep learning. And you has categorically saying that AI is not AI will never replace a dentist. Actually, it's always be a co-pilot, and it will equip and make a dental surgeon more you know able and more able to treat the patients and all. Anybody who want to ask question, they can ask question by unmuting their microphone, or they can ask question in the chat box by typing. You can also write to Dr. Rabia at Rabia Koya, the email ID which she has shown actually. rabiakoya@hotmail.com. So, Dr. Rabia, since we are slowly and gradually imbibing the newer technologies in India, and there might be inertia in us, but yes, we are gradually moving ahead. As already, the Prime Minister told that we are investing hard on AI in this Independence Day speech from Red Fort. So we are about to imbibe and we change our behavior and adopting the AI. But there is a anybody want to ask question, or then we'll move to our paper presentation competition for the faculties as well as the PGs. Thanks, Dr. Rabia. If you want, if you
Thank
have
you
a
so
time, you
much.
can stay with us. They are wonderful presentation by some faculties and PGs. If you have a time, you can stay with us. Otherwise, if you don't, you can leave. Yeah. Thanks again for sharing, giving your precious time on a weekend on Sunday. And we definitely try to reach out to our upcoming program as well, because
Thank you so much.
you did good work in AI actually. So that's why it's eye-opening for all our upcoming, say, newer generation dental surgeons. Thank
Thank
you.
you. Thank you both.
Yes, yes.
It's a pleasure. Thank you.
Yeah. So with your permission, we are moving to our paper presentation, Dr. Rabia.
Sure, doctor. Go ahead.
Yeah. So we have five presenters who would be presenting, two from faculty and three from PGs. The first presenter, Dr. Payal, she's, I think, not available, or she's not able to present the paper. So I'll invite Dr. Mrunal Mesham. Dr. Mrunal, are you there?
Yes, sir, I'm
Could
here.
you please unmute? Yeah. So Dr. Mrunal, please give your brief introduction and start your presentation. You share your slide, and we have fortunate that Dr. Aparna Dave is our jury member. She is judging and she would be asking question. Dr. Aparna, are you there in the meeting box?
Yeah, I'm there.
Yeah, Dr. Aparna is also there. So, Dr. Mrunal, could you please share your slide and start your presentation
Yes,
with
sir.
your
Yes.
brief introduction? We are keeping
Yes,
10
fine.
minutes for the presentation, 8 minutes for presentation, and 2 minutes for Q&A. So please make sure that it would be completed in a splitted time.
Yes, sir, sure, sir.
Yeah.
So I'm
Yeah.
not able to share the
Just wait.
document, but I
Let,
can.
let me just hold on. I'm giving you, maybe there's a problem. I'll make you a co-host. Just hold on.
Sir, it's in PPT format. Actually, they are asking for the PDF one.
You just try once again. Let's see if you would be able to.
Just one minute.
Dr. Minlal, if you're facing any problem, let us, take Dr. Manasa and then you can join after her, if
Yes, sir,
possible.
sure. That will be fine. Thanks a lot, sir. Thank you. Yeah.
Dr. Manasa, are you there?
Yes, sir. Yes, sir. I'm there.
Yeah. So would you able to share your slide and just give your brief introduction and you start your presentation?
Definitely, sir. Just a moment.
Mm-hmm. Yes, your slides are visible, Dr. Manasa. Could you please unmute? Your microphone is still mute mode.
Am I audible to everyone?
Yeah, you are audible. Your slides are visible. Carry on.
Okay,
You just give
great.
your brief introduction. Yeah.
Definitely, sir. Good afternoon to one and all present here. And it's indeed my privilege, and I thank the organizing committee for selecting my particular case report for a live streaming. With this, to introduce myself, I'm Dr. Mansa KN. I'm working as an assistant professor in Department of Conservative Dentistry and Endodontics from Okkaligara Sangha Dental College and Hospital, Bangalore. And currently, I have enrolled for my PhD course as well, and currently I'm in the synopsis presentation status, and I'm doing under Rajiv Gandhi University of Health Sciences. So with a small introduction of mine, I would like to start off with my case report titled Conservative Smile Rehabilitation in Severely Generalized Dental Erosive Wear Using Injection Molded Direct Composite Restoration, which is a case report. Just a moment. So coming to the introductory part, so as we all know that the non-carious cervical lesions are one of the most commonest dental conditions that we come across, and this is definitely going to impact both aesthetics as well as function. And we look at the literature about how the prevalence rate of the dental erosion is. So there are two things which I would like to emphasize here is one, in the adult or a general population. So it is reported prevalence of about 44 to 48%, wherein it's mainly because of the strong habits like the carbonated drinks or citrus fruits and etc. And looking at the last one, where we look at the age factor, how predilection or how prevalent it is in the particular age group, definitely we look around in the age of more than 45 years of age, ranging up to 79.7%. And this is definitely going to be a cumulative exposure and an age-related vulnerability. So with this, what is that we come across when the patient is having a non-carious cervical lesions? Definitely, it is going to impact the aesthetics, as well as there is going to be a functional impairment as well. So coming to some of the etiological factors, as we all know that erosion can happen either because of the intrinsic factors or extrinsic factors. Coming to some of the intrinsic factors, vomiting, regurgitation, or rumination, and coming to extrinsic, it could be because of diet, medication, and environmental factors. And also because of the behavioral, cumulatively, there could be a dental erosion, which could cause. And one key important factor that I would like to emphasize is how important it is for us to have an early diagnosis of dental erosion. So with this, definitely when there's an early identification of dental erosion, we could do dietary modifications, improved oral hygiene, and definitely a prompt consultation is also going to be early diagnosis of any such, not just a non-carious cervical lesions, anything that patient has having which patient is not aware of. It would lead to always a early intervention is better than a delayed treatment. So definitely in my particular case, since it was a severe dental erosion which had occurred, definitely it was a more invasive, and also cost factor is also going to increase. So early intervention is always a key in maintaining oral health and avoiding severe dental complications. So this is again my particular, the image that is seen is an intraoral photograph of my particular patient. And here what I get to see is a severe dental erosive wear, cumulative of both cervical abrasions as well as attrition. And here I get to see a structural tooth loss. There was an aesthetic impairment, and also there was a functional decliner. So these are the preoperative intraoral photographs of my patient. So one is a front view and mesial and the distal view. And these are again the smile photographs of the patient, which is a preoperative. So then what we followed is a digital intraoral scanner. Basically, intraoral scanners were used and a digital wax mock-up was done in order to explain the patient how post-treatment the treatment outcome is going to come, be it a direct composite restorations or be it an indirect or whatsoever. We wanted to assure that how the final aesthetic outcome, what patient has come for seeking would look like. So with this, I would like to start my case presentation where patient named Hina, age 57 years, she came with a chief complaint of poor appearance of her teeth, reported with short teeth, spacing between teeth, discolored restorations in upper and lower front tooth region, and duration is about 5 years that she wasn't happy about this. And she also desired expression of tooth whitening and also aesthetical improvement. A little bit about the history of presenting illness of the current situation, why she's come for, is because earlier she had severe acidic beverage and soda exposures, which has eventually led to an extrinsic dental erosion. But in her initial consultations at the private dental hospital, she discontinued these causative factors, and she had also got some of the composite restorations for aesthetical purposes. But what happened is eventually when she has come to my hospital, the restorations were fractured, it was partially dislodged, and definitely it was an unsatisfactory aesthetic appearance. And she also expressed that over a period of time, the condition of her teeth has progressed. It's actually worsened is what she was trying to say. And she emphasized that already that she had a very severe tooth loss, and she definitely didn't wanted any sort of invasive approaches, like be it a veneer, indirect veneers, or be it a full mouth rehabilitation, or be it the full coverage crowns. So all she wanted was absolutely without removal of any tooth structure, please improve my aesthetics, is the only request that the patient had when she visited my particular hospital. So this is OPG, which was done in order to check for if there is any periapical changes or the overview of all the dentition, and everything looked all right. With this, coming to the clinical examinations and some of the findings, definitely there was no extraoral examination. Everything looked all right, but aesthetically, definitely it was compromised. And coming to intraoral examination, definitely there were dentinal exposures in multiple teeth with the structural tooth losses. There was some erosion and abrasion in posterior and anterior regions, which was generalized. There were fractured composite restoration in the tooth numbers which I've mentioned, dislodged restorations in so-and-so tooth. There was grade 1 mobility in one particular tooth, which was still okay. And there were some prosthesis. And definitely I would like to emphasize the last point, which was a deep erosive lesions, which I I could see in most of the premolar regions of all the 4 quadrants. So what investigations we followed was definitely, as I said, the OPG was done, everything looked all right. The vitality was next, which was assessed here, where we tested for cold test followed by electric pulse testing. And definitely the normal vital pulse status gave us that it's a green signal that all the tooth are responding well. So with this, I came to a diagnosis of generalized erosive tooth wear compounded by attrition and abrasion, resulting in basically, as I mentioned previously, there was a structural loss of enamel and dentine, there was fractured and dislodged restorations, reduced vertical dimension, and definitely aesthetic and functional compromise were there. Before I could come up to the final treatment outcome, I would just like to just overview of what are the treatment modalities that we can do in terms of dental erosion in cases. So definitely when it is a very mild erosive cases, we can think of a preventive or a non-invasive treatments like fluoride applications, remineralizing agents, and adhesive sealants. When it comes to a severe damage, definitely we can think of either a direct composite restorations or indirect restorations or full mouth rehabilitation. But all of these are definitely going to be associated with dietary and behavioral changes as well. So various treatment strategies which I could have basically, in my particular case report, if you would ask me, if not a direct composite restoration, what are the other treatment modalities that we could think of, is definitely indirect restoration, full coverage crown, a dull technique, basically where it helps in the improving of the vertical dimension, followed by the full mouth rehabilitation, followed by occlusal rehabilitation. So this is an overview of my clinical workflow. I would like to show in this pictorial representation where definitely a thorough oral prophylaxis was done, a rubber dam isolation, all the faulty restorations were removed. And as I've mentioned, the deep caries lesions, we basically followed an indirect pulp capping procedure. And after 6 weeks of a follow-up, again, the vitality check was done where the tooth was responding normal to it. And a preliminary shade matching was done. And the particular shade that I chose for this patient was A3. And a digital workflow wherein intraoral scanners and the digital wax mock-up was done, followed by which a fabrication of the stent was done, which using a GC hexaclear, followed by which an injection molding technique was followed, and the finishing and polishing was followed by. So the key important materials which I used in my particular case was definitely the Genial Universal Flow. It's an injectable flowable composite, and followed by a clear vinyl polysiloxane matrix, which is an hexaclear, again from GC. This is not definitely a GC flagship, but these products are extremely excellent when we think of doing an injection molding direct composite restorations. And definitely, lastly, I used a G Premier Bond. So this is altogether my key materials which I've used in my particular case. And this is an armamentarium setup which we had done so that it is going to help us without a hassle. We could follow the workflow well. So with this small introduction or a small brief of injection molding technique, when it was actually a pioneered by Dr. Terry Douglas and also John Powers. And this was again refined by Dr. Sachin Shah and Junaid Malik. So basically, how does this injection molding technique workflow is basically we have a diagnostic wax mock-up, digital mock-up can be done. Then using transparent polysiloxane materials, we can fabricate a stent, followed by which we will be doing an injection molding technique. As you can look at this particular image, we can do individual tooth injection molding technique. And if we are expertised and we are highly confident, we can do alternative teeth. So technically, we can do 3 teeth at a time where we can isolate every alternative tooth and work on the alternative tooth. So this is, again, I would like to just show again the preoperative photographs where you get to see a lot of erosion, attrition, and abrasion. And there were faulty restorations, which we can see opaque whitish composite restorations, which were existing when she visited my office. And these are the follow-ups. And exactly, it's been 1 year of a follow-up that the patient I've finished my treatment. And this is even before the oral prophylaxis. There's an excellent self-cleansing. The oral hygiene is amazing. And you can see the post-operative results. And this is a 1 year of follow-up, which I would like to emphasize. And this is an occlusal view of the lower mandibular arch, which is before and then after. This is the maxillary arch. And this is again the smile photograph of before. And this is the after post my treatment. So this is again the before and the after of the patient. So with this, I would just like to emphasize with this article, which I have quoted here, that actually in earlier times and even now, the conventional flowable composites cannot be used for this kind of a workflow. Definitely with the lot of chemistry and the material sciences, definitely we can still consider in current situation and also in the future perspective, definitely these kinds of bulk fill flowable composites as a promising material which we can consider for aesthetic dental procedures. And coming to the discussion part, I would just like to emphasize some of the strengths of my particular case report, and there were a few limitations as well. So the strengths of it is basically a conservative, and it's definitely a time-saving approach. It is repairable, it is cost-effective, and absolutely minimal or non-invasive approach it is. And immediate aesthetic improvement is going to be seen. And some of the limitations which I would like to emphasize here is it technique sensitive, potential wear over time. It's a monochromatic restoration, and it is not ideal if you're considering or if a patient requires some sort of anatomic layering cases. So I would like to once again emphasize that this cannot be used for every patient which walks into our clinic. It depends on the age of the patient, the characteristics, the layering that we would like to offer so that the aesthetics are going to be improved. So an ideal or a right case selection for an injection molding technique is very, very important. Only then we would achieve a good aesthetic results. So how do I actually overcome my limitations I've previously mentioned in my slides? Definitely there is a check of the occlusion and the aesthetics were checked, scheduled follow-ups, and definitely I would be monitoring, and I've been monitoring every 3 months for a year now. And definitely I'll be monitoring for the next 2 to 3 years in order to basically inform the patient as well that she should come for a follow-up periodically so that we could do a polishing touch-up so that there won't be any discolorations over time, because we know any direct composite restorations wear off, or probably there is a discoloration of the restorative material, so which could be overcome when she comes for a periodic monitoring and follow-ups and polishing as the polishing of the restoration. With this, I would like to conclude that direct composite veneers are a viable option of severe erosive wear, and the most important thing is a case selection is very, very important. So this case, a patient was extremely delighted with the improved aesthetics, function, and definitely she appreciated the relative low financial cost of treatment. And with 1 year of a follow-up, the restorations remain absolutely stable, aesthetically pleasing. And these are my references of the articles which I've referred to. And this was a small testimony what my patient has given for the treatment that I've done to the patient. And thank you so much for your valuable time and patience for hearing out my presentation.
Thanks, Dr. Manasa. Dr. Aparna, if you want to ask any question, I think Dr. Manasa.
Yeah, Dr. Manasa, it was a good presentation.
Thank you so much.
And actually not many questions, but I just wanted to know how long these restorations would last. Like, what do you think? Because most of the time, like what the problem is, if it chips off or it comes out, that is where things go wrong, even though we try to help out the patient. But what do you feel that what would be like, you have put that point, like there are potential where over a period of time, you have put your limitation over there.
Yes, ma'am.
So
I would like to emphasize on this particular point why we have chosen this particular material. Again, as I said, it's not a flagship of any particular product as such, but amongst the commercially available products in the current scenario, like when in terms of bulk fill flowable or bulk fill packable composites, the composite that I have used here is a Genial Universal Flow, which is an excellent wear resistance is there because it has a good nano filler particles like barium filler particles is there, and it has a full coverage silane coupling agent is also present in this, ma'am. Because of its good wear resistance, it has a good gloss because of its thixotropic property in the chemistry perspective. Definitely it has a long-term wear resistance compared to any other conventional composites. And coming to the second point, as clinically when we think of a direct composites chipping off, it's again there is nothing to lose for us, ma'am, because we have not prepped the tooth here. We can still repair it because again, you can just follow a same etching and bonding protocols, and we can repair the restoration even before we think of intervening further.
Okay, thank you.
So, yeah, thank you so much, ma'am. And I just wanted to add a last point. You asked me what is the time span or how long these kinds of restorations will sustain. Ma'am, well, there are couple of cases which I've done in this particular like injection molding direct composite veneers. It's been like a couple of patients which I've been doing a follow-up of 5 years, 6 years. They're still absolutely doing well, ma'am. Even without the polishing, they're still happy with the aesthetics or the color change, or absolutely there's a very minimal discoloration which we could notice, but the patient is still saying, I'm all right, I'm absolutely doing well. So with this, I would like to conclude that definitely the final finishing and polishing that we would like to do after our treatment plays a very, very important role. So upon our final restorations, we need to call the patient immediately after 24 hours, do the final finishing and polishing, which plays a very important role for the longevity of the color stability, ma'am.
Okay. Thank you, sir. Well said.
Yeah, thank you so much,
Yeah.
ma'am.
Thanks, Dr. Manasa, for
Welcome, sir.
giving your presentation. Yeah, thanks. So, with your permission, Dr. Manasa, we are going with our next presenter, Dr. Mrinal. Dr. Mrinal, are you there? Could you please share your slides?
Yes, sir. I'm here.
Mhm. Yes.
So is my screen is visible now?
Yes, it's visible.
Yes. So a very good afternoon to all the respected dignitaries present here on this virtual platform. Myself, Dr. Mrinal Meshram, and I'm working as an associate professor in the Department of Oral Medicine and Radiology in Sharad Kaur Dental College. It has been... Hello, am I audible?
You are audible.
Yes, sir. Thank you, sir. So it has been correctly said that first we make our habits and then our habits make us. So in this era of artificial intelligence, we can say, and machine learning, we can say that first we make our tools and then our tools make up. With that, I'm here to present a study, a hybrid spectral attentive network, that is HSAN, for oral cancer detection. Coming to the introduction, we all know that the burden of oral cancer is complicated in India by the late stage diagnosis and low survival rates, where 70% of the oral cancer cases are reported only in the advanced stages. Also, there are pre-malignant lesions like leukoplakia, erythroplakia, and lichen planus, which are associated with the development of the oral cancer. Now, what was the need of this study? The early detection of oral cancer is crucial. However, the currently available diagnostic methods are invasive, subjective, limited in accessibility, and therefore there is the need for other resources. Now, the rightly glooming model is Raman spectroscopy. Now, Raman spectroscopy is presenting a powerful non-invasive approach that can visualize the molecular level biochemical changes in the tissues. The other techniques are also there, like Raman fluorescence, infrared spectroscopy. They are also allowing non-invasive real-time analysis of the tissues by capturing unique biochemical and molecular changes which can appear in the normal precancerous and cancerous stages. So if we see the background and clinical need, early lesion may be asymptomatic or clinically non-specific. Conventional diagnosis involve clinical examination followed by biopsy and histopathology. Now here in this present study, we are highlighting the need for rapid and objective non-invasive approaches, especially for the resource limited settings, and these resource limited settings are more in India. Yes, it is all possible with the Raman spectroscopy, but the challenge is, this challenge with the Raman spectroscopy is they are high dimensional and susceptible to the noise. So the aim of our study is to develop a hybrid spectral attentive network for Raman-based oral cancer classification. So first conventional, then then Raman spectroscopy, then AI modified Raman spectroscopy, and then our model, that is hybrid spectral attentive network. Combine complementary information from 1D Raman spectra to 2D spectrograms, then use of attention mechanism to capture the local as well as global relationships in the spectral data, then compare the HSAN with the LXNet, VGG16, VGGNet, and ResNet 50. Then to evaluate whether the multimodal feature fusion improves classification of the performance. So our study flow is comprising of Raman acquisition, then pre-processing, 2D conversion, dual path of our hybrid spectral attenuation network, and then future fusion, and then last to the classification. So HSAN architecture, it's a dual branch multimodal deep learning framework. It will be comprising of 1D spectral path associated with the 2D spectrogram path, then attention module, which will be comprising of self-attention transformer, which will be of local as well as global dependencies, and then the spectrogram input. So it will be for the multi-cancer oral detector will be possible. So here what we have done, the study we have conducted in the 950 Raman derived samples. So it was comprising 500 cancerous and 450 non-cancerous samples. Pre-processing included baseline corrections, normalization, noise reduction, spectrogram generating using STFT, and then it resulted into the patient level 5-fold cross validation, which we used to reduce the data leakage, which is the one of again downside of the Raman. So we compared it with the other models like LXNet, VGGNet, RESNet. So in that, in LXNet, the accuracy was around 88%. In VGGNet, it was around 90%. In RSNet, it was about 92%. In our model, it was around 94%. So if we summarize it, we can say that HSN achieved the highest accuracy, precision, and recall among the evaluated models. The reported recall of 97% indicates that strong identification of the positive cases, and our study reports that the stable validation performance and rapid convergence over 10 epochs. So if we see the interpretations of our findings, the improvement over RSNet 50 supports the value of combining 1D spectral and 2D spectrogram information, which we have done in this model. Then self-attention is designed to capture the local as well as global relationship across the spectral sequence. Then also MobileNet V3 small, which provides a lightweight image pathway consistent with the paper's proposed portable or resource limited applications. So this model is compatible with the portable and resource limited applications too. Multimodal feature fusion is the central technical contribution. Okay, so we are getting synergistic or the combined effect of all this. Now, if we go for the critical evaluation of this, the strength will be, it is a novel dual branch architecture, then it is near balanced data set, then patient level is 5-fold CV, high recall, strong performance, and potential for non-invasive screening. Yes, also there are some limitations like database is the modest for clinical deep learning, limited detail on the patient demographics and clinical setting, no independent external validation cohort is reported, prospective multi-center validation is needed, and some reportings or references are inconsistent, which are appear in the manuscript. We have published this study actually. From that manuscript, we can report that some references are not relatable. So if we see the potential clinical relevance, non-invasive molecular screening of the suspicious oral lesion, potential real-time support when Raman spectroscopy is integrated with the portable devices, possible assistance in identifying the cancerous tissue as well as the surgical boundary guidance was there, then potential value in settings with limited access to the specialist pathology services, and current evidence is of model performance evidence. Now, the future scopes are the larger independent and multi-center data sets are needed. Prospective validation against the histopathological references standards will be needed. Integration of the patient metadata such as age, gender, and lesion location. Then portable Raman AI platform for the resource limited settings, and robustness testing across the instruments, acquisition conditions, and real world noise. So we can take the take-home message that the accuracy was around 94%, the precision making was around 95%, and the recall was around 97%. So HSAN demonstrate that fusing 1D Raman spectra with 2D spectrogram features can improve the oral cancer classification compared with the evaluated deep learning baselines, which will be a promising proof of concept where larger clinical validation is the next essential step. That means a large scale studies shall be conducted. So these are my references. Thanks a lot. Thank you so much for listening.
Okay. Dr. Mrunal, it was a good
Yes, ma'am.
presentation. But
Thank you,
what
ma'am.
I just wanted to ask you, I'm inquiring about it. Like,
Yeah.
you have utilized for both pre-cancer as well as cancerous lesion, your
Yes, ma'am.
study.
Yes.
So suppose it's a heterogeneous lesion, or in some places it's just hyperkeratosis, some area probably, or we can say speckled leukoplakia for that matter.
Yes, ma'am.
Is your format or is your model applicable over there if when we have maybe hyperkeratosis in one area, otherwise other area maybe it is carcinoma in situ or something like that?
Yes, ma'am. It will be very much useful in that case because it catches the molecular level studies where we can say that when the protein changes are there, ma'am, or the molecular changes are seen in the tissues like molecular level biochemical changes. So it is catching those also.
Okay, and if there's some
So,
inflammation, intense inflammation, will
yes,
it
ma'am. It
alter
is
the?
also. Yes, because here the spectral fingerprint formula is there. So when, as you are saying, the oral cancer, it will be associated with the molecular changes involving protein, lipids, and nucleic acid. Now, these changes can generate the spectral fingerprints that help to distinguish between the healthy, dysplastic, and malignant tissues. So healthy, precancerous, and cancerous. So the technique will be, ma'am, label-free and provide the real-time molecular information, giving the differentiation between normal, dysplastic. In dysplastic also, ma'am, there are stages like
Yeah.
CA in situ, then the mild changes, moderate changes, right? And then the malignant ones.
Yeah. And if there is surrounding additional inflammation because of some irritation or something, that will not interfere with your interpretation.
No, ma'am, that won't be interfering. Actually, that depends on which kind of data we are feeding. है ना? Like in biopsy, which the site is important. So here,
Yeah.
the images or yes. So it is also important, ma'am. It is just a tool or a very good maid of ours to whom we have to give the perfect instructions so that she can work better.
Okay. Thank
Yes, ma'am. And ma'am, honestly speaking, if you are like you ask the question on that topic, that's why it's a PhD study, ma'am. And when
I
in some
understand.
cases when we are talking about limitations, so it was able to differentiate between lichen planus and leukoplakia if it is totally different, but it was not able to differentiate between the plaque type of lichen planus and the leukoplakia, which clinically looks same.
Almost similar. Yes.
Yes, ma'am. Yes, ma'am. So it was so honestly, I can say our eyes and our fingers for the palpation will be always better than AI.
Yeah, fine. Okay. That's a good way.
Yeah.
Thank you.
Thank you, ma'am. Thanks a
Thanks,
lot.
Dr. Mrunal, for sharing your presentation.
Thank you, sir. Thanks a
So,
lot.
with this, thanks for the time constraint. I'm moving to our next presenter, Dr. Anisha Malik. Dr. Anisha, are you there? Could you please unmute and share your slide?
Good afternoon, sir. Am I audible?
Yeah, you are audible.
Okay, I'll just share my presentation.
Give your brief introduction and please try to consider about the time constraint actually. Try to
Sure.
finish as per split time. Yeah, okay.
Okay, so
Your slides are visible.
my slides are visible. Okay. Good afternoon, respected panel of judges and my dear colleagues. I'm Dr. Anisha Malik. I'm a postgraduate resident from Department of Prosthodontics in Army College of Dental Sciences. And today I'll be presenting my paper, Iris and Artificial Intelligence for Objective Iris Shade Selection in Ocular Prosthesis Fabrication. So, iris shade matching is essential in a prosthetic fabrication. For patients who have lost an eye due to trauma, cancer, or congenital conditions, an ocular prosthesis is more than just a replacement. It is a part of their identity. And the most critical part of that process is the iris. If the iris shade is slightly mismatched, the prosthetic eye looks unnatural. That affects the aesthetics, confidence, and the emotional well-being. So why do we need to develop a new method? So the conventional methods of painting an iris, of creating an iris prosthesis is hand painting. The iris shade selection is mostly done by visual guesswork. Yes, I said it correctly. It's guesswork. It depends on the clinician's observation, lighting conditions, and the subjective judgment. There is no true standardization. The human iris is incredibly complex. It has multi-layered pigmentation, radial streaks, scripts, collarettes, and the limbal ring, making the shade reproduction and accurate reproduction a little bit challenging. And it is very technique sensitive. There are variations, and there's a lack of standardization. So I asked myself, why are we relying on approximation when artificial intelligence can deliver precision? So the objective was to achieve accurate and objective iris shade selection for ocular prosthesis fabrication, to reduce the chair side time and simplify the shade selection process, and to provide the RGB values and detailed shade mapping of different parts of the iris. So the solution, our AI known as iris. So the sample size we took was 20,000 images. The first step of our workflow was the database collection. Photographs of the iris were collected under standardized lighting conditions, that is, using a polarized lens, a neutral grayscale background, and a uniform camera settings. We captured the iris because in a uniform camera settings, because with the AI, quality input means quality output. Step 2 was the data segmentation. We isolated the iris from the surrounding structures using a UNet segmentation analysis. The images were labeled by the AI and masks were created. The third step was building the AI model. So our AI model consisted of several our system was consisting of several platforms. I'll just divide it into 5 classes. One was the UNet, which finds the iris. The BC loss teaches the AI how to improve during the training. The IOU measures how accurately the iris was found. Affine transformations were used to help the AI handle different types of photographs, because photographs can be a little tilted or right or left. The K means clustering analysis were used to identify the most important iris color. So the model prototype labeled the masks and recognized the iris, and then created a visual shade palette and detected the RGB and the hex values. I'll be showing a short video on how the AI works. So our AI is connected to a drive system on which, as you can see, there's an image path and the model path. We can just upload the images from our Google Drive, and the AI and we just need to execute the program. The program will give you the iris colors in 3 seconds. So as we can see, we just predicted the base colors in RGB, hex values, and the CLAB values, along with the visual palette and where the color palette will be there in the iris. So we are just using another example. We just uploaded another photograph for the same and ran our program. So as we can see, there are shade 1, 2, and 3, 4 depicting different parts of the iris and where these colors will be. So as we can see, there are RGB values, hex values, and as well as the CLAB values. And we have also depicted a visual palette so that it is easier for the clinician to match the colors of the iris and hand paint it. So for this process, you don't need to have the patient sit there. You can just easily match the colors of the iris and hand paint it in the laboratory. So the current limitations of our AI is the current accuracy is 86%. For an AI to be more accurate, we need a large data set. The development requires an extensive coding to build the model, and there's a financial limitation for the same. And we are in the process of integrating this AI into a phone application. So the current progress of the AI, we have currently patented the process, and we are undergoing the patent process for the same. So in conclusion, I would just like to say, when we are replacing an eye, we are not just replacing a patient's confidence. We are replacing the life. Iris is not just a dental innovation. It is a digital transformation, maxillofacial and ocular prosthetics. It is a faster diagnosis, better aesthetics, higher patient satisfaction, and a future where precision replaces guesswork. We are creating the bridge between prosthodontics and artificial intelligence because that bridge is valuable. When you restore an eye, you're not restoring appearance, you're restoring iris. These are my references for the same. Thank you so much.
Dr. Anisha, it was a good presentation, but I just wanted to know whether you have given iris prosthesis using your model which you have proposed.
Currently, ma'am, yes, ma'am. I have given one iris prosthesis with the same, and I have distributed this program to another maxillofacial prosthodontists also in the field who are currently using this program as a trial. So, as we are still undergoing the patent process and we have to increase our accuracy for the same, we have limited the distribution to the of this software currently. So it is being used by 3 prosthodontists currently, one being me, and a few prosthodontists who are practicing outside of my hospital.
And how are the results? Like you all found it to be
so the feedback
or are you facing any difficulty? Because later in future, whenever you distribute it or you share it with people, so I just wanted to know, are there any further limitations for this particular model?
So the further limitations depend on the clinical expertise also, as I'm a postgraduate student and I'm not yet very precise in making an ocular prosthesis. I definitely faced difficulties, but the good part was I didn't have to make my patients sit and wait for 3-4 hours while I just painted the iris. I just had everything at my lab. The clinicians who were more proficient in this, they were quite happy with the results because they did not need to have the patient sit there, and overall they were able to reproduce the iris accurately. So there was a patient satisfaction also, but we need to undergo more case studies to actually prove how efficient this is.
Fine. Thank you.
Thank you so much, ma'am. Thank you so much, everyone. Have a good day.
Yeah, thanks, Manisha. So we have a next presenter, Dr. Devika Jay Ranjan. Dr. Devika, are you there?
Yes, I'm here, sir. Good afternoon.
Yeah. Very good afternoon. Very good afternoon. You please share your slide.
Yes. Okay. So I'm facing an issue with
Wait.
hello. Sorry,
Yeah,
sir.
yeah.
I just faced a small technical glitch. Just a moment. Share. Okay. Is my screen visible?
Yes.
Okay. Perfect. Right.
Okay. Yeah, perfect. You start. Yeah.
Yes. Sorry about that, everybody. Good afternoon. My name is Dr. Devika Jayarajan. I'm an oral pathologist, and I'm currently working as a senior research fellow as well as pursuing my PhD. I'm in the last stages of my PhD as well. I'm doing it with Yenapoya University. And today I will be presenting a study that I have done, wherein we faced a practical difficulty regarding a case, and we took it up to come up with an IHC panel for the same. So the name of my study is, it's to validate the P40, Vimentin, and EMA markers, immunohistochemical markers, as a diagnostic triad for oral spindle cell carcinoma. Okay. Yes. So the morphological mirage. So spindle cell carcinoma, it comprises nearly less than 1% of head and neck tumors that we find. And it has a very perplexing presentation Usually it is seen with a malignant spindle cell component that truly mimics a sarcoma that we might see in the connective tissue. So the issue with this was the fact that when we receive samples where the epithelium has been denuded or it is ulcerated and there is no clear squamous epithelium seen, these features overlap and it is very difficult to identify which is which, a sarcoma or a carcinoma. So what are the clinical stakes of making a misdiagnosis becomes the question, and that lies wholly upon the treatment that we met out. So in case of a sarcoma, it is very straightforward. We excise and we try to maintain our margins. But when we come to the SPCC, which is the spindle cell carcinoma, there is a radical surgical intervention that is required because there is a high chance of metastasis and removal of the associated lymph nodes with R&D, that is radical neck dissection, becomes the standard of treatment. And also the overall survival rate of oral spindle cell carcinoma is only 27.5%. So we are looking at a highly aggressive tumor, which needs to be met out a highly aggressive treatment and not otherwise. So there is zero margin for diagnostic error. So what is the failure of conventional markers that we can see? So when we generally suspect a case to be coming of squamous epithelium or squamous origin, the first marker that comes to mind is cytokeratin. But using cytokeratin alone, it has always been very ambiguous and it can often be misleading. So the employment of other markers becomes even more relevant in that case. The thing with cytokeratin is the fact that the expression also declines with decreasing epithelial differentiation, meaning to say as the tumor moves from one form into another form, or a different phenotype from one phenotype to the other phenotype, the expression of CK also tends to dip. So aberrant expression of other mesenchymal elements like SMA S100, that also further confounds the diagnosis because there is a chance for all of them to be weakly positive or for none of them to become positive. So the takeaway is that a negative epithelial IHC result using standard markers alone cannot rule out spindle cell carcinoma. So about our triad, this was a novel immunohistochemical panel that we came up with to try and unveil the tumor that we are dealing with. So first was P40, which is a nuclear-specific immunohistochemical biomarker. The other one was Vimentin, which is a universal biomarker. And then epithelial membrane antigen, which is a cytoplasmic or a membranous specific biomarker. So this is how we characterized the three markers and their origins. So P40 is a squamous or an epithelial origin biomarker, and it is truly positive for squamous origin. It has been employed in largely lung carcinomas and adenocarcinomas. Its study is not explored much when it comes to the oral cavity. Epithelial membrane antigen, it retains positivity even when CK is lost. And Vimentin, it indicates the epithelial mesenchymal transition which may be taking place as the phenotypes move between each other. So it maintains cellular integrity, and that is the reason for choosing it. So validating the panel or the clinical cohort that we picked up. So this was a retrospective review, and it involved two institutions. Over the course of 2 years, we came up with only 10 cases of oral spindle cell carcinoma owing to the rarity of the tumor, and this was evaluated by 3 independent pathologists. So we found that this tumor was largely seen in males, and that too in the 4th to 5th decade. And it had 11:1 ratio, male to female ratio. And it was also complemented by the fact that these patients also had a robust habit history involving alcohol usage and tobacco consumption. Clinically, we found that the TNM staging also corresponded largely to PT1 or PT3, which involves the tumor size. And in some cases, nodal involvement was also seen when conferred with the oncopathology department. The site which was largely seen was the tongue and the buccal mucosa. As positive and negative control, for P40 and for EMA, we used normal squamous mucosa from the oral tissue. And endometrial tissue was used as a positive control for Vimentin. Yes. So marker 1 is Vimentin, and we found that it was strongly positive. There was no negativity, no negative positivity anywhere across all the tumors, all the 10 cases that we saw. We found that 70% of the cases that we picked up were strongly positive and 30% were moderately positive. So this confirmed the fact that the tumors were indeed expressing a shift from a squamous phenotype towards a mesenchymal phenotype. But because it is universally positive, whether it's a carcinoma or a sarcoma, it required other markers as well to validate this. The second marker was epithelial membrane antigen. So 80% positivity was seen, where 30% was moderately positive and 50% was weakly positive, and 20% was negative. 2 cases did not pick up the stain. So EMA, it's a structural barrier. It serves on the protein that is present on the glandular epithelial cells, highly positive in carcinomas, and even positivity can be found in carcinosarcomas as they move from one phenotype to the other, like I said. And they're more consistently retained even through dedifferentiation that occurs. So EMA positivity was seen in these cases, especially in a mucosal-based spindle cell mass, which was found in all these cases. There was a small squamous component, as you can see, and there was also transition where the cells were within the connective tissue. They were picking up a spindeloid shape, and they were turning out to be positive. The next was P40, which was of key interest actually in this study. And it found that 30% was strongly positive, 10% was moderately positive, and 20% was weakly positive. So across all the cases, we did find that there was a positivity that was displayed, which confirmed the diagnosis of spindle cell carcinoma, because we did go back and we did confer with the clinical records and oncopathological records as well. So the clinical insight was that P40, it's highly selective for squamous epithelium, and it indeed confirms that the spindle cells are of a squamous epithelial origin and not that of a sarcoma. So the efficacy of this triad is that no single marker can give you a confirmatory diagnosis. Vimentin it will universally catch the transition across a carcinoma or a sarcoma, whereas EMA and P40, they indeed go ahead and confirm the squamous lineage. And together, whatever ambiguity remains as to the diagnosis of the case is resolved. So what is this epithelial mesenchymal transition becomes the question. So there are 3 hypotheses that talk about spindle cell carcinoma and its origin. The first is whether it is a collision tumor, 2 separate tumors that come together, or whether it originates from a monoclonal cell, that is monoclonal group of cells, which undergo transition, or whether it is just a tumor with a hyperactive or an atypical reactive stroma. So over time, they have literature has come to a consensus that it is indeed just a monoclonal group of cells that, with aggressiveness and progression of the tumor as it increases, as it picks up, it just undergoes dedifferentiation with regard to the phenotype that is expressed, and it requires a much more radical approach in treatment. Okay. So how do we translate our findings to a surgical strategy? So if a tumor is identified as a spindle cell neoplasm on hematoxylin and eosin staining, where the surface epithelium is denuded or ulcerated, we can apply this panel, P40, Vimentin, and EMA. And based upon the results, we come up with 2 diagnoses. One is that of a primary sarcoma, which is also rare. It's a rare entity that is found in head and neck malignancies. And the other one is that of a spindle cell carcinoma. Like I said, the key action remains upon the treatment that is met out, one being local excision and the other one requiring radical surgical resection and radical neck dissection. So it identifies the necessity for nodal involvement also or management based on the diagnosis that is provided, because it has a high tendency to metastasize. So precision over morphology. So this study, it was really eye-opening because the whole study was based off the fact that there was a case that was received, and the case was passed between departments. Oncopathology and oral pathology came together and tried to work out what it was. And the development of this panel also was done with relation to a lab. So the idea is that this study is taken forward. It is taken forward with more cases included into the cohort. And over time, it is possible that we are aiming to establish a standard panel as available with different labs and make it a standard kit that is available for purchase and for usage for patients who are diagnosed with the same. So it is not a luxury that we should be thinking about. It should be something that becomes a norm when we are faced with such a scenario. This case, I mean, this has also been published, the study. And thank you for your time.
Thank you, Dr. Devika. And I had to ask you though, this tumor, though it's quite rare in ulnar cavity, but we do see the cases, and it is good that you're focusing on having a kit or having a panel of markers for this.
Yes,
all I wanted to ask is sometimes spindle cell carcinoma shows a loss of or a focal there is a loss of focal expression of epithelial markers.
Yes.
So how do you handle it? Probably if you could just repeat that in case it is negative for P40.
Yes, ma'am. So that's a very good question that that you've asked me, ma'am, because generally that is seen when hello, am I audible?
Yeah, you're
Yes,
audible.
okay.
Please continue.
Yes. So generally, that is a problem that we encounter when the tumor progresses, when it has reached a stage where almost all the cells have undergone a transition. So if I'm understanding correctly, at that point is when all the epithelial markers tend to express negativity. I think that was the question, isn't it, ma'am?
Yeah. I
Yes.
just wanted you to repeat that part.
Yes. So what we did in this study is that none of the cases in our exclusion criteria, we did not include any cases that have undergone, also with regard to chemotherapy and radiotherapy, patients who have undergone any form of treatment, there is a chance for them to also express the spindeloid shape and lose all these epithelial markers that are generally expressed. Yes. So what we picked up were incisional biopsies before the first biopsy that came to us, and incisional biopsies, and we ran these tests where you can also see an epithelial. Some of the cases did not show an epithelial component. It was pure stroma with the spindeloid shape. But in cases where treatment has already been met out, or where they have undergone radiotherapy, or it is a true sarcoma, these components were not expressed. So in that case, you will treat it as we see it, which would be as a sarcoma. But generally, 9 out of 10 cases, before it reaches that point, the patient would have already reported with the mass, ulcerated mass, and an incisional biopsy would have been done. So it is generally discovered in the early stages itself.
Okay.
Yeah.
Thank you.
Thank you, ma'am. Thank you, sir. Thank you, everybody, for your time.
Thanks, Dr. Devika. Now, the last but not the least, our presenter, Dr. Hafida. Are you there? Dr. Hafida, could you please share your slide and give your brief introduction? Yes, your slides are visible.
Hello, sir. Good afternoon. Am I visible, sir?
Your slides are visible.
Sir? Hello, sir. Am I audible?
You are audible. Your slides are visible.
Okay, sir. Thank you. So very fine good afternoon, respected judges and colleagues. I'm Dr. Hafida Konyabdullah. I'm a senior research fellow and a full-time research scholar from the Department of Oral Pathology and Upper Dental College. Today, I'm pleased to present our work titled Multiomic Profiling of Head and Neck Squamous Cell Carcinoma, Insights in Precision Oncology. Our study began with a simple question. With thousands of molecular changes identified in head and neck squamous cell carcinoma, how do we determine which ones actually matter? So we know that head and neck squamous cell carcinoma, or HNSCC, is a malignancy arising from the squamous epithelium of the head and neck region, including the oral cavity, pharynx, and larynx. HNSCC is very molecularly heterogeneous, and large genomic data sets reveal thousands of molecular changes. But a long list of altered genes do not necessarily give us a clinically useful answer. So our objective was to integrate multiomic and clinical data to prioritize molecular candidates with potential prognostic and therapeutic relevance. Why does this matter to dentistry? Dentists are integral to the recognition and diagnosis of oral malignancies. Conventional clinical assessment and histopathology remain very essential, but molecular information can add on another layer to understanding tumor behavior and differences in clinical outcome. The long-term goal is therefore not to replace morphology, but to complement it with molecular information and move towards more personalized care. We started with approximately 42,000 curated human genes and screened with TCGA, HNSCC transcriptomic data for differential mRNA expression. This reduced the data sets to 60 shortlisted genes. We then validated their expression at the protein level using TCGA proteomic data and also examined the clinical characteristics such as HPV status, nodal status, and protein-protein interaction. So from these 16 identified candidate genes, we then validate their expression at the protein level using TCGA protein data. With higher expression was significantly associated with adverse oversurvival of 30 shortlisted genes. Importantly, therapeutic exploration was a parallel branch. The shortlisted protein were assessed for structure availability and predicted druggability, followed by in silico docking. So the strategy was start broad, integrate molecular and clinical layers, and progressively prioritize candidates with prognostic or therapeutic relevance. So what did we find? From approximately 42,000 genes, 60 showed significant higher mRNA expression in HNSCC with concordant higher expression at the protein level. When clinical outcome was added, higher expression of 30 genes was significantly associated with adverse survival. It is important because we were not simply asking which genes are overexpressed. We were asking whether those molecular differences also has some clinical relevance. So our integrated multiomic approach narrowed a large molecular data sets to 30 clinically meaningful genes in head and neck squamous cell carcinoma. We then look specifically at the overall survival of the cases. And among the 60 shortlisted genes, 30 showed a statistically significant association between higher expression and poor survival. So these are some of the genes which have showing high p-value, showing adverse survival, impairs prognosis, and statistically significant prognostic indicator. So there was higher gene expression, which consistently altering with the reduced overall survival. It also indicated that high-risk HNX squamous cell carcinoma patient subgroups for targeted therapeutic strategies. And we have also established 30 genes are reliable for prognostic biomarkers for precision healthcare management. So linking our molecular expression study to patient survival added clinical relevance to the candidate prioritization. And then we have looked for the genes. This was a parallel study which were selected for structurally and therapeutic exploration. And we have identified these genes such as MSN, GT2H4, HAU7, and MNDA. Using Wilcher screening and molecular docking, MSN showed predicted binding with selected chemical ligands. We also explored predicted interaction of the 4 proteins with the pembrolizumab and nivolizumab, which are clinically used monoclonal antibodies in HNSCC. The analysis suggested that There is a high predicted affinity in these genes such as GTF2H4 with predicted binding also observed for HAUS7, MSN and MDA. However, these are computational predictions. They generate hypotheses and do not establish a therapeutic interaction. Experiment validation is essential. So coming to key highlights of my study, the key strength of the study is the multi-level prioritization. Rather than beginning with a few predefined genes, we screened a large molecular data sets and integrated mRNA expression, then went to the protein expression, and then carried the clinical outcomes. This identified 30 survival-associated candidates, while a parallel structural and druggability analysis highlighted 4 proteins for therapeutic exploration. So that study moves from asking which genes are altered to which candidates deserve further investigation. So from large-scale molecular data, we focused clinically relevant candidates. So the immediate next step is validation. These candidates need confirmation in independent cohorts and through appropriate molecular and functional studies. If robust candidates are validated, we can then explore whether they are detectable in saliva and whether they could eventually be incorporated into saliva-based biosensors or microfluidic platforms. Am I interrupting, sir?
You are audible.
Okay, sir. In the longer term, validated molecular information could potentially be integrated with AI-assisted risk assessment.
Would you please
and
unmute
digital,
whoever is
digital decision support. So the pathway is discovery, validation, translation, and ultimately digital integration. These are 4 possibilities, not technologies developed in the present study. So we have transformed molecular information into meaningful tools for tomorrow's dentistry. These are the key references and computational resources supporting the analysis, including our published ACS Omega study. I sincerely acknowledge the institutional and research support for the research work. I'm especially grateful to my mentor, Dr. Riaz Abdullah, and my collaborator, Dr. MS Mustaq, and all our collaborators for their scientific guidance and contribution. I also thank IDDCON 2026 for this opportunity to present our work, and my sincere gratitude to ICMR DHR Fellowship for assisting with the financial support of this project work.
yeah.
So to conclude, we started with approximately 42,000 genes and narrowed them to 60 consistently overexpressed candidates. Survival analysis identified 30 genes associated with adverse outcome, while parallel structural and druggability analysis prioritized 4 proteins for further therapeutic exploration. So if I leave you with one message from this study, it is this: we did not search for more genes, we searched for the genes that matter. Our findings provide a focused foundation for experimental validation and future precision oncology, with long-term goal of transforming molecular information into meaningful tools for tomorrow's dentistry. Thank you for your patient hearing.
Thanks, Dr. Hafiz. Dr. Aparna,
Dr. Hafida, it is quite good presentation. You have mentioned all like your takeaway point is like genes that matter. That is what we are more concerned about rather than just adding up numbers to our study, right?
Exactly.
I don't have any further questions. It's a good presentation. Thank you.
Thank you so much. Have a nice day. Thank you.
Thanks, Dr. Hupeda, for joining with us. And with permission with Dr. Hupeda, we are actually lagging 40 minutes with our scheduled time. So before wasting our time, let us move to our next speaker, Dr. Navneet Kumar. Dr. Navneet, could you unmute your microphone? Dr. Navneet, are you there?
Yes. Good afternoon, sir. Good afternoon, everybody.
Very good afternoon. So Dr. Navneet would be talking on digitalization of all on X, and as a moderator, let me give his formal introduction. Dr. Navneet Kumar is a prosthodontist, implantologist, and diplomat of the International Congress of Oral Implantologists, ICOI USA. He is a postgraduate in maxillofacial prosthodontics from Bapuji Dental College, Devangre. He was one of the first dentists in India to receive comprehensive training in digital implant planning and digital prosthetics from South Korea in 2017. With over a decade of experience, he has planned more than 30,000 cases and 80,000 implants for clinicians across India, UK, Australia, Portugal, and beyond. Currently, he serves as the Director of Digital Dentistry at DIO Digital Implant India, leading digital implant planning, production, and clinical support. He has conducted international training program in Turkey and Myanmar Global Digital Implant Planning Center, and he is serving other dentists worldwide. So over to you, Dr. Navneet. If I missed anything, you can add on and you can share your presentation.
Thank you very much for the kind introduction, sir. And I hope I'm properly audible to all of you.
You are properly audible, yeah.
Okay. So I'll just share my screen. I hope the presentation is visible to all of you.
Yet to visible. Your slides are visible, but it's not. Your screen are visible, but slides are not visible to us.
Is it visible now? Is it changing?
Not yet. Yes, now it's visible.
It's visible now?
Yeah, it's visible. You are audible. Continue, sir.
So, good afternoon, everybody. Today, the topic of my presentation is one of my favorite topics, which is called digitalization of orthodontics. So when we talk about digitalization, we have to understand what is digital planning. Although the timeline is very short, but I'll give you two examples of advantage of having digital planning. Digital planning means the planning done beforehand in the computer system, and you use a surgical guide just to execute it. So there are two distinct advantages of having a digital planning done. Number one is your anatomical or surgical advantage, and number second is your prosthetic advantage. So let me take example of this case. So in this case, the patient basically reported to us for an orthodontic treatment. Okay, and he had this impacted supernumerary teeth very close to the mental foramen. So when I spoke to my surgeon, he told he cannot guarantee whether this, while removing this structure, we won't be damaging the mental nerve. So we innovated a little, and in this case, what I did is I took the scan of the sulcus. We created a surgical guide. We created a surgical guide to access this supernumerary teeth, and then we raised the flap. We seated the surgical guide, okay, and took out the entire chunk of the buccal plate with the help of a trephine drill, and then access that area, and then split the tooth, and we took out the supernumerary tooth. So although this is not an implant case, but this case gives you an exact importance of what surgical planning can do, what digitalization can do. And giving a paresthesia to a 14-year-old boy with all the technology in our hand, I don't think that is right. And in this case, we were able to avoid the same. So this is the post-operative OPG and the post-operative IOPA. And let's look at this case, which will give you the prosthetic advantage. So in this case, if you see, the patient has got ample amount of bone. This is a trauma case of the maxillary anterior region. The patient has got ample amount of bone. We can just open the flap and easily place the implant. But are those implants going to be placed in the exact prosthetic position? So when we did the prosthetic analysis means we first put the crown digitally on the patient's intraoral scan all the models, we first place the crown and then we position our implants. So in this case, we realized that we had to position our implant much more buccally than where the bone was available. So it would have basically resulted in the exposure of the implants. So this is the preoperative data, and definitely the intraoral space was also very, very less. So we positioned the implant in a much more buccal area. We grafted the entire buccal zone and then definitely gave the temporization to the patient. And this is the post-operative healing, the interdental papilla, and the profile that we were able to achieve. But what I want you to focus all of you on is this part, the screw access hole. So there was a lot of bone on the palatal side. We could have easily placed the implant in the palatal side, but that wouldn't have resulted in this kind of screw access hole, the ideal positioning of the screw access hole. So we were able to achieve only this because of digitalization. And imagine giving a horizontal cantilever to a 27-year-old boy, how that would have resulted or that would have affected his life. So if technology is there, we should use it. So this is the message that I wanted to give you, that what digitalization can do for you and for your patients. Now let's move on to the topic. That is what is All-on-X. So All-on-X, it can be either a combination of All-on-6 upper and lower. It either can be All-on-8. It can be a combination of your All-on-7 in the upper, All-on-6. So X denotes the number of implants basically. Or it can be your conventional All-on-4, which Professor Paulo Molo had invented. So it depends on basically the various case scenario. But these are the basic questions that we have in full arch rehabilitation. That how many number of implants are enough, whether my implant should be straight or tilted, whether I should load my implant or not, whether I should give a splinted prosthesis, and how much cantilever is the ideal cantilever, how much maximum cantilever can I give to the arch. So let's see the evidence. So first, how many implants are enough? So a systematic review says that a maximum number of 4 to 6 implants is more than enough for a very high estimated 5-year survival rate of reconstruction. So minimum 4, maximum you can range up to 6 to 8 depending on number of teeth that you can give. So minimum 4 number of implant is more than enough to give you a fixed rehabilitation. Whether my implant should be straight or tilted, it does not matter in today's scenario. If you're using multi-unit, if you're tilting your implants, and if you're using the multi-unit abutments, then it does not matter whether your implants are straight or tilted. Both have got the same survival rate. Whether I can do immediate loading or delayed loading, it does not matter. Again, the article suggests that whether you place immediate implant or even if you do immediate loading in full arch cases, it does not matter. It's the survival rate difference is not statistically significant. So whether my prosthesis should be splinted or separate. So in mandible, the prosthesis should always be separated if you are extending from your 7 to 7. Okay. Why is that a reason? Because of this challenge, which is called as the mandibular flexure. Okay. So the mandibular flexure is maximum in the 7 region, and it basically doubles from 380 microns to 630 microns from first molar to the second molar. So that is why it is always advised till first molar you can give a splinted prosthesis, but when your implant moves to the second molar, it is more advised that we give a split prosthesis. Then evaluation. So this is another article which has evaluated basically your mandibular flexure compared in dentulous versus the edentulous patient, and the result is basically the same. And how much of cantilever should be an ideal cantilever? So no cantilever is an ideal cantilever, but the maximum amount of cantilever that should be given is 12 mm. No cantilever should extend beyond 12 mm. And even if you are giving a cantilever, like in this case, in the lower arch, so we had to give one cantilever. So because we are giving one cantilever, so you should always make sure, specifically the last teeth, that while the closure of arc is happening, your first point of contact should not be on these cantilever. If your first point of contact are going to be on these cantilever, then you will not see failure of this distal implant. You will see the failure of basically your front implant. So always maintain some amount of gap between the cantilever in the distal part, like in this case, as we have maintained. So what will happen if you have an excess cantilever, like in this case, or like in this case? It will always result in the fracture of the distal part. So please remember that no cantilever is an ideal cantilever. So let's see what are the basic steps in the fabrication of the full arch prosthesis manually and how we are going to digitalize it. So in manually, we first place the multi-unit abutment, whether straight or angulated, and then we place the multi-unit healing caps. Then we take the manual impression coping, we splint them with the pattern resin, and then we pick up the impression in the customized open tray. And then we do the jig trial, we do the jaw relation, we do the teeth set trial, we do the metal trial, and then the BIS trial and the final. So there are various multiple steps which are there in the full arch rehabilitation. And there is one more question that we have to answer. When we are doing a full arch rehabilitation, what is the better way to work around it? Whether we should use a multi-unit or we should work at the implant level. So it is always advised that the multi-units are much more better, whether you are placing your implant straight or whether you are placing your implant in the angulated scenario. So in both the conditions, you have to use multi-unit only for the full arch rehabilitation. So let us see what are the various methods of making full arch impressions. As the one we have already discussed is conventional. Now second is digital with the help of your H scan bodies and scan adapters. Then there is something called as reverse scan body. Then there is a new technology which is called as an extraoral photogrammetry, and you'll be hearing about this technology a lot in the future. And then there is something called as intraoral photogrammetry, which is done with the help of flag scan bodies. But today, what we are going to discuss is we are going to discuss the technique of the reverse scan body and under the concept of DioNavi full arch. So this is a clinical overview of comparison of your conventional intraoral and the photogrammetry. And photogrammetry has been proved to be the gold standard for full arch rehabilitation cases. But the main disadvantage of this one is basically it is very, very expensive as of now. So what is the problem when we do intraoral scanning? So the basic problem that we face is basically your mixed lab workflow. So what do we mean by mixed lab workflow? It means that when we take the intraoral scan with the help of scan bodies, the lab guy is basically printing those models. And definitely the model printing has got, the printing technology in itself has got some kind of errors. And then the lab guy is fabricating jig trial and jaw relation on that printed model after putting the digital analogs. And after that, again, once we have given the jaw relation and the jig trial back to him, then what he's doing is he's again putting the scan body on those faulty models and then scanning that part and then fabricating the metal framework. So what happens when he fabricates the metal framework? It does not seat. The processes does not seat. So we keep wondering that what happened actually. I did everything right. I did digitalization and everything, but still my processes is not seating. The basic problem is the mixed lab workflow. So here the lab guys are trying to combine the conventional and the digital method together. And this is not how it actually works in the digital era. So when we look at the solution, it is basically your complete digital workflow. So you have to capture the position of the implant in some kind of provisional bridge or provisional restoration in full arch cases. And then you have to use the reverse scan body. And then you have to directly design on the scan. Use the reverse scan body, scan the provisional, and then directly design the prosthesis, and directly the fabrication of the prosthesis has to be there. So this is the reverse scan body that I'm talking about. And let us see. But one big question which is there for all of us, that what is the missing link in the FMR, implant FMR, that we are still ignoring and we are still paying the prices. We are still paying the price. So let's see some cases about the missing link. So this was a case done by me in the year 2017, one of the first digital cases of the country, in which we did the implant placement also with the guide and the prosthesis also in a digitalized manner. So after the implant had healed, I put the H-scan body. We took the scan and everything was perfect, looked great. We took the scan and then we created a special jaw relation to record the jaw relation. We got the vertical bite also, and then we uh, we got the virtual implant analog position, printed the model, and then printed the DMLS framework. Everything was perfect, fit was perfect, and we gave the final processes to the patient. But patient kept coming back to me year on year with some chipping or some fracture, okay, of the ceramic. So I was wondering why this was happening, and it did not strike me until it had 7 years had passed. So this is a 7-year follow-up X-ray. My bone level are absolutely okay, no issues at all. But still, I have a lot of ceramic chipping. And you know what was the reason? The basic reason is the deprogramming. I did not do any kind of deprogramming in this patient. So whatever the forces were there, they directly were transferred onto the ceramic, and probably they had developed cracks in the initial phase of the rehabilitation only. So I directly transformed the edentulous patient to a fixed restoration, and that is where the ceramic took all the pressure and it kept chipping away. So this is a very, very common problem which is faced by doctors throughout India and throughout the world also. So now let us see. When I learned this, then I modified my technique. So now I started giving provisionalization. So this is the case which will give you an example that after provisionalization, what happens. So in this case, the patient had aggressive periodontitis, and she had a severe TMJ clicking because of the crossbite on the right side. TMJ clicking was there on the left side. So we planned 6 implants in the upper and 7 implants in the lower. We utilized wherever the bone was there. And this is the virtual plan. You can see in maxilla, all my implants are in the severe angulation, a young office going female. So we have to give some kind of temporization. So we've saved few teeth strategically so that we could give temporization to the patient. And this is the first change in smile after the first round of temporization. And during the second round of temporization, we use the implants basically. Okay, so now we have given her a proper centric, a proper bite, a proper aesthetic. So centric, aesthetics, and vertical, all 3 factors were taken care. And then we moved on to the final restoration. We kept her on this temporary for approximately 2 months. And after that, we moved her on to the final restoration. And in those 2 months, her left TMJ clicking had absolutely stopped. And this is the video of the metal trial, and then the BIS trial. And then this was after the final restoration. And you can see the changes. The more important is not the aesthetics or the everything here, and this is the post-operative OPG of the case, but is the clinical follow-up. 1 year follow-up, no chipping. The gums are absolutely stabilized. And this is the basically 3-year follow-up. So I still do not have any kind of chipping, because what we have done deprogramming in her case. Okay, we have relieved the tension from those muscles, and we have taken care of the TMJ clicking of the left side. So she's working absolutely fine. I have little bit of loss of gingiva here, but I can take care of that in the future, no problem. Okay. So this is the follow-up 3 years radiograph. Okay. And you can see the crestal bone levels are absolutely stable. So the 2 main points is deprogramming of the jaw and follow the complete digital workflow. If we do these 2 things, we are absolutely certain that there won't be any kind of chipping in the full arch prosthesis. And the answer is basically your provisional bridge, a temporary restoration, and we can use this temporary restoration as the framework for the final, and we can scan these temporary restoration with the help of these reverse scan bodies. And the technique is basically called as DioNavi full arch. So basically there are 3 key components. One is your surgical guide, second is your provisional bridge, and third is your final restoration. So The basic technique is simple. You do the diagnosis, you do the surgery with the help of surgical guide, and then you can give the prefabricated temporary to the patient, then scan the first temporary, and then create a second round of temporization, then scan the second temporary, and directly give the final restoration. So there is no intermittent step in between. So from first temporary to second temporary to the final restoration, this is what the full digital workflow is all about. And it has got two varieties. One is with the help of full digital workflow, and second is the hybrid digital workflow. In full digital workflow, you are doing the surgery with the help of your surgical guide. But in the hybrid digital workflow, you can also do the surgery conventionally, and you can still follow the provisional bridge steps, and you can give the final restoration to the patient. So this is the core product, which is called as the provisional bridge. We call it the provisional bridge, or PV, or the first temporization. So in this case, you can see we put the implants, upper all on 6, lower all on 4, give the provisional bridge, scan the provisional bridge, and the best part is that all the work that you're going to do is going to be outside the patient's mouth, is going to be outside. So you're not working inside the patient's mouth. During the entire full arch procedure, prosthetic procedure, you're not going to work inside the patient's mouth except for bite adjustment, nothing else. So then we scan the provisional and directly fabricated the final restoration. And this is the final restoration for the patient. So in 3 to 4 steps, my case is basically complete. Then this is another case, lower all on 8. In this case, we gave that provisional to the patient, and in this case, this is the provisional, and we fabricated a PFM bridge for the patient, for the lower one. The same patient came for the time of upper rehabilitation. Already 2 implants were present, so we added 5 more implants. And again, because it was periodontally compromised, so we saved a couple of teeth for the initial round of temporization. And after that, we created our first provisional, including the 2 implants which had been placed previously. So this is my first provisional. We pick up the first provisional and place the first provisional into the patient's mouth. Okay. And we do the finishing and post-processing of the first provisional with the components called as cylinder protector. This has got certain uses. And this is my first provisional ready to be placed into the patient's mouth. So you can see in my first provisional, there is a little bit of occlusal discrepancy. So that is why it is important that we give the second provisional to the patient. So this is my post-operative OPG after the first provisional. And then I put the material on the undersurface for the relining. If any kind of excess is there, I remove that excess, then put my scan body, and then attach the scan jig like this, and then scan the provisional outside the patient's mouth. So you can see we are working outside the patient's mouth here. Okay. So this is the scan of my first provisional. From there, I go ahead and design my second provisional, and then give my second provisional, which is perfect occlusally. Okay. And then I place my second provisional with the help of cementation, and again repeat the second relining and putting the reverse scan body onto the second provisional. And from there, this is my fitting of the temporary cylinders on the multi-unit abutment, and then scan of my second provisional, and from directly I go ahead and create my final restoration. And this is the final restoration PFM in the upper one as well. Okay, and this is the 1-year follow-up OPG, and this is the smile line that we were able to achieve. So there are two the main prosthetic, the main component here is the first provisional bridge, or the first temporary, or the second provisional bridge, or the second temporary. From directly there, we move on to the final restoration. The final restoration can basically be your titanium frame and zirconia prosthesis, or it can be directly your full zirconia prosthesis, which is held with the help of a special screw, which is called as the torque screw or the direct screw, or you can have sectional zirconia bridges also placed into the full arch restoration. Now, this is another case that you can see from edentulous to first provisional to the second provisional and then to the final restoration. So edentulous, second provisional, final restoration. Now you can see in my second provisional, I had to correct the midline, I had to correct the smile line. So because of all of these factors, we need these multiple provisional steps, and from there we had reached till here. Now this is another case in this upper 6 and the lower 6 implants, and this is the same case in which the PFM prosthesis did not fit basically. So this is the preoperative of the patients. So from there, we placed the 6 implants and we temporized. This is the first round of temporization. This is how her smile changed after the first round of temporization. And then this is the post-operative OPG after the first round of temporization. Why I'm showing you always these OPG? Because you have to verify the fit of the temporary cylinder onto the multi-unit. If your temporary cylinder is not fitting onto the multi-unit, then definitely your final process is not going to fit because you're utilizing this fit only. So this is my design of the second temporization, and my second temporization is fabricated, and this is how her smile changed from first temporization to the second temporization. And then again we reline, put the cylinder scan body and the scan jig, and again the blue one that you are seeing is basically your final design of the full zirconia. So if you see, I still want to improve her smile. I want to get that perfect smile arc. And after that, we design the final restoration. And then this is the screw that I was talking about. And this is how we could overlap onto the facial photographs. And this is my full zirconia restoration. There is no metal framework in it. So you can see here, this is my full zirconia restoration. And this will be directly screwed into the patient's mouth with the help of a special screw, which is called as the torque screw or the direct screw. Now, this is not like hexagonal screwdriver. The screwdriver is entirely different. This screwdriver is basically a flower-shaped screwdriver. And this is the final restoration into the patient's mouth. And when we fix this final restoration, which we had made with the help of entire digitalization, no model printing, nothing, okay, no jig trial, no jaw relation. Everything is done, but it is done digitally, okay, with the help of photographs, with the help of temporization. And this was the final restoration that we were able to place, and it was absolutely passive because there is no room for error to come in when we are doing the work in a complete digital manner. So you can see the fitting is perfect. And this is how her smile transformed from pre-operative to the post-operative. And this is another case. So till like this, we have been doing till now, the case that I have shown you. But what is going to happen in the future? So this is the future. So this is the provisional scan temporization. You can see my reverse scan bodies, and this is my temporary, and this is the virtual articulator. And this is the virtual articulator. And now we have got the capability of basically overlapping the patient scan into it. So now you will see the patient face can actually be overlapped on the temporary, and you can change everything. You can also have the patient virtual bite. So you can see this is the virtual articulator giving the patient's own TMJ simulation in the full arch rehabilitation. And this process is going to become the entire norm of the full arch rehabilitation. So the future is there for you, and the future is going to be for full arch rehabilitation. It is going to become a facial driven, prosthetically oriented planning that all of us are going to see in the future. So the door of digitalization is open for all of you. It takes a little bit hard to walk in inside, but once you have that heart to walk in inside, there's a whole new world which is there waiting for you. So thank you very much for a very patient listening. And if there are any questions, I'll be more than willing to take it. Thank you very much.
Yeah, thanks, Dr. Navneet. Actually, my device is, some glitch happened, so I'm joining with other device. Anybody want to ask any question, they can ask question right now, and they can type on a chat box. Any question?
Thank you, Dr. Sunil. I can understand the topic is very new for most of them. So,
Yes, yeah, yeah. No, the before that, Dr. Rabia is also presented, and it's related to AI, and also that's why this is happening. So for this, we are moving to our next speaker. With your permission, Dr. Navneet.
Yes, sure, sir. Thank you very much. Thank you, everybody, for giving me this opportunity. Thank you very much.
You can stay with us, Dr. Navneet. If any question comes, no, you can answer after the presentation of Dr.
Sure.
Anisha. So we are taking Dr. Yeah. So we are taking Dr. Anisha before Dr. Abhay Lamba. Dr. Abhay Lamba's scheduled talk is after Dr. Navneet, but he have to rush to OT for one procedure, so he would be joining later on. So let me introduce formally Dr. Anisha, and then Dr. Anisha, are you there? Could you please unmute?
Yes, I'm here.
Yeah. So let me give you a brief introduction. Dr. Anisha Parmar is MDS in Conservative Dentistry and Endodontics with a keen focus on biometric principles. As a consultant endodontist, she is dedicated to integrating modern evidence-based concepts into clinical practice, with several national and international publications to her name, including work on NITI file system. Dr. Parmar actively contributes to the academy and clinical advancement of dentistry. Her lecture on biomimetic paradigm reshaping modern dentistry reflects her passion for preserving tooth structure and enhancing restorative outcome through minimally invasive techniques. She continued to bridge research and chairside practice, bringing a scientific, conservative first approach to every case she treats. Dr. Anisha, if I missed anything, you can add on, and then you can
No.
start
You
your
covered
presentation.
everything. That is very, very nice of you. Thank you so much for introducing me. Shall I begin?
Yeah, please.
So my screen is visible?
Yeah, your screen is visible. Can you put in a slide share mode? Yeah.
Yes.
Perfect. You can continue, Dr. Anisha.
Okay. So, hello, this is Dr. Anisha, and today I'm going to present on biomimetics paradigm reshaping modern dentistry. So, let's begin. When we look at a picture like this, we can see old amalgam restoration, secondary caries, leaky margins, poor perio control. Now, how will you restore it? You'll do some endo, you'll prepare some crowns with huge margins, and eventually, over the years, this will come back to you. There would be tooth with failed tooth and not your restoration. Your restoration is intact, but the tooth fractures. There would be post and cores which are fracturing. There would be again leaky margins with class 5 caries. And again, you will be redoing this where you already have compromised so much of the dental tooth structure in the first place. Now, again, going ahead would be a very challenging task. Also, we are compromising the tooth structure again. So, now coming to the main topic, what needs to be changed? Just a minute. Yes. So maybe your diagnostic mind needs a little change. Maybe how you see and analyze the things needs a change. Now, how do we do this? And what is biomimetics? Biomimicry is something where you are copying or emulating the natural tooth structure, which is life. So the art and studying is defining and considering to replace what is already there with the original thing. This is not something new. The Eiffel Tower itself has taken a biomimetic concept and is taken from the human bone humerus. Now, the shift has happened over the years. Earlier, the dental practice was majorly extraction based, then we came to restorations, then preventions and diagnostics. The current is where we are looking for revascularization, regeneration. The first use of biomimetics was by Dr. Pascal Magnet. Now, what are the concepts you need to keep in mind? Keeping the theory aside, what are the three things which you keep in mind is to conserve the tooth structure and its vitality, to increase the longevity of the restorations we do, and also to eliminate retreatment. You don't need to retreat each time. The concepts we need change are from foot coverage crowns, you need to shift to onlays and overlays, aggressive crown preps. So from conservative approach to biomimetics, we need to change things from foot coverage crowns to overlays and onlays, from aggressive preparations to conservative preparations, from retention walls, which were used for bonding, we need to look for adhesive bonding. And the most important thing is to preserve the pulp vitality. The concepts and the principles to be kept in mind is to preserve, to mimic, to achieve, to avoid, and to respect. Now, coming to the biomechanics, there's this one thing which you need to understand is what you are replacing. When we replace enamel, there's this theory and this article I want everyone to go through. This is the dome concept, and it makes us understand that the cathedral dome, the dome of the enamel, is similar to a cathedral where it is protecting the dentine. So, all the forces which are on the cusp are converted to a compressive load. Thus, when we are replacing it, we have to make sure that these forces are evenly divided and there's not a single force happening over an area. If at all these principles are not taken care of, we will come across failed restorations, failed cuts in the restorations, which was perfectly fine. So you're not failing on the bonding part, but you're failing on the part where the tooth structure is not capable enough with the bonding. So it is very important to keep these in mind whenever we are replacing. So the biodome concept says that whenever we are doing a restoration, we should try to preserve the biorim. The biorim is the most concentric portion of the tooth. Maximum fractures happen whenever this area is not under proper preservation and care. So the current concept says that rather than preparing full margin crowns, we should try to create margins which are above the biorim and look for bonding which is directly to the enamel and dentine, which is by adhesion and not just with retention forces. Now, there are 7 pillars which I need you to take care of. These are by Pascal Magnet. The first is to be very much involved in what you're replacing and to see. So, take impressions, take photographs. The second pillar is to try to preserve. If you see a very thin layer of dentine which is present, even if it is carious, so I repeat, the current protocol says that even if you're leaving a little infected dentine, not just affected dentine, but your entire area around it. So your bonding area should be completely clean and should be clear of caries. But just above your pulp, if there is 0.5 to 1 mm of dentine which is infected, you can leave that 0.5 mm, let the dentine be, and then create the entire composite layer. This has taken into research, and this gives a better pulp protection than using any of the materials or directly jumping on to doing a root canal. So preservation of pulp vitality should be an obsession. The moment you see a two caries approaching pulp, try to differentiate between infected and affected. The third pillar is, as I said, once you have created, you preserved your pulp. The next thing which comes is bonding. So you should think about, the first thing is bonding, and how will you bond it? Are you bonding to the enamel or are you bonding to the dentine? With the current generations, you don't need to etch the dentine, but you need to etch the enamel. So selective etching, which is etching your enamel, is the protocol I believe is the best one, gives the maximum bond strength and the least micro leakage. Now comes your restoration. You have done your bonding, you have preserved the tooth structure. Now what are you replacing this with? You can either use composites, or you can use short fiber reinforced composites or ceramics. The current protocol says that the composites, if used very nicely with injection molding, heated composites, they are equally strong as ceramics, but the technique is very important. Also, it all depends on how much cusp coverage you need and how much cusps are already there. So coming to this preservation and keeping the biorim intact. Now, retention and resistance form, which was used earlier, this is not the current concept. You need to depend completely on bonding. And these are the current protocols, and the margins, if given in this way, it would give you very good amount of tooth structure which are preserved and also good aesthetics. One must also upgrade. So each and every case that you do has to have rubber dam, and along with rubber dam, that is not just enough. You have to have magnification. This is not really now an advanced tool. This is a compulsion. You cannot see directly. You need magnification to see, and also rubber dam isolation is not a choice anymore. It has to be done. Not just the tools. Now, coming to the techniques, there are three techniques which I am going to explain today. Two of them in detail. One of them is immediate dentine sealing. Deep margin elevation, we all know, and we have to make sure while bonding that this is done. And pulp revascularization. And the last thing, it is very important that we prioritize the saving of the tooth and not your restoration. You are not replacing the tooth structure to save the tooth structure and your restoration. You have to save the tooth structure the first and not the composite which you're filling. Thus, it is very important to see how much walls you have. If at all you feel, measure every time, see, do you have around 1 mm of the layer which is present at the cusp? If it is not there, think about capping the cusp or shifting to an onlay or an overlay. Now, immediate dentine sealing is something I wanted to explain because it is one of the first very important things which is very much overlooked at. So, immediate dentine sealing has to be done under rubber dam. After your caries removal, this has to be done for each time you're doing a restoration or indirect restoration. You have to ideally abrade with air abrasion. If you don't have that available, make sure it is all clean. Then apply a very thin layer of bonding agent, 20 seconds scrub, light, and do a flowable composite. This will give you a seal to the dentinal tubules. So the next time, if you are doing an indirect restoration, you can directly seal it, and the amount of dentine micro leakage reduces very nicely. Now, after this, you can either do a composite inlay or onlay, or you can do filled composites or inlays. or onlays. In onlays, when we are doing restorations, there are a few things you need to keep in mind. The first and foremost important thing is margins. If you can see, it is very important to create space for the replacement, also to preserve. Your margins are always inclined and not any sharp angles. It can be straight. You could be covering the buccal surface, which is one lay, or you could be completing the covering the entire surface. But the margins should not be sharp. They should be in the central fossa if you're including that, and there should be no 90-degree joint, and bevels are very important. Now, coming to biomimetics in endodontics, till now we were seeing the restorative part. Something which I feel is already missed and always overlooked is whenever we are trying to preserve the pulp vitality, we only think about doing when the tooth is already, like, very near to the pulp. But we can also think about revascularization processes. I would take one case about that as well. So to preserve the vital tooth structure is the most important thing. Now, these are a few things. These are a few things you need to take in mind. As I've already explained, immediate dentin bonding is the most important thing. Along with this, vital tooth preservation is important. Now, when you see very deep cavities, something like that, you would think this would go in a root canal, right? But with proper composite, you can actually save it. There's a case where you could see there's pulp exposure here. This was immediately sealed with MTA and layered with composite. The restorations last and the outcome is very good. This one of the cases which I would like to present of pulp revascularization. This was a recent case I did. Now here you can see that it is a 11-year-old kid with big lesions in the upper buccal region. There is open canals which are Bandabas canals with lesion which is approximately 10 mm and 13 mm. These are central, which is 1-1, 2-1 and 2-2. The ideal case which the periodontist decided earlier was a root canal. The openings were already done by her. This is how the occlusion looks like. This were the openings done by her, but we intervened and we changed the treatment cycle. Here we started with what is the pulp revascularization. There's an article by Kim et al. In 2017 where he suggests to use and create apexogenesis with MTA and also PRP, which is plasma-derived growth factors. So in this case, we did the same. This is the protocols which we have followed, where we have created a barrier with MTA, brought in the blood, and we have also filled this entire region with PRP. This was the PRP which was created. You can see the membrane. It is very good and from her own blood. This entire membrane is injected in all the three centrals.
Sorry
and
to
we push.
Dr. Anisha. Your
Yes.
slides not being seen. Actually, it seems like you've paused your screen sharing. You're not able to see it.
Just a minute. I'll check.
Yeah, yeah. I guess your voice is muted.
Is this visible?
Oh, yes, yes, yes. Thank you.
Okay. So this was the case where we injected PRP directly in the canals. If you can see this picture where we have placed it inside the canals, the openings are very wide. I would not have done this much wide openings. It was done earlier than me, but if at all you're doing openings, don't make it this wide. Try to preserve the dentine around the tooth as well. This is after pushing it inside. You can see there is bleeding from all the 3 canals, which is good. Blood should be induced. After we can prepare this, we can clean the coronal portion, and we have done MTA plugs. This is after a month, where we can see the MTA plugs are intact. We are looking for a long-term follow-up on this case, but we have done cases like this earlier as well, where ideally the cases which they want is that pulp revascularization should mean a new pulpal activity, which means the pulpal vitality should be there. In 90% of the cases, pulpal vitality is not present, but the tooth doesn't discolor, and we can see apexogenesis, which is the complete closure of the apex, which has been seen. What we look forward is to make it completely good ahead, and the tooth root apexes should be clean. So for an 11-year-old, where we see where the tooth could have been just done a root canal with this much thin walls, it could be have easily fractured. So doing something which is preserving the vitality as well as making sure that at least the tooth is developed is a better idea than shifting directly to endo. So thus, your biomimetic workflow should be something like this. There should be diagnosis. Make sure you try to preserve and protect. Isolation is very important, and make sure you isolate. Adhesive sealing, restorative layering, and finishing and follow-ups. One of the most important things which you have to keep in mind is follow-ups. Thus, keeping in mind all of this, I would like to come to the end of it. It is not experimental, it is evidence-based. It doesn't take too long. You just have to be efficient in what you do. Proper isolation and keeping in mind the curing technique is very important. I keep on saying this, rubber dam and magnification. Please use it and you would find really good results. Thus, coming to the end, wrapping it up, use immediate dentine sealing, deep margin elevation for large restorations. Put ahead in your mind what you're going to use, do your bonding well, preserve the tooth structure. Even a small amount of 1 mm of the dentine or that enamel will help you in bonding to try to preserve it. Thus, ending it here. Examine, pause, and try to bring the change. Thank you.
Anybody want to ask question, they can ask question and they can type on a chat box. No questions yet, Dr. Anisha.
Okay.
So you will stay with us. Maybe if question comes after Dr. Abhay, then we'll connect.
Okay. Okay. Thank you so much.
Yeah. Very enriching, nice presentation, Dr. Anisha. With your permission, we are moving to our next speaker, Dr. Abhay Lamba. Dr. Abhay, could you please unmute?
Yeah, hi, can you hear me?
Yes.
Okay, can you see the presentation, my screen?
Yeah. Immediate machine implants.
Yeah.
Just hold on and just interaction.
Okay, sir.
Yeah, Dr. Abhay Lamba is a distinguished implantologist with over 29 years of clinical experience, a graduate of Manipal Academy of Higher Education, Mahe 1994. He holds a postgraduate certificate in implants from Mahir 2001 and is pursuing his MSc in oral implantology from Goethe University, Frankfurt. He has trained globally in advancement grafting, sinus lifts, and CT-based implant surgery. A pioneer in lift maxillary sinus surgeons in India, he is a fellow of the ICOI USA, DGZ Germany, and the Academy of General Education Mahe. Accomplished speaker, he has lectured in at IDA, ICOI, Asia Pacific, and AOI conference. He is a contributory author on implants in orthodontics in Dr. Gurkirat Singh's textbook of orthodontics and a founding member of Asia Pacific Association of Implant Dentistry. He is currently a senior faculty and a speaker at with DGOI Germany, Dentsply Academy, and APAID. Over to you, Dr. Abhay. If I missed anything, you can add on and you can start your presentation.
Sure, sir. Thank you. Thanks a lot, sir, for a kind introduction. So, okay. Can I see my screen, sir? I think I can see only your screen.
Your screens are visible, sir.
I can't see my screen here, sir. You have to unshare your screen, sir. Yeah. Okay.
Please unshare and then
you have to unshare your screen, sir, so my screen can come up, sir. Okay. Okay, today my topic is immediate functional implant restoration in anterior aesthetic region.
it's not moving actually.
So this is some hang. One sec. Okay, yes.
Yes, yes.
So before I start my presentation, I bow to my teacher, my dean, Dr. K.S. Bhatt. Because of him, I'm an implant surgeon. He motivated me, he guided me into the path of implants, and way back about 29-30 years back. So I'm in private practice. I'm also a fellow of ITI, fellow of ICOI, AOI, DGOI, DGAZI, SOLA, and also a co-founder of APAID and AOI. And I have my own private practice, as well as I have a dental lab attached to my practice. So before I start this thing, I just want to give you a small glance on different classification of immediate implantation given in different time, and this is one is the latest from the ITI classification, depending upon the time duration when we are doing or placing an implant. So it's like immediate implants placement, where we perform the implant placement on the day of extraction in the same surgical procedure. We call it type 1. Then we type 2, which is where we place the implant when the soft tissue healing is already done. It's like 6 to 8 weeks normally, and sometimes we can extend it to 8 weeks depending upon which decade the patient is and is gender of the patient. Especially in the ladies, normally it takes a little bit of more time, so we normally wait 4 to 8 weeks. Then early implant placement with the partial bone healing, that's about 12 to 16 weeks, that's about 4 months. And then late implant placement when it's a fully healed site. less than 6 months, but normally we don't wait more than 1 year, because then we lose most of the bundle bone or the anterior label plate. Then if you put it on the consensus on 2018, Gallucci et al. In an ITA consensus, given a very versatile immediate functional dental implant restoration protocol or classification, where we talk also along with the immediate implant placement. So we divide it into type 1 and C. It's more like immediate implant placement with the A, B, C, where we have a immediate placement after extraction socket. It's like early loading in type B, and then type C is the conventional loading where it's all healed. So now we differentiated into immediate loading on the same day and then 2 weeks, or after the complete healing 12 to 6. So it's depending upon that, we divide into type A1, A, B, and C. Also, as further decided in the same consensus was like what type of immediate loading can be given, sir. That is single implant, which is 1 arch implant placement, or multiple implant, like maybe on 2 implants, or a sectional loading, or a partial posterior functional loading, or a full arch loading all on 6 or all on 6, which Dr. Navneet already talked about it, so I'm not going further into it. Then in an old classical classification by Carl Misch, who we normally say the father of modern implant, father of modern implantology. So he talked about similar kind of on depending upon the time of implant placement, like immediate loading, early loading, occlusal load applied after 1 week, where we talk about the prosthetic loading of the immediate implants, where we don't load it in 1 hour. We load it after 48 hours or after 2 months, or maybe after more than 2 months. So it's like functional or non-functional restorations. So this is normally placed out of occlusion, and we replace it after say 2 months with functional loading. So here the risk factor was more on a prosthetic loading. Then comes the latest new classification based on socket, root, and other site classification. Ilian et al. Given on the socket classification, where he has divided into type 1, type 2, and type 3, where facial soft tissue and buccal bone are intact. So as we go into the immediate implant protocols, the further classification came in depending upon the facial bone, presence of facial bone, the level of facial bone. So if it is completely intact, we call it type 1. But soft tissue is there, but facial bone is kind of partially resolved or a fenestration, especially in the canine region, we call it type 2. And then the loss of both facial soft tissue and a buccal bone plate because of some recession or a pocket or a label, some periodontal issues there, we call it type 3. So it's a complex defect where we need to do a soft tissue augmentation with the CT graft, as well as we can do immediate implantation, but then we need to have a more soft and hard tissue grafting there. But in type 2, we just have to do a more of a hard tissue grafting and maybe a bone graft. Or in type 1, we normally don't do any grafting, we just do a providence. So if we classify into buccal and facial, here we have a little bit of hair, and then this is kind of, we have soft tissue and hard tissue defect both. Now there was another classification given on surgery, where we position of the tooth there and how we're going to place the implant there. So as further we go into the more immediate implantation, further investigations start coming in, and we have these there. So can it all give classification on surgery there? It's a label cortical plate. Most common augmentation if thin plate is there, or maybe a late resorbing graft need to be placed in between there. Normally this is the ideal condition where we place an implant more palatally. Root center in the middle of the alveolar housing means palatal and the label plate are equally. There's not much of palatal bone there, so we have to have a balanced bone, and it's a quite favorable. We straight has to go into the socket position. We place an implant. We do not orient the drills to accommodate the primary stability in those implants. Now there's a type 3 or a class 3 is like where it is more palatal cortical plate. This is most common there, and we have a lot of labral bone deficiency there, especially post-action. Sometimes along with the root, the labral plate also comes with it. So that's where it is a bit of a complex there, is a risk is there, and it's very thin plate there. Then at least 2/3 of the root, the class 4 classification we call it, at least 2/3 of the root engage both labally and palatal cortical plate. So it's a very complex anatomy, and let me put it there in a graphics. So it's like in a class 1, as a palatal and buccal is like exactly in the center, where it's nothing much of a worry. We can place an implant. We have ample bone on buccal and palatal side. Whereas in a class 2, is slightly tilted towards more cortical plate. We can angulate it to place an implant. More favorable position than class 1 cortical plate, which is a bit of a complex situation there, and we need to do some grafting and orientation of drill there. And a buccal on a class 4, where it is completely penetrates through the buccal cortical plate. Like mostly I've seen these type of cases during or post orthodontic treatment. The kids or the adults, they had this orthodontic treatment done earlier, and then they, we have some root tipping was done, or tipping kind of orthodontics was done, and the root actually exposed off from the buccal plate. This is very quite complex there, and then rehabilitation is a little bit involved, a bit of complex augmentations. Now if I put it in a SAC or straightforward or a SAC ITI classification, it's like straightforward or advanced or complex. So it's a simple way of putting these cases under SAC classification, depending upon CAN or Ilian or Gallucci classification. So we normally take all the three, like sagittal position, then root position, as well as the timing. We put it into the case under SAC is like straightforward case or advanced case or a complex. So I'll share with you a bit of cases involving straightforward, advanced, and complex cases with my clinical cases. Now if I consolidate all the classification in one table form, so ITI normally the Gallucci et al. Came in because of the timing. Also MISH is also about timing, but related to the prosthetic loading, that is early loading, immediate loading, and a delayed loading. And so here immediate implantation, but restorations depending on the late, depending on of loading. So Gallucci further restored it, classify, if I consolidate, is 1A, 1B, 1C. So that is related to immediate loading, specific to immediate. With the Gallucci, placement and loading on the same day, but depending upon the condition we have, placement and loading determine the restoration with the final restorations. So now if you look at the Ilian, where we talk about the socket integrity, because most of the time when we do immediate implantation, the socket is something which is very important there, and where is the position of the roots are there. So I would say you put Elan, that is the buccal plate, and the Elan is the position of the root. So that need to be case selection. It makes it much more easier for us to select the case, and then standardize the our loading and immediate placement protocols further. So I would say single tooth loss in aesthetic zone, especially the maxillary entry region, depending early aesthetic and time sensitive outcome. So we want to maintain the soft tissue integrity there as much as possible. And then when talk about full or partial denture, required rapid restoration, teeth in a day, or all in X, or we talk about all in 4 or on 6 already. Dr. Navneet has very elaborately talked about it. And also sometimes the patient is also, if not psychologically motivated, then immediate loading is not a option, because then you have to talk about the eating habits, and you have to also see whether the patient has any parafunctional habit or no. So in sometimes we normally delay it and we give a denture. And some patient who have a good bone, but they don't want a denture, so these are the good candidates. So we have to do a patient modulation there before we go ahead with the. So what are the anatomical and biological criteria to look into it? It's like optimal site, like whether we have a favorable site there. Intact bone wall should be more than 1 mm or equivalent to 1 mm, and it also ensure that we do not lose much of a mucosal or soft tissue recession. Also, we should have a nice peri implant, thick soft tissue around our implant. So this is one thing. Then there should not be any acute infection. Chronic is not a problem, because chronic is more like a corruption what we have in our country. We are used to it. So the chronic infection is something like where body is used to it, and we already have a very definitive cyst lining there, so we can easily remove that granuloma, and the socket is as good as a normal socket. But in acute infection, it's at the cellular state, so it can lead to a macrophage state, and also can lead to the bone formation or bone resorption around the implant if we try to place implant in an acute infected socket. There are certain protocols there, but yes, we have to depend on certain expensive machines to do that. Lasers or ultrasonics, you have to understand those protocols before we get into the immediate implant placement in acute inflamed sockets. Now, about the sufficient bone volume apically, lingually for stable anchorage. So more than 3 mm should be a primarily stable in a healthy bone, especially periapically. We should have a torque of somewhere around 25 to 40, and 40 is a rule of 40, means ICQ normally should be between 50 to 70. Occlusal schemes that allow overload of the provisional restoration during healing. So we can do functional loading or segmental loading depending upon number of implants there. So if you're doing a single posterior immediate loading, I would not advise you, but in a like a triangular angulation, if you can create in posterior, but in anteriors you can do single immediate loading on a single implant functional, especially if you get a good primary stability there. But still, I would advise you in an occlusal scheme, it should be free from the functional loading. Patient-related and chondritic factors that you have to look into: a poorly controlled diabetes or thyroid, or you have a periodontitis or active infection, a gum infection in the patient's mouth. If the patient is a non-compliant, oral hygiene is poor, then you have to motivate the patient till it's ready for the treatment to get the implants done and hygiene is optimal. Also, in case of periodontitis, I would say you can still motivate the patient to have a better oral hygiene. Also, you can do some bit of flap surgery to reduce bacterial load or infection load in the patient's mouth. Diabetes is something patient has to be aware of it, and has to be in the band of between 5 to 6 HbA1c. That's the, where the it's not affecting the calcium metabolism. Then heavy smoking is something I would not advise where the implant should be placed, especially in the anterior region. It can lead to failure because of poor vascularization of the peri-implant tissues and the bone. Acute infections, as I already explained, thin soft tissue and high smile line is also a contraindicated or 1A condition where we have to ensure that we do a proper planning to achieve that. Also, we do a little bit of add bit of more connective tissue to do that. Now, patient-related chronic factors, also parafunctional habit, I just mentioned in the last 2 slides back. Inadequate bone or primary stability is no go for immediate loading. Complex anatomy, yes. Deep bite, especially class 2 diff 2 cases where you have a lower anteriors, are in active occlusion with the upper anteriors because of retrocline upper anterior. Laterals may be, but centrals can't be placed there because you are in active occlusion or bite with the lower interiors. So we talk about procedural different techniques also. So when we talk about different techniques of placing implants, is like immediate, as we talk about fresh extraction sockets, then early 4 to 6 weeks, delayed I just mentioned. So depending upon the techniques, you also talk to the patient. So functional loading demands higher primary stability, robust bone like D1 to D3. Yes, with the drilling protocol, you can convert from D4 to D3 or D3 to D2, depending upon our system and the bone condition. We can modify the drilling protocols to ensure that we have a nice D1 to D3 peri-implant bone density. But that also needs a little bit of skill to achieve that. So grafting needs a defect site buckle. I have already mentioned about the connective tissue grafting. As a biotype, thin biotype is more riskier in anterior than thick biotype, which is more forgiving as compared to thin biotypes. Also, the buccal gap or a jumping distance, we call it, should be less than 2 mm away. But if it is more than that, then you need to fill it with xenograft or autograft or PRF, PRGF, CGF, depending upon whichever you have faith into it, but everything works. So talk about the digital and guided techniques because it's the digital conference, I had to mention that. So pre-surgical planning is must using CBCT and 3D slides across sections and everything, and with the intraoral scans, digital wax-ups, restoration-driven plans. We already talked about in yesterday and today. We talked about a little bit of pre-surgical planning. Surgical guides are actually I've been in practice from last 30 years, but nowadays I'm more and more independent upon guided surgeries. I still feel navigation surgery is still a lot to go and a lot to learn, except certain cases like zygoma and difficult cases. I think static guides are much more precise than navigation surgery. They also have still a lot of zone of issues there, or while doing this surgery, the positioning and everything. It's a steep long curve for the navigation surgeries. Static surgeries, static guides are much more precise. Okay, so prosthetic techniques. So what type of prostheses we are planning for our cases, like temporary abutments like titanium and PEEK. Also we can use in anterior like zirconia abutments with a temporary crowns, a composite crowns. Later on we can replace it with Emax or Empress crowns or ceramic crowns. So these are for the interiors. For posteriors, normally use PMMA crowns with a PEEK crown to restore or to reduce the occlusal load from my my abutments. So final restoration, if you're doing immediate restoration, provision restoration, normally we load it within 6 weeks. So the bone around the implants are much more denser as compared to a delayed healing case. So immediate loading cases can be also loaded with final restorations early. So if I put it again on immediate table, key attributes here, validation, or I would say the survival rate with the Gallucci classification 97 to 99%. Type 1 be 98%, type 1C is more than 98%, and type 2, 3, A, B, C, early placement is nearly 90 to 98%, and type 4, A, B, C, late placement more than 95%. If you look at the type 1, the immediate implant placement is nearly 99%. So if you look at the literature, I think in aesthetic zone, immediate implant placement has a better soft tissue adaptability and survival rate as compared to conventional and delayed and early loading if you look at the literature. Now I'm going to talk about single tooth loading requires high primary stability, full arch immediate loading, complex planning, cost intensive, but yes, cross arch stabilization also gives you immediate function capability in those. Overdenture with immediate loading, especially in the lower mandible, is very much successful, nearly 100%. But in maxilla, it depends upon which kind of restoration you're giving. You have to be, if you're using a locator or you're using ball and socket, you have to use the lowest stress silicone to load those overdentures. So it should not give you too much of extrusion forces while removing the overdenture. In a post-section site, the risk of micro movement is there, but with the primary stability and little out of occlusion planning gives you much better results. With a CAD CAM, the precision is much more high. You need a little bit of expertise and soft AI enabled tool. Speakers before me talked about AI in CAD CAM and planning. So I'm not going much further with the details into it, but will show you in the my surgical cases. So key points for immediate function is primary stability, occlusal scheme should be non-functional loading area, preferably to avoid overloading. Case selection, bone volume should be adequate, favorable occlusion, absence of acute infection. So preferably a chronic infection, not a problem, or a fracture root is not a problem, but acute infection should be avoided until unless you are good with the protocols with ultrasonics or lasers to take care of acute infection at the site. Prosthesis type, single crowns, fixed partial denture. I think we have CAD/CAM labs available very closely to all the clinics now in most of the cities, tier A, B, and C. So it is possible to deliver the prosthesis in the same day or the next day. But most important is the patient compliance, like aesthetic expectation and systemic health of the patient, how they deal with it. That's also an important factor in this. So recent innovations, we talked about intraoral scan and CAD/CAM. I'm going to show in the cases 3D printed surgical guides. I'm going to show that also with the cases. Surface modified implant, which is a bone to our immediate implantation. It increases the implant surface or implant contact with the implant bone, and also it also become more hydrophilic than hydrophobic. So these surface treatment also gives us more hydrophilic implants, faster healing, also a mold surface to for the collagen to attach to create a more denser bone around our implants. Biomimetic materials, we have much better materials, 3D printed material, customized healing abutments, much more where we need not to modify the soft tissue later on. We can start the soft tissue maturation from the day we place the implant, contour the soft tissues, as well as we can have more natural looking abutments which are more elliptical or squarish shape, unlike other stock abutment which are round and very short, which gives you very wide cantilever over single crowns also because of smaller marginal line. So we have AI guided planning. We already previous lectures already mentioned that. And implant approaches, we talk about corticobasal and zygomatic. They're also working, and corticobasal, I do not have much of faith into it, but then yeah, it's happening. So I would call it as novel. It's not a evidence based. So let's start with the case so I can finish it off on time. So this is a female 20-year, is a delayed case, congenitally missing tooth, and a lady got an orthodontic treatment done, but the bone was not moving. Orthodontist was tried everything, but then it was not available the right size for the implant placement. So we decided to go with a guided surgery. So as you can see here, we don't have a much of bone available here. The height and the width was available, but if you see the bucco palatal, we don't, mesodistal, we do not have much of a distance. That's 3.4. Height, I think the length or height of the bone was available, but then at the apex where the central incisor and the canine has is only 1.94. So if whatever implant, if I use a 13 mm implant, as you can see here, I have a space for 13 mm implant, the chances of going into or invading into periodontal space was much more higher. So I planned a shorter implant for that, because a longer implant either has to be thin implant or a one-piece implant, but then one-piece implant will not give you, because here angulation is much more steeper. So we plan digitally, and we use a guide there to virtually place an implant to create a safe zone here. So I could place a nice 3x10 implant. So we decided for that, and we made a surgical guide after virtual planning. I kept the guide little longer with the offset of nearly 12 mm, so I can have a longer drill, so I can have a longer sleeve, so I can have a much more precise implant drilling. Because of rotational movement, it sometimes gives you vibrations, and you can go off the line. So to avoid that, I use a long sleeve, selection of long sleeve, and really 12 mm offset. So once the guide is made, placed in the mouth, used a punch to remove the soft tissue, because I had a nice peri-implant connected tissue here, so need not to worry about it, how much thick connected tissue, and I can go ahead with the punch. So after I did that, I placed the implant surgically, and as you can see, I nearly escaped going into the periodontal space of the adjacent two teeth. And as I mentioned, if I go one slide back, as I mentioned, I am safe. I had only 1.2 or nearly 2 mm space there, but because of the taper tip, I was safe a distance from my periapical region of adjacent teeth. So after the implant was placed, Normally I placed a long gingival tissue, so I can have more of a concave profile, so I can have soft tissue and hard tissue moving over the implant. So deeper the implant I placed, a better soft tissue profile I will have with my case. So this is post 3 months. As you can see, the papillae with nice stippling and nice coverage over my temporary, and then I took the impression. As you can see, my customized implant, I had nice concave, the bone start walking. So this is after 3 months, as the bone is nicely around my implant matured, and finally I given a ceramic crown. So this is post 6 months, the case is doing fine, and post 2 years. Now this is another case, immediate implant loading and extraction, a function loading where we have a pocket formation, but the tissue is a type 2 type where we have lost the buccal plate but sufficient soft tissue. So we might have to do a hard tissue or a small grafting, but not to do a connected tissue graft. So it's more of a Gallucci type 2 type, like 1B. So we go ahead with that, and as you can see, there's a chronic infection periapically. So this is was the case. So there was no buccal plate, so as you can see here, but we still have a thin palatal bone there, and there was no buccal plate, and periapically there has a granulation tissue and a pocket formation. So we did the implant planning. As you can see, the shadow of implant placed there, so more than half the implant is in the primary bone with the stability. As I told you, the more than 3 mm should be in the healthy bone for a periapical stability of my implant. So this was planned, and implant was surgical guide was made, and again I use a long, here I use a tunneling knife to remove the soft tissue. I didn't scrape much of granulation tissue from the periosteum there, but I removed every bit of granulation tissue from the bone socket and the walls. And then I have slit membrane, a bilayer membrane, collagen membrane between periosteum and the socket wall of fenestration, and then I did the implant placement. So most of my bone debris should stay inside the socket, so I used, without irrigation, low RPM, high torque. So collected as much as bone I can, and then I placed the implants, and as you can see here, the implants was placed, and then after that I placed the membrane and some late resorbing bone graft, because it was more than 2 mm the jumping distance. But as you can see, I placed the implant well within the triangular palatal and mesodistal bone, so I had a support from palatal bone as well as mesodistal bone. So I did a long vertical lock suture, we call it Gatlow sutures, so just not to have too much stress on my incisal line or a papillar area, so I should not have a retraction of papilla. Then I did the impressions and transferred it to the model. This was the old case, pretty old case, so the digitalization in India was a little bit not complete that time. So we did a modified peak abutment, and we made a temporary crown, and we placed the implant in the patient's mouth with a PMMA crown. As you can see, the papillae are well sutured there. Now this was the bone condition with a thin black line showing the bilayer membrane there, and that was same day when the patient walked out. This is after 3 months. As you can see, the membrane is still there, but the bone start under modification slowly. And this is after 3 months. This was the temporary crown, still papilla nice. Post 6 months. As you can see, the cortical plate start coming back in, thin cortical plate. As you are aware that periodontal periosteum is responsible for making cortical plate, the BMP comes from the periosteum, decides the thickness of the periodontium. The vernical needle-like projection into the bone decide the thickness of cortical plate. So we created a exact original anatomy of the bone around our implant with a sufficient bone with a nice physiological features of body we have used there. So now this is post 1 year, and this is what the we have achieved the aesthetics in this case. Now I'm going little hurry with a sectional loading for the interiors. So here we have a fractured tooth. 2014 the patient came, we did a rehabilitation for the lower jaw. The upper jaw had some issues. This was actually done in 2009, and the patient came back to 2015. A little bit of the perios in the midline, there was a space coming in, so that was suggestive of some problem pathology there. And then the patient came back in 2016 as the space start coming back. So this was in 2009. This is 2000. Later, after rehabilitation, patient came in 2016. The midline, the diastema start increasing. That is suggestive that there's something wrong with the roots. So we removed the crowns, and then we saw most of the crowns are damaged. So we extracted the thing, remove all the granulation tissue. We didn't place any membrane because the socket, the buccal plate was intact. So we just cleaned it, used the guide to place our implant and more in a palatal position there. And this was the position, the multi-unit abutments were placed. As you can see, it's not parallel though, but they become parallel by using multi-unit abutments. And then we pick up the impression, and we gave the patient a temporary. And this is post 1 month when the patient came for a checkup. The papillars and bone around it better. We didn't lose any buccal profile or a labial profile of a patient or a stippling or an attached gingiva here. So after the temporary was given, we just checked. This was a temporary given out of the occlusion there, and then we have taken the final. This was the post 3 month, the condition of our papilla and bone and facial profile. And then we gave the final prosthesis screw retained restorations. And as you can see, the midline is gone and papillas start moving in between the spaces, and we haven't lost any bone level. It was still fine. Most of the implants were submerged 2 mm, and this is later on after 2 years. This is 2020 after 2 years. This is 2021, and this is from here to here in 2022. So as you can see here, we have a nice facial profile, stippling. We haven't actually, there's no change from original. If I go one step back, as you can see here, the papilla and the shape of your facial profile is exactly the same. So there's another case. I'm taking a liberty to finish this case. This is close to me. This was done in 2001. This case, immediate loading, but we didn't have multi-unit abutment that time, so we done cemented restoration. But now the patient has some issues with the lower ones. So we removed the lower ones. He's a controlled diabetic, and we removed the teeth. Digitally we plan, virtually we remove the teeth. We made a surgical guide as we can. We have different software to use that. So where we virtually remove the teeth where we need to place the implant, and then we made a guide here or a marginal line just to mimic the tooth there, and we created a prosthetic profile of the patient without really putting any. So wax-up was created in the patient's mouth with the software, and then these are the 4 wax-up created, implant positions placed. Here we purposely create a 15-degree variation anterior, posterior and buccolingually. So we have to counter the intrusion and extrusion forces. We are planning to do a functional loading in this case, and planning was done, and it was further guide was made, and we used a open face sideways guide there because posteriorly it's difficult to open such a big mouth to place an implant here. So guide was milled. This is autoclavable material, and then we placed the implants, and it was loaded on the same day. And this was made with a PEEK material with a composite on top of it. So the PEEK material was used to dampen the forces, and we made it in 2 phases. we made the wax up and then we splitted it with a framework with a PMMA veneering material, and then we placed that in a patient's mouth and screwed. So it's a screw restoration with a PEEK and PMMA. And later on, as you can see, the screw holes are perfectly where it has to be, and the next day it was loaded. So from here to here in 24 hours. So this is with the PEEK restorations with the PMMA and temporaries, and this was the final restoration with a PEEK and composite material. The definitive restoration given after 2 months, and patient left India, and then 2019 this was given. Then the patient came back later on for the final ceramic one. The lower ceramic implants were placed and final ceramics were given there. So that was 2019. The 2 implants were added and final process given there. So this is another case with the immediate functional upper and lower loading full mouth, and where we created the temporaries first virtually, and then we used a surgical guide to place implants and loaded the prostheses on the same day. So extractions done and the implants were placed with 2 long implants with 2 short implants in posterior region. So it was all in 4 with a long implant engaging the cortical crestal bone and the buccal cortical, and then 2 short implants, and then it was loaded. This was the temporary in the day 1, and this was later on changed into the final prosthesis, and this was final process given to the patient. So this is another case. I'm just finishing with the last case here. It was an extraction done. The bridge was broken and there were hardly any roots there, fractured roots were there. We used the existing broken zirconia as a framework, a guide, and then the lower one also a functional immediate loading, and upper ones also created similarly. As Namdeep said, we can place the implant tilted and we can use multi-unit to make them parallel. So to counter this, as you can see here, there's a lot of angulations are given there to the implant to accommodate the best available bone to have a best primary stability, but in the ambit of the prosthetic angulation or multi-unit. So we can have all the screw holes coming exactly where we want to. So I'm passing this slides a little faster so I can complete a presentation. So this was the surgical steps. As you can see here, all the holes are on the occlusal where we want it to be. That's the beauty of digital planning, virtual planning, and the implants were loaded on the same day. And the patient was recalled after 6 months. As you can see here, the bone all healed up nicely, and this was also a posterior functional loading in lower ones, and this was the final crowns given to the patient. So, and this is last case, additional case, also a immediate loading and a sectional upper maxilla. All on 4, this is the indigenous implants made in India, and all on X was made on the same day. We given the temporary, the denture was converted into the prosthesis, screw return process on the day 1 using a fast delivery protocol. And then later on the patient was given a final ceramic restorations, hybrid restorations later on. So this is from a single tooth to a multiple tooth we can do immediate loadings. This is all sectional loading cases where we do use an indigenous implant designed by me with the help of iFix. So these were sectional loadings and immediate single loadings done. So many cases are there for full mouth with the digital planning. As you can see here, we have all on 6 protocol immediate loading, and later on, so from single tooth to a full mouth can be done with immediate loading protocols. This is post 4 years. We haven't lost any bone As you can see, we haven't lost bone. So this is the beauty of digital planning and immediate function. So if you remember the first, I can show you many cases like that when the function loaded. So these are all rapid conversion of dentures into the final restorations, and later on changing out to final restorations. So this is all the success story of digital planning with the titanium CAD/CAMs, with the temporaries. We can load them and give them a very nice looking restorations. This is my office where I work. That's my OT where I have a scanner also. And this is my prosthetic rehabilitation here where I do a chaired side dentistry immediate loading on the same day. This is my team. I have an in-house lab for all my prosthetic needs. And this is my beautiful team, and because of these guys, they all are the reason of all the successful smiles we have given to the patients. So knowledge can only be got in one way, the way of experience. There's no other way to know. That's my spiritual guru, Swami Vivekananda. Whenever I lose or lost my way, I normally read to his philosophy. It gives me always a reason to find a new way to overcome my failures. Thank you. Jai Hind.
Thanks, Dr.
Sorry, I had to fasten up a little bit. So
yeah. So, any number of cases we have discussed.
So no, sir. This is digital dentistry is actually evolving every day with advent of new technology here. And nowadays, as Dr. Navneet was talking about photometry and this is also coming in. Face scans are coming in, but the 30 minutes is too less a time to talk about digital dentistry because it's no more a simpler branch of implantology, because implants have become too evolved now. So we know it's like from analog to digital. Digital also is absolutely another chapter in advancement of implants.
Anybody want to ask any question? They can unmute and they can write in the chat box. No questions.
I hope I was not too fast.
But you know, the cases and the success story is great actually. Digital planning is very, very good to, get the restoration.
Yes, we can actually predict the outcome the day we do the scans and we do the VEX-ups. Nowadays, with the AI-based planning softwares like RealGuide and other, it makes our life very simple. I think everybody should learn this because they will understand the prosthetic component of implants. If you can understand the prosthetic and implant physiology, then I think every case can be successful.
Yes. Okay. So with your permission, we should move to our next speaker.
Thank you, sir. Sorry for taking 10 minutes extra.
No. Our attendees are enjoying this lecture.
Thanks for inviting me for such a wonderful platform, sir. Thank you.
Yes. Okay. Thanks. Dr. Sharad, could you unmute your microphone, please? Dr. Sharad, are you there?
Yeah, hi, am I audible?
Yeah, you are audible. Yes. So moving to our next speaker, and he would be throwing light on CBCT made simple, navigate, smarter, diagnose better. With formal introduction to Dr. Sharad Sahai. Dr. Sharad Sahai is a consultant maxillofacial radiologist and the director of DMD imaging and over 12 years of experience interpreting 50,000 plus CBCT scans and more than 1 lakh OPGs so far. BGS from Lucknow and an NGS from Goa. He was regional director at AAO MFR from 2011 to 2013. He set up India's first specialized 3D dental imaging department of DCA Imaging, New Delhi, a keynote speaker at ICGMFR, Hiroshima 2011. He has published in leading international journals including Dentomaxillofacial Radiology and Dental Traumatology. He is founder and CEO of Dentry Technologies, a cloud-based dental PACS, PACS, and RAS platform, and previously served as CEO of DIO Digital Implant India, leading digital navigated implant planning services. Over to you, Dr. Sharad. If I missed anything in your introduction, you can add on and you can start your presentation. Your slides are visible, you are audible.
Thank you very much, Dr. Nurul. And thank you, first of all, for giving me this opportunity to be here on the IDDCON 2026. I am a maxillofacial radiologist, did my master's in oral medicine diagnosis and radiology from GDC Goa. And in the short 30-minute time that we have today, I would like to talk on some very simple things about cone beam computed tomography or CBCT, with the emphasis on trying to do it yourself, trying to make most of this rather transformational imaging modality in dentistry. So I have a practice of dental and maxillofacial imaging since 2011. Before that, since 2007 to 11, I was working in a super specialty diagnostic center in the dental, set up a dental imaging department. We have offices across NCR and also in Western India, in Goa. And more recently, we've also evolved from just doing cone beam scans to what I heard Dr. Lamba also mentioning in the end, 3D face scans coupled with cone beam CT scans, which is now the new age combination of diagnostic data, which can be merged with the help of a lot of AI-driven platforms to enhance the information that we can provide for implant cases, orthodontic cases, face-driven treatment planning. But in today's discussion, let's begin with a very simple thought. When we talk about 3D imaging, when we talk about cone beam CT, what are we exactly doing? What you see on the screen right now is a map. And I'm sure all of us are pretty used to now looking at maps thanks to Google Maps and other maps providers. Even places where we know the way, we like to make sure that we are taking the fastest route, the shortest route using the maps. So in this world, 3D world, would you trust a 2D map to navigate the 3D world? That is the important question. And that applies so much to dentistry, because you are not dealing with two-dimensional objects in dentistry. You're dealing with teeth and bones and gums and soft tissue and the other stomatognathic structures, which are all three-dimensional in nature. So how can we continue making all our treatment planning, diagnosis, and judgments based on just two-dimensional X-rays, whether it is intraorals or panoramic X-rays or other types of X-rays? Which is why 3D becomes the most important thing that we need to be aware of. How to use it, when to use it, most importantly. So when should you think of 3D navigation in dentistry? You should think of 3D navigation when it's about dental implants. One implant, multiple implants, full arch cases, any type of implant scenario. You should think about 3D navigation when it comes to root canal anatomy, endodontic issues, undiagnosed or unexplained cases of pain, when the patient presents to you with pain, but you're not able to prima facie see what's the reason for the pain, particularly related to the teeth or already endodontically treated teeth. Management of impacted teeth, temporomandibular disorders, including the airways, and obviously any pathology. So these are the key areas where one should think of 3D navigation with cone beam CT in the field of dentistry today. So today I will be talking about three very basic or elementary things related to cone beam CT. The first, what are the basic principles of cone beam CT imaging? Relevant for a practicing dentist, a student of dentistry, all of us. How do we read images? or what are the types of images, which are the ones that should be used for reading what type of issue, and what are the most important clinical applications. How does CBCT make a difference in different scenarios across clinical dentistry? So let's start with the basic principles. Today, for most practical purposes, we are dealing with cone beam machines or working with cone beam machines, which are called as second generation hybrid machines. These are second generation because the ones before these, which came towards the end of 1999 or the beginning of this new century, were the ones that were capable of doing larger scans for the full face, scans for just the entire maxilla and mandible, but not capable of doing smaller scans or localized scans. The second generation of machines did two different things. One, they were able to collimate the X-ray beam and give the ability to do sectional or localized scans so that you only scan the area that you want. The other important technological enhancement in these machines is that the detector technology changed so that with the same detector, you could now do the cone beam CT and also panoramic X-rays or OPG X-rays. So that's why the term hybrid comes in. You don't need two different machines, one for OPG and one for CBCT. The same machine can do both panoramic or OPG and CBCT. And if the cephalometric arm is attached, then even the cephalometric radiography can be done with the same machine. Another principal difference to understand before we move on is how CBCT works. This image is a representation of how cone beam CT, represented by figure A, is different from medical or spiral CT, represented by figure B. As you can see in figure B, in a medical CT, the patient generally is lying down on a table, a flat table, and the table incrementally moves forward or keeps moving ahead towards a donut-like gantry, where there is a source of X-ray on top, which emits a thin fan-shaped X-ray beam. That fan-shaped X-ray beam passes through small areas of the patient's anatomy, and that attenuated X-ray beam is then captured by multiple rows of detectors which are located below the table. That is the physics of how CT works, which is why the table keeps moving and small parts of the anatomy are scanned. In cone beam CT, as you can see from this image, first of all, the patient is not lying down. The patient is either sitting or standing. And there is a horizontal gantry, as I showed you in the previous images. And the X-ray source emits a conical beam. Therefore, the term cone beam CT comes. Cone-shaped X-ray beam is emitted from the X-ray source. It passes through the patient's anatomy and it is captured by one single large detector as the machine moves horizontally around the patient's face. This difference in technology is important to understand also, because it is this difference that allows cone beam CT images to be useful for dental issues like endodontics, periodontics, fine resolution images. It also enables cone beam CT scans to consume as much as 20 to 25 times less radiation compared to medical CT or spiral CT, which is why cone beam CTs are justifiable for dental use, but the spiral or the medical CT is not justifiable for routine dental use. It could be justified for bigger issues like maxillofacial trauma, maxillofacial pathology, or other dysplastic lesions which require contrast enhanced imaging. But cone beam CT with higher resolution, less radiation becomes the default 3D modality of choice to visualize the bones and the teeth in the dental and maxillofacial area. So in a cone beam machine, when a patient is standing within the machine, during the path of the horizontal motion of the machine, multiple Ceph-like images, which are called as basis projections, are captured all along the path of motion of the machine. At the end of the machine's rotation, all of these are clubbed together by a computer program to construct what is called as a 3D volume. This is how you get cone beam 3D volumetric data. So today's cone beam machines offer us the ability to do multiple fields of view or FOVs. There are multiple selectable programs on a machine console which allow us to scan according to our requirement. As you see, you can select which scan size is required for the case. If it is for the purpose of dental implants and you need to scan the single jaw or both the jaws, maxilla and mandible, you can select that program. If you need a smaller scan for a localized area, 1 to 3 teeth, then you can select the smaller incisive, molar or premolar volumes. When you want to scan the entire face with the TM joints or just the maxillary sinuses, you have dedicated programs for that. So we can scan according to our requirement. Only the primary area of interest gets irradiated and you get information in that area. So all machines may not have the maxillofacial or sinus modes or the TMJ modes, but the full capability machines will have these modes also. So when we do a sectional scan, this is the kind of area that gets covered, which is generally about 3 to 5 teeth, depending on the patient's jaw size. Typically, a sectional scan is about 5 centimeters into 5 centimeters in size and is good enough, like I said, to cover about 3 to 5 teeth. In a single arch scan, the entire maxillary or mandibular arch can be covered, where you can see most of the maxilla here. But depending on the patient's jaw size, again, the pterygomaxillary regions may not be completely covered. When we do both jaws, we have the ability to visualize both the maxillary arch and the mandibular arch, minus the complete coronoids and the TM joints. This is in the dentoalveolar modes. And finally, when we do the large field modes or the more full face modes, then we are able to scan the entire face, which includes the maxillary, mandible, joints, in the. Then it is also important to understand that typically when we do 3D imaging, anybody, our first instance of understanding is that this colorful image here is what is the meaning of a 3D scan. However, unlike the popular belief, the meaning of 3D is that you are able to visualize any one object. For example, here there is a trauma and there is an intrusion in injury to this maxillary central incisor. The ability to visualize that maxillary central incisor in 3 perpendicular planes, the X, Y, and Z axis, the axial D2, the coronal D1, and the sagittal D3. That is the real meaning of 3D imaging. That it gives us the ability to visualize any object in 3 perpendicular planes so that we can get more detailed information about that object. When we do a cone beam scan for any patient, any size, one big difference between 3D imaging of cone beam CT and X-rays also is that when we scan a patient, actually we scan everything. We scan the entire face, the soft tissue, the nose. We scan also the bite block onto which the patient is biting. But it is the enhanced or advanced software that allows us to be able to only use the useful parts from this image. So below what you see are the same images of the same patient. But what has been done is that through software processing or image processing, only the hard tissue structures like the bones and teeth are visible. The soft tissue part of it seen in the upper images, which are anyways not diagnostically useful or helpful, have been eliminated. This is the big breakthrough in dental cone beam imaging compared to any other form of dental diagnostic X-rays. Image segmentation goes one step further, which means that from these sets of images that you see in the first row and the same images you see in the second row, there is a difference. The difference is that we have been able to crop out parts of the image that are not useful for diagnostic purpose, like the cervical spine, like the stylohyoid complexes, parts of them seen in the upper image, like part of the hyoid bone seen in the upper image, and retain only parts of that image which are diagnostically helpful to us. This gives us the ability to be able to process images according to our requirement. And that enhances the depth or diagnostic capability of cone beam CT. Now let's look a little bit about reading cone beam CT images. When we talk about reading cone beam CT images, it is important to understand that there are 3 or 4 different types of main image sections. As dentists, unfortunately, in our days when we did our bachelor's and master's until more recent times, formal education of cross-sectional imaging or 3D imaging was not even part of the graduate or postgraduate curriculums. But today's dental students and surgeons have far greater exposure. It is important to understand that the axial or the horizontal images are the ones that give, these are the axial or the horizontal images, which allow you to get an overall perspective of the jaw. So for example, here we are seeing the mandibular arch with multiple implants placed in that mandibular arch. And one of the implants, as you can see, is lying in the floor of the mouth, medial to the mandible. The next is the coronal images. These are images acquired by sectioning along the the coronal suture, and they give the anteroposterior view of the jaw. So here you can see the mandibular implants. You can see the orange mark mental foramen and the inferior alveolar canal. And you can see the implants along with the buccal and the lingual cortices of the alveolar bone of mandible. Finally, you have the third type of image section, which is called as the sagittal section, which is taken by sectioning along the mid-sagittal suture. Now, these are taken obliquely along the axis of the mandible. That is why they are showing you this picture and not straight along the mid-sagittal suture. They are also helpful to ascertain the mesiodistal relationships of teeth and other structures. Let's take an example here. In this image, you see all 3 types of key image sections: the axial, the coronal in the center, and the sagittal on the right. And it is plainly evident that there are 2 impacted canines which are visible. Is there a problem with these images? Perhaps yes. We can see the 2 impacted canines. But what is the problem? That we don't see them completely. We are not able to see where are the root apices of these canines. We are not able to see beyond a certain area about what is their relationship to the nasal floor. What is their relationship to the adjoining teeth? This problem arises because these 2 impacted teeth and so many other structures in the oral cavity or in any patient's mouth are not straight structures. They are not straight. They are generally curved or they are angulated, which means that these true perpendicular XYZ axis images do not solve the problem. Hence, we need to learn and understand that if we just orient our image planes along the long axis of the object that we want to see, then we get a much better visualization. So the moment we aligned the planes to one of those impacted canines, the right canine, you can see that the canine root is completely visualized. There is a slight mesial dilaceration of the canine root in the apical area. The apical third of the root is indenting the nasal wall. And here you can also see that it has a close proximity to the anterior wall of maxilla also. This is the information that the orthodontist or the oral surgeon need to be able to plan their treatment. The same principle of oblique planes or oblique slicing applies to all areas of dentistry, including root canals, endodontics, periodontics, impacted teeth, except for dental implants. And we will come to that. So if you can remember this part, it's going to be very helpful. The last but not the least, or perhaps the most well understood type of image section is what is called as cross sections or paraaxial sections. Here, and I think as dental professionals, most of us are most familiar with these type of sections because they are most routinely used for the purpose of dental implants. These sections are created by marking an arch, marking points along the mandibular arch from midline to periphery or from right side all the way to the left side. What that does is that once you mark out those points, the software automatically opens up the mandible and creates an OPG-like picture. Once it does the OPG-like picture, it also cuts fine sections which are seen below. These are called as cross sections or paraaxial sections, which give you a buccolingual view of the alveolar bone. This buccolingual view allows us to be able to measure the available bone width and height, particularly in the case of dental implant planning. It also enables, the software also enables us to be able to mark out the position of the inferior alveolar canal and the mental foramen, as you can see from this orange marking all the way here on the panoramic and also on the cross-sectional images below. So we can completely measure the bone width, the bone height, and also where the vital structures are located. That is the importance of these cross-sectional images. So let's quickly move on to some clinical applications of cone beam CT. As I said, the key applications, one of the key applications is pre-implant bone assessment or for the purpose of dental implantology. Our objective for implant bone assessment, particularly pre-implant bone assessment, is to determine the bone quantity, the height and width, the bone quality, which is the density or strength, the long axis of the alveolar bone, the morphology of the ridge, to determine the internal anatomy and jaw boundaries, and also if there is any pathology in the area where we want to work. So when we talk about ridge anatomy, let's take this very simple example. This is also an illustration of why even for one implant nowadays, using just panoramic images or two-dimensional X-rays is not good enough. Here, if you focus your attention on the missing central incisor in the mandible here, based on the panoramic image, it looks like there is an adequate amount of bone present in that area. However, when we actually do the cone beam CT and look at the cross-sectional image, this is what the cross-sectional image from this area looks like. It's an hourglass kind of a configuration because there is a marked constriction at the junction of the alveolar process and the basal mandible, because of which the amount of bone actually available to place an implant is much less than what it appears on the panoramic. Plus, there is the risk of a lingual cortical perforation, and we know that in the anterior mandible there can be, sublingual venous plexus, any inadvertent injury to vital structures in that area can lead to a life-threatening hematoma by raising the anterior floor of the mouth. So one has to be particularly careful. Similarly, this is a cross-section through the molar region of the left mandible. Here, as is seen on the OPG, same on the cross-section, the bone volume or the bone height does not appear great. But when we see the cross-sectional image on the CBCT image, we see one more important problem, which is that in the crestal part of this image section, there is asymmetric resorption buccally, which means the amount of bone available to actually place an implant or use for an implant is further reduced because you'll have to create a crestal osteotomy to get to a flat table of usable bone where you can place at least a 4 millimeter implant, which may be perhaps difficult in this area. So understanding the bone morphology is very important. As I already said, for the purpose of dental implant bone assessment, cross-sectional or paraaxial images are the key. Nowadays, modern CBCT platforms are also enabling automated or AI-driven generation of these curves and marking of these nerves, which makes it a little more simpler for the uninitiated users to be able to work with these images. When we talk about bone morphology, there can be, all of these are examples of different types of bone morphology from the same part of the mandible. All of these are sections from the mandibular second molar area. So depending upon when the teeth were lost, depending upon the patient's own factors, the strength of chewing, strength of musculature, dietary patterns, and amounts of resorption and remodeling, it can show any different types of morphological variation. One needs to be sure what are we looking at before we plan the implant in that area. When we talk about bone height, we understand that bone height means that from the crest or subcrestal area, you have to measure the bone available till the nearest vital structure. So these are three different cross sections from the three different parts of the mouth. The one in the center is a cross section from the maxillary molar region. The one on the right is a cross section through the mandibular incisor area. When we look at this cross section, the red line there shows you the total bone height available from the crest all the way to the inferior cortex. But actually, the bone available to place an implant is only this much, indicated by the green line, because below that is a very fine neurovascular canal exiting onto the lingual aspect of the mandible, generally in the midline or in the paramedian region of the mandible. This is the mandibular lingual incisive canal, which carries fine neurovascular bundles and opens into the sublingual area, anterior floor of the mouth. So bone available is only this much. In the central image of the maxillary molar, it's straightforward from the crest of the ridge to the sinus floor. That is the amount of bone available. Not much problem here. In the image on the left, this is a cross section through the mandibular canine region, where there is a canine, there is a periapical radiolucency. It appears as the bone is available from the crest here all the way to this part, generally around the basal part of the mandible. But the bone actually available in this case is barely this much, because you see that there is a large fenestration defect of the buccal cortex. You don't see the buccal cortex around the root. The moment this tooth is extracted and the periapical rarefying lesion is curated, there will hardly be any bone, which is why it is so important to study the morphology, the cross sections, and the amount of bone carefully before one decides on what to do. The other important and very, very vital area of cone beam interpretation for implants is bone density or bone quality. Now, I generally prefer to refrain from using the word bone density, where many of you would be familiar that there is this concept of bone density or quality based on the MISH classification. There is a D1 to D5 classification system where bone density types are defined according to the Hounsfield unit values obtained from CT. But what is important, more important to understand today is that this system of classification is not applicable to cone beam CT. Current dental literature is very unequivocal and clear on the fact that any cone beam CT machine from any manufacturer, it does not give you the Hounsfield unit values like medical CT or spiral CT. What it gives you is a grayscale value. That grayscale value is variable. In our own practice, we have also over the years checked, researched on this, done cone beam CT and CT for the same patient or specimen, measured the density values in the same area and found variations. So the this system of D1 to D5 based on grayscale or values from CBCT machine numbers is not reliable. What is preferable? Let's look at some examples. So these are all cross sections through different parts: maxillary molar, mandibular canine, mandibular second molar. And what is important to see in all of these, when we assess the bone quality, what we do is that we look at the cortical integrity, the cortical thickness, trabecular shape, number, and spacing. So in these images, if you see, let's take the bottom right image of the mandibular second molar. There's a thick cortical outline, and there is a dense marrow which has very few trabeculae. It's very dark, very lucent. So it's osteopenic marrow. We know that it is a low density bone. Similarly, in other examples, the cortices are very clearly outlined. The internal trabecular bone or the cancellous bone is showing few trabeculae. They are spaced out. So generally, it is tending to be on the lower side of density. And that is how we assess the bone quality with cone beam CT. The other important aspect to see is the other end of the spectrum. So like here, you can see these are sections from the mandibular molar. All the sections show you a very distinct cortical outline, but centrally inside the cortices, there is hardly any trabeculae. It's completely radiolucent. So this is osteopenic marrow. This is spongy or low density bone. For the purpose of dental implants, it is important to know that you are not dealing with this end of the spectrum. or with the extreme other end of the spectrum where it is very high density bone, hardly any intertrabecular spaces. Thankfully, most dental surgeons and dental professionals are already familiar with looking at bone trabecular pattern on intraoral x-rays and even panoramic x-rays. So try and apply the same knowledge onto these sections when you're reviewing these sections for the purpose of studying bone density for your dental implant cases. That's how we do it in our practices. Once we've had the chance to look at the morphology of the ridge, the height and width of the bone, the quality of the bone or the density of the bone, then we are in a position to decide on placing and planning a virtual implant depending upon what software platform we are using. So here, this is a virtual implant. Typically, when we place a virtual implant, we bear in mind considerations like a clearance of 1.5 millimeters from adjoining teeth, a clearance of about 1 millimeters from buccal and lingual cortical plates, 2 millimeters to 3 millimeters from the inferior alveolar canal or mental foramen. And if there are two adjoining implants, an inter-implant clearance of about 3 millimeters. Those considerations are the generally acceptable considerations for planning implants virtually. One more caveat here is that, see, this planning that we're doing, this is non-prosthetically driven planning because we don't have the occlusion. Nowadays, as I'm sure you've heard in the previous lectures from Dr. Lamba or before that from Dr. Navneet, it is possible to do prosthetically driven planning by merging the cone beam data with patient's intraoral scan or digital impression data. In that case, you can plan the implant, and on top of that, you can even plan the prosthetic, which allows you to do a more comprehensive planning. Here, for the purpose of planning the implant, understanding the implant dimensions and positions, this is good enough as a starting point. So as I mentioned, it's possible. This is what prosthetically driven planning looks like, that you have an implant. On top of that, this brown line is what the gingival outline, the soft tissue outline is from the intraoral scan. On top of that, you get the available prosthetic space. You can have a virtual crown. These are the guide sleeves. So it's possible to do a more comprehensive planning with the help of cone beam CT data merged with intraoral scan data. Let's move on to the next set of applications, which is for endodontics. And in our practices, we have seen this is the fastest growing part of cone beam CT practice for us. It is the bread and butter. It is the backbone of clinical dentistry. And believe me that it has more applications and more widespread applications than even dental implants. Let's see how. First of all, cone beam CTs allow you to visualize any type of variations of dental canal anatomy, root canal anatomy. You can actually look at canal anatomy of any different configurations, multiple canals, splitting, merging, splitting again, if the cone beam CT scan has been done properly. Let's start with a small example. This is a panoramic periapical radiograph for a maxillary molar, where you can see part of the tooth structure is broken. There is a periapical radiolucency. There is also some endodontic restoration inside the canals. This patient was referred for a cone beam scan. When we did the scan, or when we do a scan of any such case, we are trying to achieve two things. One, we are trying to see what is the problem. So unlike the periapical radiograph, the moment I see these cone beam images, let's look at the axial image first. I can see that there is a large radiolucency around the roots, but also there is a radiolucency all around the tooth. There is expansion of the buccal cortical plate, thinning and expansion also of the palatal cortex, which immediately changes my provisional diagnosis from a periapical abscess to a dentoalveolar inflammatory lesion or a dentoalveolar abscess. Second, I can see in the sagittal image, in relation to both the mesiobuccal and distobuccal roots, there is a large radiolucency and it is displacing the floor of the maxillary sinus. Same is happening in the coronal image with regard to the distobuccal and palatal roots. The floor of the maxillary sinus is symmetrically displaced and thinned out. The other important thing to see is the gray area above the roots and the sinus floor is the maxillary sinus cavity. That cavity is supposed to be full of air, which means it's supposed to be pitch black like this. But it is gray, which means that there is secondary involvement and inflammation of the maxillary sinus also. So this is the what. What is the problem? My first job. The second part of the job is, why is this problem happening? So let's look at the mesiobuccal root. Typically, in such instances or such cases, we localize each root one at a time and then try to find why this problem is happening. So when we localize the mesiobuccal root, same way as I localized the impacted canine previously, by aligning the planes to the long axis of this root, I'm able to see that there is a partially filled canal in the mesiobuccal root. Also, when I look at the coronal image or the buccolingual image, I can see that there is another accessory canal or an MB2 canal, which is totally uninstrumented. So higher up in these axial images, I was able to see two distinct canal orifices, the mesiobuccal 1 and the MB2. And further up in these buccolingual sections, you can see MB1 and MB2 very clearly. What this explains is the combination of partially filled MB1 and uninstrumented MB2 explain the large rarefying lesion in relation to the mesiobuccal root, which is concomitantly also involved the distobuccal root. When we evaluate periapical lesions, so
on CBCT scans,
in these periapical lesions,
optimize viewing conditions for evaluation, triangulation,
I'm sorry, I seem to have got stuck with the video. Let me try to go back.
on CBCT scans. The learning objectives for this particular video include optimize viewing conditions for evaluation, triangulation or localization of the associated tooth or teeth and the periapical lesion, and finally the assessment of the periapical lesion and the tooth endodontic anatomy to form a conclusion about the pathology. So we will start with an example of a sectional CBCT scan of the maxilla. To begin with, we will adjust and optimize the viewing conditions in terms of the brightness and contrast. And we will broadly zoom in to the area of interest, which is seen here in the right anterior maxilla. So for gross evaluation without any plane localization, let us start with the axial sections. When we scroll in the axial plane from the cranial to the caudal aspect of the volume, we can visualize that there is a rarefying lesion in the right anterior maxilla and hard palate area, whereas we see relatively normal anatomy with a focal periapical lesion in the left anterior maxilla. Going further, we can visualize that this lesion is extending from the paramedian region and coming up to the canine area. There is associated changes with the adjoining labial cortex and perhaps proximity to the nasopalatine canal with the lesion. As we come further down, we can visualize that the lesion is rather large in the anteroposterior and transverse dimensions and has a definite association with the nasopalatine canal also. Further inferiorly, the lesion can be seen to be associated with the maxillary central and the lateral incisor teeth. With these gross findings visualized, let us now go back to the multiplanar view and try to localize the lesion in the three perpendicular planes. So we begin with the axial plane where we can visualize the lesion and then go to the sagittal plane. The sagittal plane alignment needs to be adjusted according to the long axis of the alveolar process or the lesion. And the moment we do that, we get a different visualization of the lesion on the coronal planes. Here, once again, from a dental standpoint, the alignment in the axial section can be adjusted further so that it aligns with the curvature of the maxillary alveolus. And the moment we do that, we can visualize the lesion on the coronal planes even better. So now the extent of the lesion can be visualized on the coronal, on the sagittal, and on the axial sections.
So similarly, it is possible to also look at an already treated tooth. In this instance, I'm showing you an example where this patient came for a scan because there was an already endodontically treated first molar. Patient had pain. So the first thing that we had to do was to find out why the pain is there. When we started looking, we could see that periapical lesion with a mesiobuccal root. After that, we localize each root at a time. First, we localized the mesiobuccal root and found the MB1 canal, which was instrumented, and the restoration was going up to the subapical area. So really not too much of a problem over there. But then the moment we look at the cross-sectional appearance of the MB root on the axial plane, you see it's a broad root. Always suspect there would be another canal. And when we looked for it by adjusting the image contrast, by adjusting the planes properly, we were able to visualize a distinct mesiobuccal 2 or an MB2 canal that was going all the way and merging with the MB1 canal in the subapical area. It is this canal, uninstrumented, which was obviously the reason for the pain and the periapical lesion for this patient. Another important application in modern endodontics or any dental practice is to find out cracks using cone beam CT scans. Typically, when there is a crack, there will always, particularly a crack in a localized area, there will be an isolated infrabony defect in the adjoining wall. So as you can see, there is an infrabony defect with the distal root of this first mandibular molar. And on the adjoining distal wall, marked by these blue arrows, you can see the canal, as you can see the crack that has been involving the cervical crown and the root trunk of this distal aspect of the tooth. The next set of important applications for day-to-day dentistry, clinical dentistry, is the visualization of impacted teeth. Here, I've taken one very simple example. This is a patient who had multiple impacted or unerupted teeth in the mandible. As you can see with the colorful volume rendered image and the adjoining sagittal image, there are multiple tooth-like structures which can be seen at various levels inside the mandible. Let us focus our attention on this tooth in the close to the angle of mandible, and around that there is a large radiolucent lesion. Here, when we start localizing these kind of structures, it is not just enough to say that, oh, it's a mesioangular impaction. But when we localize them in all the three planes, like what we have done here, we are able to decipher a lot more information. First, what is the relationship of the inferior alveolar canal with this impacted or embedded tooth? As you can see here, the roots are only calcified till cervical third. Still, is it feasible to think of extracting these? See the blue arrows showing you the position of the inferior alveolar canal in this buccolingual image. The inferior alveolar canal is closely abutting the root. So any instrumentation in this area, it's possible to have a transient or some form of nerve injury. to this structure. It is very important to have the proper localized images and get full visualization of the root positions, their association with the vital structures for impacted teeth, and then plan for the management. Last but not the least, I would move on to evaluation of the temporomandibular joints with cone beam CT, which is another very, very important area because there is a lot of patients who come with pain, relate pain, clicking, deviation, difficulty in mouth opening, chewing, who are very often it's difficult to ascertain what imaging to do, how to go about diagnosing their problems. And cone beam CT scans for the temporomandibular joints give us a lot of information. So let's quickly look at the anatomy. Typically on cone beam CT scans, we are able to visualize a lot of anatomic information and structures. C represents the condyle of the TMJ. What you see above as the GF is a glenoid fossa. The PGP is the preglenoid plane. The AC is the articular crest. These are very important structures of the temporomandibular joint. What is represented by these orange arrowheads is the anterior joint space. What is represented by the yellow arrowheads is the posterior joint space. And what is represented by these blue arrowheads is the superior joint space. These joint spaces should generally be symmetrical anterior, posterior, and superiorly. If there is an asymmetric increase in the joint space, particularly in the maximum intercuspation position, it is indicative of some form of either myofascial pain dysfunction, joint inflammation, or even internal derangement. The PT here is the petrous temporal and the EAM is the external artery meatus. So this is the broad anatomy of the temporomandibular joints on the cone beam CT scans. When we want to visualize the TM joints using cone beam CT, this is what we do. Typically, to visualize any one joint, we localize that condylar head, align the long axis with the condyle and the ramus, so that we are able to see all these structures clearly. The same structures which I showed you. Once the planes are aligned and we have adequately zoomed into the area of interest, then we are able to see all the findings. Here on the left TM joint, as we scroll from medial to lateral, we can see that there is erosion, flattening of the condylar head, and there is subarticular sclerosis. There is an asymmetric increase in the joint space, posteriorly and superiorly. So this patient is, this scan is indicative of degenerative joint disease, and depending on the clinical symptoms and the severity of those symptoms, if a further workup with an MRI is done, one could probably see that there is internal derangement of the TMJ disc also. So disc derangement or diagnosis of disc derangement is beyond the scope of the cone beam scans. We can create a baseline evaluation of the status of the bony structures of the temporomandibular joints with the help of cone beam CTs, significantly better and without any guesswork compared to any X-rays. So with that, I think there is given the time that we have, I thought this is the short description of what we could do with cone beam applications. All of these people are my wonderful team members, radiologists and technologists who work across offices and help us create the kind of imaging magic that we do in our offices. I would also like to conclude by saying that we know there are a lot of young dentists and dental practitioners out there who are interested to learn more about this, learn more in detail. You're welcome to do that with this description that is provided on this slide. You can visit our training page and find various individual courses or even course bundles on cone beam imaging, depending upon whatever you are interested with. These are completely online, accessible to you from the comfort of your homes or wherever you want at any time. And there is a discount code mentioned in the slide below exclusively for the participants of this event. So please go ahead and find a course that helps you. Thank you so much to the organizers for giving me this opportunity, and I'm happy to take any questions if there are. Thank you.
Anybody want to ask any question? They can unmute and ask question. Or they can either type on a chat box. There is a one question from Dr. Zarish Akhtar. She asked that how you calculate the joint spacing of TMJ on CBCT scan.
Can you repeat that, please? Sorry.
The question was how you calculate the joint space of TMJ on CBCT scan.
So the joint space for TMJ scan, temporomandibular joints, can be calculated with the help of, like I said, the oblique sagittal sections. And the important thing when calculating the joint space with cone beam CT scans is that you have to take standard reference points from the medial end of the joint to the lateral end of the joint. You have to create oblique sagittal images of, like I showed you, the aligning the joint. You have to properly align the long axis of the condyle from the medial to the lateral pole, create oblique sagittal images that show you that picture, and then go ahead and measure from one end to the other. Take generally multiple readings. So like if these are the images for the condylar head, the oblique sagittal images. I'm showing you the orange, yellow, and the blue arrows. These kind of measurements need to be taken in the medial third, in the central third, and in the lateral third of the joint. So typically one would say that you take 2 to 3 readings in the lateral third, 2 to 3 in the central third, and then 2 to 3 in the medial third, and take a mean of those readings to calculate the value of the joint spaces. That is the scientifically acceptable approach to calculate the joint space.
Any further questions? Dr. Akhtar, thank you, Dr. Sharad. Thank you.
I think there is one more question.
Yes.
From Dr. Hafida, which is
yes. You have explained the
this
clinical application.
pathology most often changes the surgeon's original treatment plan. I'd like to ask that in your experience with CBCT finding in a jaw pathology most often. So I would say that the findings that would change a surgeon's original treatment plan are, if we talk about an impacted tooth with a cystic lesion or a rarefying lesion around it, a third molar or a canine, then the proximity to the vital structures like the inferior alveolar canal, that can change the surgeon's approach from a go all in and take everything out to a more conservative approach. That is one. The other kind of finding in CBCT that could change a surgeon's approach is that very often very innocent looking lesions or just plain radiolucent lesions, non-expansile lesions seen on a cone beam scan can actually be masquerading a dysplastic or a malignant lesion, in which case, based on the CBCT finding, the best thing that we can do is to ask for further imaging, contrast CT or contrast MR. And then obviously the purview of management changes from just a simple enucleation or conservative curettage or anything to a more defined approach in terms of surgery, chemo, radiation, if it is a dysplastic process. So those would be the two most prominent ones that I can think of. Thank you. Thank you. So thank you very much. And I'm happy to if there are any more questions, feel free to send me an email. I'll be happy to take those. And thank you, Dr. Nurul, for this opportunity to be a part of this wonderful event. You're muted. I think you're muted.
Sorry. But I'm saying that thanks for giving, enriching and enlightening presentation on in and out of whole CBCT and all, and how it take important in navigating smarter and diagnosing better. So with this note, Dr. Thank you, Dr. Juhi is thanking you, Dr. Sharad.
Thank you.
So with this thanking note, we have one more speaker who's supposed to join, Dr. Sagar Jagdish Abhichandani, but I think he's not available. He's not reachable now. So we're supposed to, conclude the whole session and all. So let me give a vote of thanks to all the faculty, the speakers, the attendees, the organizers, the digital media team, and all. So let me thank all the speakers from day one. In day one, Dr. Uruji Desai, Dr. Ramia, and Dr. Ratin Das has joined. And on day two, we have paper presentation of say 15, 16 faculties. And then we have two speakers, Dr. Hemal Shah and Dr. Punita Vora. They have spoken on multiple topics and all. And today we have a long, presentation of, we started by 12 o'clock and it is now, I think, 6. So the whole 6 hour we have, spoken in depth all the aspects of digital dentistry. We have, touched all the, specialty of digital dentistry. We have prosthodontist, periodontist, implantologist. We have oral pathologists who have spoken. We have oral radiologists. So all the speakers from various different specialty who have spoken. For today, special thanks to Dr. Shaban Khan. He has spoken on dental photography and simplified. He has spoken on photography in dentistry. Then we have Dr. Rohit Agarwal, who joined and who just spoken on digitization of immediate loading. Then Dr. Harshvardhan Arya talked more about central incisors, that how to restore central incisors. Then Dr. Rabia joined from Mumbai, Wokat Hospital, and she has thrown light on artificial intelligence in digital dentistry from clinical practice to intelligent workflows. Then we have 5, 6 paper presentation today. Then Dr. Navneet Kumar joined and spoken about digitalization on all on X. And then our speaker, Dr. Anisha Parmar, she has spoken on biomimetic paradigm reshaping modern dentistry. And then before Dr. Sharad, Dr. Abhay was speaking on digital protocols for anterior immediate implant restoration, where he shown that how we supposed to plan digital planning and all. And in the end, in the last but not the least, Dr. Sharad, he is still with us. He has given all the detail about CBCT, made simple, navigate smarter, diagnose better. Because we have very, innovation in technology and all. So we have further, we can explore further and we have a proper diagnosis. When we are having IOPA only and OPG, there are, chances of misdiagnosis, but now when we have cone beam and all, so it's a better visibility, 3D visibility we have, and it's better that we can planning a better treatment plan. With this note, I thank all my speakers. I am thankful to my digital media team. I'm also thankful to my, the registration team who worked day and night for registration and making this event a successful. With this note, this is our second International Digital Dentistry Congress. And we'll again join coming up with international diagnostics in oral, health actually. So we are one upcoming event which is coming on 23rd, 24th, and 25th of October. So in the dentistry domain. So we'll let you know through our emails and all. So far as the certificates are concerned, we have two festivals are coming. One is Eid Miladun Nabi, and another is Raksha Bandhan. Raksha Bandhan is on 28th of August. So we would be, uploading our the certificates of every participants post Raksha Bandhan, maybe 29th or 30th of August or the first week of September on the portal. or either we can send you on a WhatsApp. We have all the database, email IDs, and mobile phone and WhatsApp numbers. So either we can upload on on the portal, or we can send you through email or a WhatsApp. So you logged in, and we'll inform you regarding that. So with this whole note, we are concluding for the day. And thanks all speakers, all organizers, all who is joining across different part of the world and all, and making this International Digital Dentistry Congress a successful. We are signing off the day. Anybody want to give any suggestion? They can unmute and they can give suggestion to make it further better and all. Or anybody want to say something or contribute something before we signing off for the day? Any participant want to unmute, give their feedback, suggestions, anything? Okay. So with all due respect for all faculties and all attendees, we are signing off for the day. Thanks all, and have a